superficial fascia. Then after superficial fascia, sir, deep fascia, and then muscles, and then bone. Okay, so you will be able to understand these different layers. These are important. So Hollywood, Bollywood, Tollywood, all are eyes on the anatomy. The song dedicated for this event, yes, all are my student, all the talent person, they are my student. They did the CBI anatomy and now they are spreading their yes talent. So the song dedicated to this anatomy part, yes. Yeah, do you know? कलियों का चमन जब बनता है, थोड़ा शीशा होता है, थोड़े घुंघरू होते हैं, थोड़े मोती होते हैं, समथिंग लाइक दैट. बट एक्चुअल वर्जन, एनाटॉमी में बदन तब बनता है, पहले स्किन होती है, फिर फेशिया होती है, फिर मसल होते हैं, फिर बोन होता है. Yes, don't forget the background music also. So these are the different structure, different way to remember. Now you can never forget. Now see, this is the space in between the muscle. So this is known as the intermuscular space. So what are the boundaries of any intermuscular space? All the entire intermuscular space of the body in single magic. Yes, what are the boundaries? Roof, floor, entry wall, posterior wall, medial wall, lateral wall. Yes, in the similar way, what are the boundaries? Roof formed by skin, superficial fascia, deep fascia. Sir, floor is formed by muscles and the bone. Sir, boundaries are formed by muscles and the non-contact part of the muscle, that is tendon. Okay. Now what are the content? एनाटॉमी में डाइसेक्शन होता है, पहले वेन होती है, फिर आर्टरी होती है, फिर नर्व होता है और लिम्फ होता है. हाँ, are you getting? So any space like the axilla, what are the content? Axillary vein, axillary artery, axillary nerve, axillary lymph node. What are the content of the femoral triangle? You can say femoral vein, femoral artery, femoral nerve, femoral lymph node. What are the content of the popliteal fossa? Yes, answer is the popliteal vein, popliteal artery, popliteal nerve, and the popliteal lymph node. These are the structures. So now you will never do any mistake. Agree? So this was the first magic. Now see the second magic. Second magic, you can see, sir, this is the country, great country, holy country. Yes, the India. So north state is supplied by the Ganga, south state is supplied by the, yes, you can say the Krishna, Kaveri, Godavari. Right now I came from the class from the Georgia. So Kura is at the Georgia. So Georgia is supplied by the Kura river and it gets supplied by the Ganga river. Ganga will never supply to the Georgia. Yes, Kura will never supply to the India. Simple. In the similar way, I told you the second magic that the nerve of the particular compartment will supply all the muscle of that compartment, skin over that compartment, and joint of that compartment. Yes, sir. Simple. So the nerve of the entry compartment, yes, the three-dimensional anatomy, we did the beautiful integration. Again, lal fool, neela fool, anatomy, beautiful. Just look here, sir. The Hilton law, the second CBI magic. Can you see the R in the entry compartment? Which nerve? Comment here. Yes, reply, sir. Submusculocutaneous nerve. So all the muscles in the entry compartment, B, B for biceps, B for brachialis, C for coracobrachialis, all are supplied by musculocutaneous nerve. Definitely one question from this area, sir. The posterior compartment, sir. Here's the triceps. Which is the nerve? Comment here. Yes, please be fast. Radial nerve. So all muscles here, they are supplied with the radial nerve. Now in the forearm, anteriorly, the nerve which is flowing, that is the median nerve. So every muscle in the entry compartment supplied with the median nerve, except towards the ulna, this flexor carpi ulnaris. So flexor carpi ulnaris is supplied with the ulnar nerve. Okay, sir. Now on the back side of the forearm, sir, there is a which nerve? Sir, there is a posterior interosseous nerve. So all muscles are supplied by posterior interosseous nerve. Getting the point? So these are the different facts which you have to remember. And after that, also we had seen the muscles of the lower limb. So can you see in the lower limb, the thigh entry part? Yes, here is the femoral nerve. So all the muscles are supplied with the femoral nerve. Yes, on the mid side, obturator nerve. So comment and be fast. Yes, here is the obturator nerve. And on the back side, there's a sciatic nerve. So all the muscles on the back side, they are supplied with the sciatic nerve. Yes, now in the leg, you will see, sir, there is an entry compartment, deep peroneal nerve. So every muscle in the entry compartment is supplied by deep peroneal nerve. Yes, on the lateral side, there is the which nerve? Sir, there is a superficial peroneal nerve. So every muscle on the lateral side, they will be supplied by the superficial peroneal nerve. And then on the back side, there is a tibial nerve. So every muscle is supplied by the tibial nerve. Okay, this all the things we will revise, but this was our basic concept. This was our first thing. Agree, everybody? We revised everything in the 35-40 hours, then we revise in the 10 hours, and the same content with the high speed we are going to complete the everything. Why? Because Bruce Lee told, I don't fear from the person who practiced the 10,000 times of the kick, but I fear from the person who practiced the one kick for the 10,000 times. We are doing the same thing. not cutting them any content, and we are revising. If you all are liking this thing, yes, the students who studied with me, make me the heart, give me the heart. Who studied previously, you will find this is going to be the very, very beneficial session for all of you. And don't forget, tomorrow we are going to do all the 19 subjects Maha Marathon session at my YouTube channel. Don't forget to join there. Okay, fine. It is very beneficial session. Every time NEET PG I-9 if FMG we do this one. So don't forget to join that session at the 10 a.m. also. Okay. Now look, we did this one. The Escavian rule we did. Yes, second Escavian second magic also we did. Okay. Now I'm going to tell you the third magic. Sir, third magic. Sir, there is the one bone, there is another bone. Junction between the two bone is known as a joint. If muscle is crossing the joint from the superior side, it will cause superior movement. If muscle is crossing the joint from the inferior side, it will cause inferior movement. Okay. So what is your rule? If the muscle is crossing the joint laterally, lateral movement, medially, medial movement. If anteriorly, anterior movement. If muscle is posteriorly, posterior movement. Is it okay? Means where muscle goes, there movement flows. Jidhar muscle, udhar movement. Jidhar muscle, udhar movement. Jidhar muscle, udhar movement. Are you getting? Don't forget. So from these three magics, definitely one question is going to ask. Is it okay? Yes, yes. Fine. Okay, sir. So now I told you this zero magic, second thing, then first CBI rule, yes, sir. Then second CBI rule we complete, yes, sir. Then third CBI rule. So now we are going to enter in the general anatomy and the terminology part. Okay. So look here, one question from the bone parts, or indirectly on the basis of the parts of the bone. Yes, the bone tumor will be asked. Yes, bone. Yes, thank you, Dipanshu for 6 crore rupees. Yes, कोई थैंक यू नहीं बोलेगा. आई विल सेंड यू माई गूगल पे नंबर, उसमें 10 रुपए भेज देना, मैं तुम्हारे नाम का गोलगप्पा खा लूंगा. ओके, इन एनाटॉमी नो थैंक यू, नो सॉरी, ओनली गोलगप्पा पार्टी. ओके, yes. So what are the four parts of the young bone? Sir, epiphysis, sir, diaphysis. The epiphyseal end of the diaphysis is known as metaphysis. In between the, yes, diaphysis and the epiphysis, there is a growth plate of the cartilage. Is it okay? Nutrient artery is entering, it is going up and down, and it is making the hairpin band. Do you remember? Due to this hairpin band, yes, the bacteria is coming and it is getting trapped here and it is causing infection. MCQ. Yes, what you have to remember? MCQ. Not ortho microbiology integration. Most common site of the bone infection or osteomyelitis, metaphysis. Why? Because here is the hairpin band. Most common site, most common cause, Staphylococcus aureus. And most common age group, this metaphysis found in the children. Yes, when there is the effect of the growth hormone, this growth plate is getting ossified, so it is getting fused. So epiphysis, they are getting fused, and only diaphysis. Epiphysis and diaphysis, they are getting fused. So only two parts of the young bone, or two parts in the adult bone. Yes, now see, in the clinical, you will see the growth hormone is acting at this growth plate of the cartilage, and there's an elongation of the height of the bone. So there is the increase in the length of the bone. In adult, this condition will be known as the acromegaly. A for acromegaly, A for adult. But in children, this is known as gigantism. But if it is decreased, then you will see the dwarfism condition. Is it okay? Fine. Now, on the basis of this epiphysis, diaphysis, metaphysis, you will see the bone tumor. Bone tumor is very important. One topic sure from this part. More than 100 plus topics are going to ask from this anatomy session in your main exam. So get ready. Yes, remember, dear friends, रास्ता भी जानते हो, चलना भी जानते हो, तुम आग हो तबीयत से, जलना भी जानते हो. खुद को मोम न समझो जो झट से पिघल जाओगे. तुम सूरज हो, डूबकर निकलना भी जानते हो. So the time of the exam is close. Many students, they will get panic, they will get, yes, oh my god, what will happen? No, be cool, calm, relax. We revise the things many times, we did the MCQ practice, and last, at this moment, don't get panic. Okay, you have to apply the hit and run theory. Be cool, calm, relax, focus over the question. Four options are there. One option will cry and say, I'm not answer, don't mark me. Another option will say, oh my god, oh my brother, I'm not the answer, don't mark me. Now confusion will be in between the two. So what you have to do, you have to mark one thing, whatever you are feeling best, whatever you are having the feeling from the brain, feeling from the gut, mark it and move. Don't waste the time, concentrate on each question. Okay, fine. Okay, sir. So now again, look here further. Sir, types of the epiphysis. So only this thing, PTAA patta. P for pressure epiphysis, T for traction epiphysis, A for aberrant epiphysis, and for atavistic epiphysis. What are the classical example of this pressure epiphysis? ends of the long bone. What are the classical examples of the traction epiphysis? Sir, trochanter, greater trochanter and lesser trochanter. So ends of the long bone, they are the pressure epiphysis. Greater trochanter, lesser trochanter, they are the, yes, traction epiphysis. And then you will see the aberrant epiphysis, which is generally absent, like first head of the first metacarpal. And coracoid process is the atavistic. So atavistic, you can remember the coracoid process. One time they asked the pressure epiphysis in the, I think, 2025 exam. That's why we had seen. Okay, yes, tubercle, T for tubercle, T for traction, they are also the traction epiphysis. Okay, fine. Now come to the next joint. One question sure from the joint topic, so don't forget this one, joint topic. Yes, this is a summary of the joint topic. Joint junction between two bone. One question sure from here, your non-veg mnemonic is the FCS, फक्स, जो लाइफ तुम्हारे साथ करती है, फक्स. दिस इज द निमोनिक. F for fibrous joint, C for cartilaginous joint, S for synovial joint. Okay, sir, fibrous joint, there is a fibrous connective tissue. Sir, cartilaginous joint, there is a cartilaginous tissue. Synovial joint, there is synovial fluid. So no movement at the fibrous joint. This is known as a syn orthosis. Break the name and think about it. Syn means fusion, ortho means chipakna. Yes, again I want to warn to all of you, use the headphone or go away from the your family. Okay, क्योंकि इस क्लास में कभी भी कुछ भी धमाका हो सकता है. ओके, बाद में मुझे ब्लेम मत करना, मैंने पहले ही चेतावनी दे दी है. यस, रिमेंबर डियर स्टूडेंट, मेरी एनाटॉमी को सीरियसली लेना, बाकी चीजों को सीरियसली नहीं लेना. ओके, फाइन. लेकिन होता उल्टा है कि लोग जो है मेरी बाकी चीजों सीरियसली लेते हैं, एनाटॉमी सीरियसली नहीं लेते. ओके, ऐसा नहीं करना है. ओके, सो माफ करना, कभी कभी मैं इधर उधर निकल जाता हूं, लेकिन एनाटॉमी सीरियसली लेना, टू मेक इंटरेस्टिंग द टॉपिक्स, टू अवेक टू ऑल ऑफ यू. ओके, फॉर योर मोर कॉन्सेंट्रेशन. तुम्हारा दिमाग कभी कभी इधर उधर चला जाएगा, तो उसको वापस लाने के लिए मैं कुछ भी बोलूंगा, कुछ भी करूंगा, ताकि तुम एनाटॉमी में रहो. Don't forget many useful things you are going to get. Okay, so now what are the different types of the fibrous joint? So remember, yes, सा सू जी, अर्ज किया है. स्टूडेंट की भी क्या लाइफ है, ना हस्बैंड है ना वाइफ है. यस, शादी के बाद तुमको ससुर जी और सासू जी का इंपॉर्टेंस पता चलेगा. सो फनी निमोनिक सासू जी, एस फॉर सूचर, एस फॉर सिंबोसिस, जी फॉर कॉम्फोसिस. नाउ कार्टिलेजिनस जॉइंट, सर, this is also known as amphiorthosis, two types, primary and secondary. Now the diarthrosis, also you can say synovial joint. So this is the your funny mnemonic. Do you remember the funny mnemonic? Yes, प्रियंका चोपड़ा आंटी से बहुत प्यार हुआ. Okay, so P for plain synovial, C for condylar, S for saddle, E for ellipsoid, B for ball and socket, P for pivot, and H for hinge. One question sure from the joint directly or indirectly. Okay, so first we are looking the sutures. So do you remember plain suture? Yes, plain suture, squamous suture. This is the serrated suture. Teeth like this is the dented suture, and this is the triangular wedge shaped. Yes, wedged groove suture, scintillasis. How you can remember? Do you remember? Yes, do the hand in this way, and we did this one. Plain suture, squamous suture, serrated suture, dented suture, which is the strongest suture, then wedge and groove suture. So you are going from here or there, any part in India or abroad. If any person is coming from the front, so you have to know he or she is CBI agent, yes or no. Then what you have to do? Look into the eyes of him or her and do this one. Yes. If he or she is smiling, means yes, he or she is CBI agent. But suppose he or she is running behind you to kill you, then immediately run away from there. Otherwise, Eji Mangal Bhavana Amangal Hari. Are you getting? Can you recall how we remember this all the things? And now I'm going to show you this all the things with the beautiful three-dimensional way. Yes, look here. Lal full, Neela full, anatomy beautiful. Yes, so look here, this particular part. What are the different types of suture? So intranasal, plain suture, sir. Interpalatine, plain suture. Okay. Now also the squamous suture. Can you see the inter? Yes, parieto-temporal, temporoparatal suture. This is a squamous suture, and you can easily see, sir. This is the zigzag, zigzag, zigzag. Anterofontanel. This is the serrated suture. हाथ कंगन को आरसी क्या, पढ़े लिखे को फारसी क्या. Interparietal suture. This is also the serrated. Now where is the dented suture? Look here on the back side, sir. Fontanel of this skull. This is the lambdoid. This is a posterior fontanel. This is clear cut, dented. This is the strongest suture. This is the first suture which is getting close. First fontanel which is getting close. Agree everybody? Now look on the behind, sir. This is a single bone vomer. ENT question. This purple color bone is the vomer which is making the wedge, and this blue color bone, this is the sphenoid bone. It is making the Yes, groove. This is making the groove and this is making the wedge. Sphenoid is making the wedge and the vomer is making the groove. So this is the, yes, wedge and groove suture. Hope you all got the point. This will be important in the pediatrics of gynae for the fontanelle of the skull. Okay, so we did this all the things, and then Sasuji. So this is the su. Okay, synodesmosis. So there is a radius, there is a ulna. So both are interconnected together with the help of the ligament. This is the middle radioulnar joint, which is the synodesmosis, FMG 2022 question. But the superior radioulnar joint and inferior radioulnar joint, there is a rotatory movement. Rotatory movement means supination pronation. Again, FMG 2022 question. Yes, I told you at that time, in front of the interosseous membrane, the nerve is the anterior interosseous nerve, which is nothing, which is a deep branch of the median nerve, MCQ. Yes, behind this interosseous membrane, another nerve is there, which is the posterior interosseous nerve, is the deep branch of the radial nerve, MCQ. Getting the point? Okay, sir. Now, gomphosis is found in the gum. Between the teeth and the gum, there is a gomphosis. Okay, sir. Now, look here. Cartilaginous joint. Sir, primary cartilaginous and secondary cartilaginous joint. I told you, primary cartilaginous joint, it is getting ossified. So, no movement. Yes, it is also synchondrosis between the epiphyseal and diaphyseal. Very important question. 2024, FMG 2024 question. Remember, between the epiphyseal and diaphyseal, which joint is found? Answer is the synchondrosis. But if between the two cartilage, there is the fibrous connective tissue, so this is secondary cartilaginous joint. Yes, partial movement is present. So remember the formula MIS. M for manubriosternum, I for intervertebral disc, and S for symphysis pubis joint. Okay, so these are the secondary cartilaginous joint. Very, very important. Now look here, the different synovial joint. So we had seen the synovial joint. Look here, sir. Best joint, ball and socket. Multi-axial joint, like the formula is SHIT, SHIT. Shoulder joint, hip joint, incudo-stapedial joint, and talocalcaneal navicular joint. Very important. Okay. In pharma, we learn the SHIP. Yes, sulfonamide, hydralazine, isoniazide, and procainamide. Drug-induced lupus. Also, you can say the drugs which are getting metabolism with the acetylation mechanism. Again, if this question is asked, I will tell you that topics was integrated with the anatomy class. So don't forget this all the things. So remember this SHIT. Next. Sir, this is the multi-axial joint. So shoulder joint. Can you see the shoulder joint? Yes, there is a flexion, there is an extension, there is an abduction, and there is an adduction. Okay, and then medial rotation, lateral rotation. These all the possibilities are there. So remember, this is what is a multi-axial joint. Now, can you catch the biaxial joint? Sir, the ellipsoid joint, which is having the elliptical surface, ellipsoid joint. So just remember E. Yes, push it E. Then it is W. This is the M. So wrist joint and metacarpophalangeal joint, metatarsophalangeal joint, they are the biaxial joint. Only two axes. Wrist. Can you see flexion? Extension, one axis, adduction, abduction, another axis, two axis. Now come to this, sir, hinge joint, uniaxial movement, only the flexion and extension, door-like movement. So we are opening the door, we are inviting the guest. So remember the formula is IEA, I for interphalangeal joint, E for elbow joint, and A for ankle joint. So these are the classical hinge joint. Okay, now come to the next, sir. If the articulating surface is S-shaped, then it is saddle joint. The classical example, first carpometacarpal means a thumb. This is the question which had been asked. Don't forget this one. Na? This question had been asked. Now there is a I am sad formula. I for incudo, M for malar. These are the saddle joint. I am sad. So incudo-stapedial joint is the ball and socket, while the incudo-malleolar joint is the, yes, you can say saddle joint. Now the plane sinus joint. So costotransverse and costovertebral, these are the plane sinus joint. Then condyle joint. So knee joint and temporomandibular joint, they are the condyle joint. Then pivot joint. Whenever you will see the rotation, there is a pivot joint. So C1, C2. There is a right and left. This is the rotatory activity. This is which joint? This is the pivot joint. And then superior and inferior radioulnar joint. That is also the classical supination, pronation, rotatory movement. Yes, that's why these are the your, yes, remember the pivot joint. Jahan rotation, wahan pivot. Agree everybody? Got the point? Okay, sir. Sir, we had seen the one ionicity question, all are present between the two thoracic vertebrae, except, so remember, in between the two thoracic vertebrae, there is an intervertebral disc, and intervertebral disc is the classical example of the secondary cartilaginous joint. Sir, symphysis joint. Yes, also you can say synchondrosis. Now, can you see the skull fontanelle? Sir, important. Entry fontanelle, posterior fontanelle. Right and left to anterolateral fontanelle, and right and left on the posterolateral fontanelle. So these are the fontanelles of the skull. Is it okay? Got the point? Clear? So when they are getting close, sir, first fontanelle which is getting close, posterior, 3 months. Then at the 6 month, 2 anterolateral. Then posterolateral, 12 month. And the anterior is last. So what is the formula? 3 1 ja 3, 3 2 ja 6, 6 2 ja 12, 12 2 ja 24. Khatam, Tata, bye bye, gaya. Simple. Don't forget. Integration with the obs-gynae, pediatrics, also the age determination in the forensic medicine. Is it okay? Got the point? Okay. So what is the sequence? Put the hand in this way. 3 1 ja 3, 3 2 ja 6, 6 2 ja 12, 12 2 ja 24. Got the point? Again, 3 1 ja 3. First fontanelle which is getting closed, portion fontanelle, lambda, 3 month. Yes, then 2 enterolateral, Tyrion at the 6 month. Then 2 posterolateral, mastoid fontanelle at the 12 month. And last is the entry fontanelle at the time 24 month. Done better? Agree? Right, sir. Now, after this, yes, the bullet train analysis, we are not missing even the MCQs. Okay, so look here, the question had been asked about the pressure epiphysis. So type of the epiphysis is important. Yes, the question has been asked again about the joint. Syncontosis, epiphysis, diaphysis is had been asked. They asked about the, yes, middle radioulnar joint in the 2024. Middle radioulnar joint, it is which type of the example? Syndesmosis. And then they are asking every time, first carpometacarpal joint, they are asking every time. So answer is sudden. Yes, 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 comment, be fast, be fast. And then they ask the fontanelle. So the entry fontanelle 12 to 24 months. Okay, fine, very good, lovely answer, lovely answer. Now they are asking January 2024. There is a S-shaped, the base of the thumb, which joint? Sir, saddle joint. It is involved in the rheumatoid arthritis. Okay, now look here further. Sir, identify the type of the joint. Sir, remember this is the middle radioulnar joint, that is a syndesmosis. They are asking again the joint supination pronation. It occurs at the superior and inferior radioulnar joint, that is the pivot joint. And then they are asking about the pubic symphysis, which is secondary cartilage joint. And then they are asking again the pubic symphysis. Same question with the osteology image, with the radiology image, but the topic is the same, the question is same. So don't forget the PYQs and the PYTs. If you will miss the PYQs and PYTs, yes, you will do the big mistake. 80% of the topics, directly, indirectly, in twisted manner, they will ask from the PYQs and PYTs. That's why tomorrow at 10 a.m. at my YouTube channel, we are going to revise all the 90 subject PYQs, PYTs in one liner form and the buzzword form. So don't forget to join that session. Yes, and then question for the frontal plane. Sir, the frontal plane, frontal and the posterior side. So this is the plane which is dividing the body into the front and back, that is a coronal plane. Okay, so we completed this another session. Now we are going to look for the head and neck area. Are you ready? Yes, yes, yes. So you can attend the class. But also what I want to tell you, yes, at the YouTube that session will be always, so don't miss your classes. Okay, you can join that YouTube session later also, you can see later. Okay, लेकिन हाँ, लाइव में देखने का मजा ही कुछ और है. वहां पर खूब सारे मस्त मस्त कमेंट करेंगे, धारा 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 बुलेट ट्रेन स्पीड से हम सारी चीजों कंप्लीट करेंगे. ओके, फाइन. सो लेट्स स्टार्ट द हेड एंड नेक एरिया. खोकर पाने का मजा ही कुछ और है, रोकर मुस्कुराने का मजा ही कुछ और है. हार तो जिंदगी का हिस्सा है मेरे दोस्त, हार के जीत जाने का मजा ही कुछ और है. ओके, फाइन. Okay, sir. So now come to the next. Sir, we are going to look for the pharyngeal apparatus. Look at this embryo. Yes. Head bulge, pericardic bulge, tail, upper limb bud, lower limb bud. Yes, this is the mouth. So near the mouth, there is the special apparatus, pharyngeal apparatus. Okay. So now compare this all the things with the same. So can you see head bulge, pericardic bulge, tail, upper limb bud, lower limb bud. Yes, and this is the mouth stoma. And can you see here are the very special structure? These are the, yes, pharyngeal apparatus. On the backside at the midline, there is the, yes, segment structure. These are the somites. INICT question, sir, this segment structure, they are making the vertebra and the ribs. Yes, these are segmented. Now again, remember the pharyngeal apparatus will give rise to the structures which are near the pharynx. 2-3 question directly, indirectly from the pharyngeal apparatus topic, integrated with the surgery, medicine, ENT, radio, pedia, many subjects. Okay, yes. Now look here again, head bulge, pericardiac bulge, upper limb bud, lower limb bud, same na. So this is mouth stoma. So near the mouth, can you see these are the special structure, pharyngeal apparatus. So now we are cutting and we are going to observe. Sir, we are going to cut here and we are going to observe from this zone. So when you will cut, you will see the outer layer is the outside layer, ectoderm. Ectoderm is the cleft. And can you see this is the endodermal layer? Endodermal layer is the pouch. And in between them, sir, this is the mesoderm. Mesoderm is the arch. Is it clear? Fine. Done? Okay, sir. Now we are going to look the same thing from the backside. Again, you're looking from the backside. So this is the mesoderm. Mesoderm is growing. from the east side near the pharynx area and making the horizontal thickening, which is known as the pharyngeal arch. Okay, so you can see this is the mesoderm is making the arch, and in between the two mesoderm, ectoderm is going inside. So this ectodermal indipping is known as the cleft. Okay, and then you can see the endoderm is out bulging in between the two mesoderm. So this endodermal out bulging is the pouch. So there is the first, second, third, fourth, and sixth, fifth arch disappear. Can you see the first arch, second arch, third arch, fourth arch, and sixth arch? So how many clefts are there? Sir, 1, 2, 3, 4 cleft. How many pouches are there? 1, 2, 3, 4 pouch. 4 cleft, 4 pouch, and the 5 arches are persisting. Okay, getting the point? Okay, sir. Now try to understand within the each arch, 1, 2, 3, 4. 4 structures are developing. Yes, the nerve, the muscle, the artery, and the cartilage. These are developing within the pharyngeal apparatus. That's why pharyngeal nerve, pharyngeal muscles, pharyngeal cartilage, pharyngeal artery. Is it okay? Done? Okay, sir. So again, remember this combination of the pharyngeal arch, pharyngeal cleft, pharyngeal pouch, as well as the meeting point of this all, that is pharyngeal membrane, is also the pharyngeal apparatus. Remember, sir, this pharyngeal arch, pharyngeal cleft, and pharyngeal pouch, endoderm, ectoderm, mesoderm, and the meeting point of this all, that is the pharyngeal membrane, is equal to pharyngeal apparatus. So remember, all are CBI students. So do you know? और करो मीटिंग करते रहो मीटिंग ऑल हुआ मीटिंग दिस डायलॉग इज आल्सो कमिंग फ्रॉम द एनाटॉमी सर व्हाट इज द pharyngeal membrane द मीटिंग point of the mesoderm ectoderm endoderm is known as the pharyngeal membrane in the pharynx area. So this is the same diagrammatic presentation in linear way. Are you getting? So what you can say, sir, the first arch, second arch, third arch, fourth arch, and sixth arch. Can you see the first cleft, second cleft, third cleft, fourth cleft? Can you see the first pouch, second pouch, third pouch, and fourth pouch? Yes, sir. So now we are going to revise what are the different derivatives of this all the arches. Okay, so look here. First we are going to look the first arch, second arch, third arch, fourth arch, sixth arch. So nerve of the first arch, can you see the mandibular nerve? The nerve of the second arch is the, yes, the facial nerve. The nerve of the third arch is the glossopharyngeal nerve. Now the fourth arch is the vagus nerve, which is giving the branch from the superior side, superior laryngeal nerve, and another nerve is going from the down. So this is the, yes, recurrent laryngeal nerve. So don't forget this one. One question directly indirectly from this area. Sir, first arch nerve, mandibular nerve. Second arch nerve, facial nerve. Third arch nerve, glossopharyngeal nerve. Now fourth and sixth arch, vagus nerve. What you can remember, mandibular nerve is the branch of the trigeminal nerve, fifth nerve. Yes, this is the seventh nerve, this is the ninth nerve, and these are the 10th nerve. So just simply you have to add plus 2. Yes, the fourth and this 10th nerve is the vagus nerve, vagus nerve. Vagus nerve. Getting the point? So you can say the vagus nerve, it is very big nerve, so it is giving the two branches, superior and the recurrent laryngeal nerve. Agree? Okay, sir. Now catch this one further. Sir, we had seen the more many concepts after the nerve. I'm going to tell you the first arch nerve, we had seen the mandibular nerve. So what are the muscular elements? So to remember the muscular element, just put the two finger here. This is the mandibular arch, first arch. So which muscles are there? Sir, temporalis, masseter, medial pterygoid, lateral pterygoid, and four muscle of mastication. You can remember the MAT mat. Okay, here is a mylohyoid which is attached to the mandible. Any muscle which is attached to the mandible, you can remember in this way. Sir, they are derivative of the first arch because it is mandibular arch. Okay, temporalis, the masseter, medial pterygoid, lateral pterygoid, also the mylohyoid, also the anterobelly of digastric, also the inside the ear, tensor tympani and the tensor palatini. So if they are asking what is the nerve supply of this muscle, apply the second CBI magic. These all are derivative of the first arch. Which river is in the first arch? Mandibular nerve. So remember, these all muscles are supplied by which nerve? Mandibular nerve. Don't forget this tensor palatini. What is the nerve supply of the tensor palatini? Answer is the mandibular nerve. Is it okay? Getting the point? Fine. Okay, sir. Why I'm telling you this all the things? Just see these facts. Yes. हाथ कंगन को आरसी क्या, पढ़े लिखे को फारसी क्या. So you can observe FMG question. So see, in the FMG, again I am going to put the crystal clear concept. 27 question in the FMG 2026. Yes, 13 question, approximately 50% from the head neck and the neuroanatomy. Okay, and they are asking the maximum question from the head and neck area. Can you see so many questions from the head and neck area? So many questions from the head and neck area. So many questions from the head and neck area. Okay, yes, neuroanatomy part. Fine. And even, yes, I'm putting this one so that you can easily found in my story. Okay, and look here. Sir, this is the ionicity question, May 2026. 21 question. You can see the head and neck, 3 plus 6, 9. Means approximately 50% again in the INICT from the head, neck, and neuro. Again, I want to tell you, in FMG exam, 50% questions of the anatomy, they are from the head and neck area. And can you see? They are asking the safety muscle of the larynx, posterior arytenoid. They are asking, yes, tensor palatini. That's why I'm showing. Are you getting? They are asking the things in twisted way, but the topic is the same. Are you getting? They are asking the ENT question, but which muscle? Tensor palatini. Tell me it is the which arch derivative? First arch derivative. Now supply. Nerve of the first arch, mandibular nerve. Are you getting? Directly and indirectly, they are asking the same thing. They are asking the Horner syndrome. Yes, anatomy. So they are asking the lumbar puncture, which had been asked in your exam. They are asking for the medullary syndrome, cranial nuclei. Yes, they are asking for the speech, Broca's aphasia, Wernicke's air aphasia. Little depth question they are asking. Na? They are asking for the Brodmann areas of the brain. Yes, they are asking certain syndrome, which is related with the ENT, Michelson-Rosenthal syndrome. Okay, they are asking for the neurogenesis of the CNS. They are asking then upper limb part. Okay, so these are the things. So again, I'm sharing this one in my story so that you can get the recent pattern. What I want to tell you, 50% of the questions they are going to ask from this area. And again, I want to tell you, yes, don't forget to join this one. Later you can see, but it will be the very, very useful session. Every time we do this session, and it is very, very useful session. Okay. Yes. So what I want to tell to all of you, again, I'm going to share this one in my story so that you can easily get. Yes. If any student is new, then you can join here. Fine. Fine. जय भोले की बोल के मेरा चैनल देखो खोल के, मेरे वीडियो को सरकाना ना, बिना कमेंट किए कहीं जाना ना। जय माता की बोलो, मेरा चैनल कर लो फॉलो, तुमको बढ़िया मिलेगी वाइफ, मेरा यूट्यूब करो सब्सक्राइब। ओके, सो नाउ वी आर गोइंग टू लुक फर्दर. Sir, now we are going to talk about the second arch. Sir, second arch is also known as the hyoid arch. Okay. Now the second arch, facial nerve. Now, try to understand first arch, now second arch. So here's second arch in the neck. So in the neck, these muscles are migrating and spreading into the face. So the muscles of the face and the neck, they are included in second arch. The formula is the sun protecting factor, SPF. So stylohyoid, stapedius, possibly of the digastric, platysma, and the facial muscles. These are derivative of the second arch. What is the nerve supply? These are derivative of second arch. Now second arch, facial nerve. जो नर्व जहां रहती है, जहां बहती है, उस एरिया को सप्लाई करती है. So this all muscles supplied with the facial nerve. Simple beta, very very simple. The possibility of digastric. This was asked in the NEET PG 2025. Okay, fine. Next, third arch derivative, only one muscle is stylopharyngeus. Getting the point? Which is the nerve of the third arch? Glossopharyngeal nerve. So can you tell me the pharynx, stylopharyngeus is supplied by which nerve? Glossopharyngeal nerve. Again, second SKVN rule. Now fourth arch. Yes, the nerve of the fourth arch, superior laryngeal nerve. What are the muscles? Sir, all muscles of pharynx, all muscles of palate. Also one more muscle of the larynx. That is the cricothyroid. So these all are supplied by nerve of the fourth arch, that is the superior laryngeal nerve. But I told you one exception. Stylopharyngeus is here, na? So stylopharyngeus is not supplied by superior laryngeal nerve, but it is supplied by the glossopharyngeal nerve. Also the tensor palatini, which is the INICT 2026 question. Sir, it is the derivative of the which arch? It is the derivative of the first arch, so it is supplied by the nerve of the first arch, that is mandibular nerve. Agree? If you know, you know. If you don't know, you don't know. Okay? Same content, nothing we are leaving. Everything we are revising. Okay? Yes. So what I want to tell you, sir, come to the next, sixth arch. So first arch, second arch, third arch, fourth arch, sixth arch. Sixth arch is the larynx. So remember, all the muscles of the larynx, they are derivative of sixth arch. So none of the six are recurrent. So that's why all muscles of the larynx, they are supplied to the recurrent laryngeal, recurrent laryngeal. But cricothyroid, sir, it was a derivative of the fourth arch. So it is supplied to the nerve of the fourth arch. Is it okay? Fine. Okay. So these are the concept. Then we integrated with the ENT also. Do you remember the pharyngeal muscle? Yes. Sir, three extrinsic muscle, three intrinsic muscle. Salpingopharyngeus, palatopharyngeus, stylopharyngeus. These are the three extrinsic muscle. ENT integration. Sir, three intrinsic muscle. Superior constrictor, middle constrictor, inferior constrictor. These are the three muscles. Intrinsic. These all are derivative of the which arch? Sir, fourth arch. So they are supplied the nerve of the fourth arch, which nerve? Vagus nerve. I will tell you this update later. But sir, stylopharyngeus is the derivative of which arch? Third arch. So it is supplied with the nerve of the third arch, glossopharyngeal nerve. Okay? Can you recall? In the similar way, nerve of muscles of the palate. Get ready in the ENT. Five muscles: musculi uvuli, palatopharyngeus, glossus, levator palatini, and tensor palatini. These all are derivative of the which arch? Fourth arch. Nerve of the fourth arch, vagus nerve. That's why these all are supplied with the vagus nerve. Except, sir, tensor palatini is the derivative of the which arch? First arch. So it is supplied with which nerve? Mandibular nerve. बेटा कमेंट नहीं रुकना चाहिए. मेरी जीभ, मेरा नॉलेज, जो भी चीज है वो उतना फास्ट चलेगा जितना तेज कमेंट बॉक्स चलेगा. कमेंट नहीं रुकना चाहिए, कमेंट नहीं रुकना चाहिए. ओके, फाइन. नाउ ट्राई टू अंडरस्टैंड फर्दर. सर, we had seen this concept at that time. We created, sir, there is a esophagus, there is a pharynx. Okay, so upper part of the esophagus, funnel like that, that is a pharynx. So which nerve is the nerve of the GIT? Sir, vagus nerve, vagus nerve. So this vagus nerve is giving one branch to the pharynx on the posterior wall. So this is a pharyngeal branch of the vagus nerve. Sir, this is a pharyngeal branch of the vagus nerve. But now it says, sir, total 5 muscles in the palate and 6 muscles in the pharynx. So I need help. Who will help to this vagus nerve? The friends of the vagus nerve are, yes, 9 and 10. So 9, 10, 11, they all will make the bunch of the nerve on the posterior surface of the pharynx. This bunch of the nerve behind the pharynx is known as pharyngeal plexus. Is it okay? Is it okay? Clear, beta? Yes. So now see, this vagus nerve plus accessory nerve, they are uniting and they are making the vago accessory complex. Yes. Hollywood, Bollywood, Tollywood, not only them, but the celebrity names are also coming from the same. You know, Saif plus Kareena is equal to Saifina. Yes. Virat plus Anushka is equal to Virushka. These nomenclatures are coming from the CBI classes. They are student of the CBI class, CBI jet. I taught them vagus nerve plus accessory nerve is equal to vago accessory complex. Are you getting? Vago accessory complex. Don't forget. Now this vago accessory complex is meeting with the glossopharyngeal nerve. So 9, 10, 11, they are making together the pharyngeal plexus. So all muscle pharynx, they are supplied by pharyngeal plexus. Best answer. All muscle palate, they are supplied by again pharyngeal plexus. If not given, then vago accessory complex, and if not given, then vagus nerve. Is it clear? So we integrated with the ENT. Don't forget. In summary, sir, vagus nerve plus accessory nerve is equal to vago accessory complex. If you are adding the ninth nerve, then these all are known as the pharyngeal plexus together. Is it okay? Clear? Yes. Thank you. Thank you. FMG 200 plus. Tom, बेटा क्रैक करना एग्जाम. मुझे याद आ रहा है ये वही बच्चे हैं जिन्होंने पहले भी क्लास की है, फिर से आके देख रहे हैं. वी हैव टू प्रैक्टिस द सेम थिंग फॉर द 10,000 टाइम. तुम सभी का सिलेक्शन होगा बेटा. हिम्मत नहीं हारना. आखिरी टाइम में नर्वस नहीं होना. जितना किए हो बहुत अच्छा किए हो, अब उसी में ही बेस्ट करना है. ओके. यस यस. कॉकरोच जनता पार्टी इज हियर. रेयो होप इज हियर. सिद्धार्थ इज हियर. बिल्कुल बेटा, मिल करके क्रैक करेंगे. यस डेविड, वी विल क्रैक द एग्जाम. नाउ ट्राई टू अंडरस्टैंड फर्दर everything I taught you right now. Sir, muscle of the larynx. Do you remember all muscle of the larynx? They are supplied by recurrent laryngeal nerve except cricothyroid, which is supplied by the external laryngeal nerve. Yes, sir. Fine. So look here, the I love you joke. Yes. एक लड़का होता है, एक लड़की होती है. लड़का जो है लड़की को कहता है आई लव यू. लड़की बोलती है ये तो मैं जानती हूँ, कोई ऐसी बात बताओ जो मैं नहीं जानती. तब लड़का लड़की को कहता है all muscle of the larynx supplied by the recurrent laryngeal nerve except cricothyroid, which is supplied by the, yes, external laryngeal nerve. Boy rocks, girl shocks. Yes. So do you remember? In the same way, we are going to say the 4 I love you joke. Get ready. Yes. All muscles supplied by except supplied by. All muscles of palate supplied by pharyngeal plexus except tensor palatine supplied by mandibular nerve. Why? Now explanation by the embryology. All muscle of palate derived from the fourth arch. Now the fourth arch, vagus nerve. Better answer, vagus complex. Best answer, pharyngeal plexus. Except tensor palatine. Sir, because tensor palatine is the derivative of the first arch. So it is supplied with the nerve of the first arch, mandibular nerve. Got the point, beta? Yes, FMG 200 plus. Abdul, very good, beta. Yes. मेरे को सारे नाम याद आ रहे हैं ना. अब्दुल भी ज्वाइन क्लास किया था, FMG 200 प्लस भी क्लास किया था. सारे नाम याद आ रहे बेटा? जो जो बच्चे बार बार रिवाइज करेंगे वो सारे बच्चे आएंगे। जो जो बच्चे थे, चलो चलो टाइप करो। डॉक्टर मॉर्फी भी थे, यस सिद्धार्थ भी था, अर्पिता भी थी, डॉक्टर स्टार्क भी है, यस शकीर, टोनी टोनी स्टार्क भी आ गया, कॉकरोच जनता पार्टी मेरे को अच्छे से याद है, कॉकरोच जनता पार्टी भी क्लास अटेंड किया था। बहुत बढ़िया बेटा, लव यू ऑल। बिल्कुल हम मिलकर क्रैक करेंगे, क्रैक करेंगे करेंगे बेटा, घबराना नहीं ना। सर मैंने बहुत कम पढ़ा है, कोई मैटर नहीं करता बेटा, कम पढ़ा है लेकिन आप उसको अप्लाई करो, इसके लिए बिल्कुल घबराना नहीं है। यस सीजी वाला भी है, बैटमैन भी है, बहुत बढ़िया बहुत बढ़िया, मिलके करेंगे बेटा, है ना। चलो आगे बढ़ते हैं। सो नाउ कैन यू ऑब्जर्व हियर फर्दर? सर वी आर गोइंग टू लुक फॉर द pharynx, fourth arch. Yes, supplied by the pharyngeal plexus, except stylopharyngeus. Sir, it is the derivative of the third arch. So it is supplied by the nerve third arch, that is a glossopharyngeal nerve. Okay, fine. Now, larynx. All muscle derived from the sixth arch. Yes. So now the sixth arch, recurrent laryngeal nerve. That's why all muscle lines supplied by the recurrent, except cricothyroid, which is derivative of the fourth arch. So answer is the vagus nerve, but better answer is the superior laryngeal nerve. Best answer is the external laryngeal nerve. Agree? Tongue muscles, they are derivative of the occipital somites. So supplied by the nerve of the occipital somite, that is the 12th nerve, except palatoglossus. So this is the muscle of the fourth arch. So it is supplied by the nerve of the fourth arch, pharyngeal plexus vagus complex, you can say. Right, sir? Now we are going to talk about the pharyngeal arch cartilage. So look here, sir. You can observe the derivative of the first arch. Sir, it is the Meckel's cartilage. You can remember the 5M. So just look which cartilages bones are here on the mandible part. Sir, M for malleus adenosus, M for malleolar ligament, anteromalleolar ligament, M for mandibulo-sphenoidal ligament, M for mandible, and M for maxilla. So M, 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 M. You have to remember 5M and the 5S. Very good, Ritik. Yes. Now look here. The second arch, Richard's cartilage. 5S you have to remember. S for stapes, S for stellate process, S for styloid ligament, S for superior small cornu of the head, and S for superior half of the body. Okay. Now third arch cartilage. So the greater cornu and the inferior half of the body, they are derivative of the third arch. Now below to it, fourth and sixth arch, the laryngeal cartilage. Okay, getting the point? Okay. So now after this all, we are going to look for the pharyngeal cleft. Ectoderm. Cleft means ectoderm. So can you see? So this is first cleft, second cleft, third cleft, fourth cleft. So this first cleft will make the external auditory canal, and remaining all the cleft are getting disappear. At the embryonic time, sir, there is one cavity, that is a sinus in the neck, that's a cervical sinus. But later, the connective tissue is filling this all. So look here on the ectoderm side, outside, there is only one depression. Sir, this is the external auditory canal. Is it okay? Clear? Done? Next. So first cleft is the external auditory canal. Remaining all are getting disappear. But sometimes they are persisting. So they are having one opening along the anterior border of the sternocleidomastoid. Look, the clinical, surgery, pedia, ENT, radio integration. If any embryonic structure is there, which is having the two opening, yes, if it is not getting disappear with the two openings are persisting there, that is a fistula. If one opening is disappearing, another opening is persisting, one opening is there, sinus. And if both openings are getting closed and there is one cavity, so this is the cyst. Is it okay? Fine. So if any patient is coming to you with the mass along the anterior border of the sternocleidomastoid, yes, this is the pharyngeal fistula, pharyngeal sinus, pharyngeal cyst, because it is derived from the pharyngeal apparatus. Sir, it is also known as a cervical fistula, cervical sinus, cervical cyst. Two opening fistula, one opening sinus, no opening cyst. Yes, in the fishes, this pharyngeal apparatus is known as branchial apparatus. Branchial means gills. We are not having the gills. So in the human, the branchial apparatus is the wrong term. But in the fishes, it is the right term. So yes, misnomer is there. You can say the branchial fistula, branchials have branchial cyst. How you will examine in the radiology? Yes, you will use the needle, you will inject the dye. If the dye is reaching up to the oral cavity and patient is saying, Doctor Sahab, the bitter taste is felt in the mouth. Doctor Sahab, मुझे मुंह में कड़वा कड़वा लग रहा है. Why? Because there is one opening, there is another opening. So you are injecting the dye here. The dye is reaching into the mouth. So this is radiology integration. Again, I want to tell you more than 100 plus topics are going to ask from the anatomy session. सेरिबेलम में मिलेंगे, मिल्क डांस करेंगे, पूरा बेटा जो हमने मेहनत की है उसको फुल एंजॉय करेंगे, सेरिबेलम में मिलेंगे और उसके लिए एग्जाम क्रैक करके ही रहेंगे. ओके, यू विल क्रैक द एग्जाम श्योरली. You will dance together, you will make the selfie together, you will make the memory together. Okay, now come to the next, pharyngeal pouch. Yes, गर्दा उड़ा देंगे, फाड़ के रख देंगे, क्रैक करके रख देंगे. Okay, now look here further. Pharyngeal pouch. Sir, this is the first arch, second arch, third arch, fourth arch, sixth arch. Sir, this is the first pouch, this is the second pouch, this is the third pouch, this is the fourth pouch. Yes. So can you see the first pouch is making one tube and tympanic recess. So this is a tympanic recess. Tube will make the auditory tube. The tympanic recess will make the middle ear cavity. Is it okay? Fine. So now try to understand. Sir, this is the external auditory canal. Sir, this is the our tympanic recess. So this is one small amount of the mesoderm is there. Okay. So can you see one very special structure is developing. Okay, which is between the external auditory canal, first left, and this is the first pouch, middle ear cavity. Tell me, what is the name? Sir, this is the endoderm, this is the ectoderm, and mesoderm. So this is the first pharyngeal pouch, which is making the tympanic membrane. Are you getting? In ENT, we are learning tympanic membrane is very rare structural body, which is formed by all the three germ cell layer. But yes, this particular anatomy, the embryology will say why it is having all the three germ cell layer, because it is developing from the pouch, endoderm, cleft, ectoderm, and a small amount of the mesoderm. Is it okay? Agree? Fine. And then there is the second pouch, which is making the palatine tonsil. And then third pouch, it is having the dorsal part and the ventral part. Dorsal part is making the parathyroid 3 and the ventral part is making the thymus. So in case of the Dijor syndrome, this third pouch is affected. So this parathyroid 3 and the thymus is not formed, though that's why the calcium metabolism abnormality and the immunity is decreased. That is a Dijor syndrome. Integration with the microbiology, biology, immunology, medicine. And then fourth pouch is making the dorsal and the ventral part. Yes, the dorsal part is making the parathyroid 4 and the ventral part is making the lateral thyroid element. Simple. So one more thing, sir, during the development, the third pouch is descending down. It is making the infraparathyroid, and the fourth pouch is remaining upside. That is supraparathyroid. Is it okay? Now look here, clinical. Again, ENT, medicine, pediatrics, surgery, and the radiology integration. Sir, the first arch deformity. Sir, there is the Dijor syndrome. Mark my word, question may be asked. And better just see, in entire classes, I will use the so magic that every face they will have the mustache. अब चाहे वो बच्चा हो, चाहे वो बच्ची हो, चाहे वो हीरोइन हो, चाहे वो हीरो हो, चाहे विलन हो, सबके मूछ और दाढ़ी आएंगे. कैन यू सी? चंगेज की खां की तरफ मूछ और दाढ़ी दिख रही है. यस सर. अगेन व्हाट आई वांट टू से, सर टाइजर सिंड्रोम कैच 22, सी फॉर कार्डियक एब्नॉर्मलिटीज, ए फॉर एबनॉर्मल फेस, सर सी फॉर टी फॉर thymic aplasia, C for cleft palate, and H for hypocalcemia. 22 because it is due to the mutation in the 22 number chromosome. Can you see? Thymus is abnormal and hypoparathyroidism because of the involvement of the third pouch. That's why. Okay, now first arch syndrome, Treacher-Collins syndrome. So erase the R. So teachers day are celebrated on the 5th September. Okay, so first arch is abnormal, so patient will present with the abnormal mandible, small mandible. Yes, there is a one more, प्यारा रॉबिन syndrome. यस, प्यारा रॉबिन की बुक जब हम उसको गर्ल्स कॉमन रूम में पढ़ेंगे. G for glossoptosis, C for cleft palate, and R for retrognathia. So if any patient is presenting with the retro, when the jaw is going backside, so this is what? This is retrognathia. Retro means behind. Okay, so don't forget this one, retrognathia. Okay, now look at development of the tongue. Yes, I told you tongue, thyroid, tonsil, they are important topic. One question from the tongue, one question from the thyroid, one question from the tonsil, definitely. And in the your FMG 2026, they ask the question from the tongue and the tonsil. Also in the clinical, they ask from the thyroid. So can you see again, lal फूल, नीला फूल, anatomy beautiful. Look here, हाथ कंगन को आरसी क्या, पढ़े लिखे को फारसी क्या, tongue, thyroid, tonsil. Can you see? They ask the question from the tonsil. Simple question, identify the tonsil. TTT, they ask the question from the tongue. Just observe this one. Yes, tongue, development of tongue. Thyroid, they will ask from the hyperthyroidism, hypothyroidism, thyroid cancer, but they will ask tongue, thyroid, tonsil, directly they are going to ask the question. Okay, now, yes, you can save, you can get this part from the Instagram easily. Now, look, sir, tongue development. Tongue develops from the first arch, second arch, third arch, fourth arch. Sir, the first arch is making the entry to third of the tongue. Second arch is not participating. Third arch is making the posterior one third of the tongue. And fourth arch is making the posterior most part of the tongue. Is it okay? Clear, everybody? Now supply. See, in the first arch, two nerves are there. One is the mandibular nerve, another is the chorda tympani. In the third arch, which is the nerve, glossopharyngeal nerve. In the fourth arch, which nerve? Sir, vagus nerve. सो सिंपल, जो नर्व जहां रहती है, जहां बहती है, उसे एक सप्लाई करती है. टेल मी व्हाट इज द नर्व सप्लाई ऑफ द एंटीरियर टू थर्ड टंग? सर, mandibular nerve. Better to say the branch of the mandibular nerve which is going to the tongue, that is a lingual nerve. So it is a normal nerve, so it will supply it will carry the normal sensation, general sensation, pain, touch, temperature. But sir, there is one special nerve, chorda tympani, which is a branch of the facial nerve, so it will carry the special sensation. Other arches are having the single nerve, na? Third arch, glossopharyngeal, fourth arch, vagus nerve. So posterior one third is supplied with the glossopharyngeal, posterior most part is supplied with the vagus nerve. Simple, simple, simple. Is it clear, everyone? Done? Okay. Now, further more detail. Can you see? They given such kind of the image. So the first arch, it is making the two lateral lingual swelling and one tubercular impart. So this question had been asked in the recent exam. These two lateral lingual swelling, they are making the entry to third of the tongue. Now second arch and third arch, second arch is disappearing. So third arch and fourth arch, they are making copula. Also you can say hypobranchial eminence, which is having the two part. Cranial part is formed by the third arch, caudal part is formed by the fourth arch. This cranial part is making the posterior one third of the tongue. Caudal part is making the posterior most part of the tongue. Complete. So remember this question, two lateral lingual swelling. समझो बेटा, टंग है तो इसमें दो लैटरल लिंगुअल स्वेलिंग होते हैं और एक छोटा सा ट्यूबरकुलर इंपार होता है. मत याद करो इसको, इसको याद कर लो, ये आया हुआ है. सो टू ट्यूबरकुलर इंपार, दे आर मेकिंग द टंग. कंप्लीट. Okay, break the name if you want to remember this now. Hypo means below, branchial means branchial apparatus, eminence means elevation. So this elevation is hypo to the branchial apparatus. Break the name and think about it. मिर्जा गालिब कहते हैं सारे राज नाम में दफन रहते हैं. Is it okay? Clear? Yes. So after this all, few more thing, sir. The most taste bud, we are going to talk about the taste bud. The dorsum of the tongue is filled by the filiform. It is most numerous and it is covered by the keratin. So no taste sensation is here. MCQ. Filiform. Sir, the fungiform, they are at the corner just like the fungus. And the foliate, they are leaf like foliate. They are found in the lower animal, vegetarian animal. And now circumferent. Can you see these taste bud are circular? Okay, and they are having the trench, vallet, that's a circumferent. All taste bud in the entry two third, they are supplied by the chorda tympani. But sir, these are close to the posterior one third. Getting the point? So this is supplied with the glossopharyngeal nerve. So except circumflex papilla, which is supplied with the glossopharyngeal. So remember this point. Yes, posterior one third, glossopharyngeal, posterior most vagus. इतना ही पढ़ना है, बार बार पढ़ना है बेटा. आपका 90% क्वेश्चन यहीं से ही आएगा, जिसमें आप चलो कुछ गलतियां हो गई तो भी आप 70% 60% ऐसे ही पा जाओगे. Whatever you studied, very nicely you studied बेटा. Maybe few subjects are stronger, maybe कुछ few subjects are weaker. Don't worry. अरे 150 तो लाना है. कौन सा 300 में 300 लाना है? रिमेंबर बेटा, 149 इज इक्वल टू 0 एंड 150 इज इक्वल टू 300. अपने को टॉप नहीं करना, अपने को सिर्फ एग्जाम क्रैक करना है. एग्री बेटा? फाइन. बी कूल, काम, रिलैक्स. डोंट ट्राई टू सॉल्व ईच एंड एवरी क्वेश्चन. इज इट गुड? गेटिंग द पॉइंट? यस. जस्ट हमारा एक सपना है पूरा 100% हम. नो वन इज परफेक्ट, नो वन इज परफेक्ट ना. फाइन. So don't try to be perfect. Clear? Fine. Yes, sir. So now come to the next further. Yes, same test bud. The histological images I'm going to show you. Sir, if they are giving an histology image, you are looking the triangular appearance. So this is the filiform. These are covered by the keratin. Nukila dikhega. But can you see if they are having the blunted and they are having the, yes, leaf like branching pattern, then it is the foliate. And if you are looking them like the dome shape, कुकुरमुत्ते की तरह, मशरूम की तरह, then fungiform. And what is important, sir, if this is circular and it is having the vallet, can you see circular and vallet, so this is circumvallet. Is it okay? Clear? Right. So now after this all, we are going to look for the head and neck face system, anatomical system. So look here, first you will see the scalp, then face, and then neck portion. Yes, ये देखो, इसकी भी हमने दाढ़ी मूछ बना दी है। क्या जादू है एनाटॉमी का। Okay, sir. So now look, the first topic is scalp. Just remember there are the 5 layers of the scalp, magic of 5. S for skin, C for connective tissue, A for aponeursis, L for loosener, and P for pericranium. Okay. Only one question they will ask, sir, this fourth layer, loose layer, is known as the dangerous area of the scalp. Why? Whenever you are hitting, this rupture of the veins, and this fourth layer is the loose layer, so blood is getting accumulated here. Sir, here there is a presence of the emissary vein. The emissary veins are joining the extracranial vein and intracranial vein, and these are valveless. So this blood is converted into the pus, and now the pus infection is reaching to the brain, and infection to the brain can lead to the death. Again, sir, loose layer, blood accumulation, then it is converted to the pus, then emissary vein, via emissary vein reaching to the brain, then there is the meningitis, encephalitis. If you are not treating, death chances is there. That's why this fourth layer is known as the dangerous area of the scalp. Now look here, sir, this loose areolar layer is having no bony attachment on the front, so it is going up to the eyelid, and it is causing the blackishness of the eyelid. So MCQs, can you see? Yes, black eye, bhag bhag dike bosh, you know this movie? So in the movies or in the general life, if the person is getting blow on the eyelid, fourth layer is getting ruptured, blood is getting accumulated, so there is a black eye. Yes, you can say the panda eye sign, you can say the raccoon eye sign. These are generally found in case of the intracranial fossa fracture. MCQs, clinical integration. Okay, next, after this scalp we are coming to the face. So let's start the dissection of the face. Skin, then superficial fascia, deep fascia is upside, then muscles. So these muscles are just below the skin and superficial fascia. Remember, all facial muscles are derived from the which arch? Second arch. So now the second arch is the facial nerve. That's why all facial muscles are applied with which nerve? Facial nerve. But sir, levator palpebris superioris, levator palpebris superioris, LPS, 3 words, third cranial nerve. Because it is mainly the muscle of the eyeball, and the eyeball muscles are supplied by what? Yes, oculomotor nerve. That's why the third cranial nerve. Is it okay? So these are the things that we have to remember. Now look, we are observing for this particular part different muscles of the face. So can you see the front muscle is the frontalis? Yes, around the eyeball there is the orbicus oculi. Remember, this frontalis is known as the surprise muscle. Orbicus oculi is known as the winking muscle. Yes, Hollywood, Bollywood, Tollywood, all are rising from the anatomy. Do you remember? Yes, we did the many Hollywood, Bollywood, Tollywood integration during the regular class. So can you recall this Priya Prakash warrior auntie? Sir, rhizolius, frontalis, frontalis, orbicus oculi, zygomaticus major, smiling, no, battisi, yes, grinning muscle, rhizolius. Got the point? So this is a Hollywood, Bollywood, Tollywood. You can see this all the things at my YouTube channel, Dr. Shrikant Verma classes with the 93,000 subscriber. Yes, हमारी जवानी के दिनों की video. Okay, sir. Now look further. Yes, sir. There is a zygomaticus major. Sir, levator palpebris superioris is here. Fine. Now look here. There is a orbicus oris, which is the whistling muscle, but the main whistling muscle is the buccinata. Okay. So the Hollywood, Bollywood, Tollywood. आंख मारे वो लड़की आंख मारे. Orbicus oculi is the winking muscle. सीटी बजाए. Buccinata is the whistling muscle. So this song is arising from the CBI anatomy class. Okay. Now look here further. हाँ, YouTube वापस मिल गया भाइयों दोस्तों. थैंक यू. YouTube मिल गया है. Yes. So now द यूट्यूब विथ योर वेल विशेस, है ना, फिर से वापस आ गया है। यस, कल हमारा वो वाला सेशन है। और ये देखो बेटा, ये आपका ना बज़वर्ड नीट पीजी लास्ट ईयर का सेशन था। बहुत एक्सीलेंट सेशन था। और वैसे ही 12 घंटे में 19 सब्जेक्ट हुए थे हमारे एफएमजी का। ये कहाँ गया? यस, दैट वन। कैन यू सी देयर दैट फर्स्ट वीडियो at the topmost corner, 21,000 views. Okay, so all the 90 subjects there. Right now again we are going to revise the things. Same session we are going to do today now. Okay, so thank you for your well wishes. Now come to the next further. Sir, there is the muscle. When it will contract, it will cause depressor levi inferioris, which is the grief muscle. And this is the mental area, mentalis. This mentalis is the doubt muscle. Remember, Hamza was a spy agent, and the Rahman Dakat uncle was always in doubt. So he was using this doubt muscle. This is the doubt area, mental area. Which muscle? Yes, you can say mentalis. Which nerve? Mental nerve. Getting the point? So he got the Oscar, 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 Oscar. Only Oscar award by the Atish Kapoor. Yes. So remember, he was using this muscle too much. That's why he is the he performed very nicely. So he is also the CBI agent, na? Look. He's using the mental area too much, na? Always he's using this doubt muscle. Okay, fine. So why I'm teaching you? Because look here, how they ask the question. Look here. Can you see Rahman Dakat area? Rahman Dakat nerve, mental nerve. Okay. So they are asking the question. The FMG exam, the NB, they are also the CBI agent. Rahman Dakat area. Fine. Now in the neck, sir, there is the platysma, the terror muscle. Okay. Now this is the facial nerve. To make easy, facial nerve, it is better to remember this particular part, the branches of the facial nerve. Put them and in this way. All facial muscles, they are supported with the facial nerve. Temporal branch, zygomatic branch, buccal nerve, marginal mandibular, and cervical. Temporal, zygomatic, buccal. Is it okay? Fine. So there is the nerve pattern. Again, rhizorius. This is the frontalis. That is the frontalis. Here is the orbicus oculi. Yes, it is the rhizorius. And if these muscles are getting paralysis, there is a Bell's palsy. Okay. Now look, rhizorius is the grinning muscle. Smiling muscle, zygomaticus major. Yes. And which is the anger muscle? Sir, there is a dilatation of the nose and depressor of the tip of the septa. So dilator naris and depressor nasal septi. What you have to do in exam? Suppose such questions are just you have to do this activity. Do this one and say, "Kate kaname matera khan pe jaunga." Something like that. So there is a dilatation of the nose. So you can mark dilator naris. बसंत इनकत कसान मत नाचना. So there is a depression of the nose. Tip of the nose is coming down. Tip of the nose is coming down. That's a depressor. Nose, that's a nasal septi. Depressor, nasal septi. Is it okay? Now, yes, nibba nibbi muscle, levator levi superioris is the sad muscle. And grief muscle, depressor levi inferioris. Okay? Now, surprise muscle. अरे मैं पैदा हो गया. So whenever there is surprise, yes, there is a corrugation on the frontal portion. So this is the frontalis, right, sir? Now look, platysma. Yes, whenever there is a horror or terror, the neck muscle is getting contraction. So this is a platysma. Done? Right. Now come to the next. Artery supply of the face. So face is mainly supplied with the 8 branches of the external carotid artery. So the formula I told you, she always likes friends over papa, sister, and mama. S for superior thyroid artery, A for ascending pharyngeal artery, L for lingual artery, A for facial artery, O for occipital artery, P for posterior auricular, S for superficial temporal, and M for maxillary artery. So Always the different Hollywood, Bollywood, Tollywood heroines, they are undergoing the facial surgery for the plastic surgery because the face is having the rich blood supply. That's why excellent healing is seen. ओके, कैन यू रिकॉल? तो चाहे कोहली की वाइफ हो, चाहे जानवी की मम्मी हो, चाहे बच्चन की बहू हो, चाहे निक की बीवी हो, फाइन, दे ऑल डिड द सर्जरी फॉर द नोज और द लिप। और द पॉइंट? यस। और इस आंटी ने तो पूरी बॉडी की सर्जरी करवा ली, जानवी आंटी। सो रिमेंबर द बिगेस्ट मोटिवेशन फॉर द लाइफ, you are not ugly, you are just poor. So crack the FMG exam, earn the money, and yes, be beautiful and handsome. Fine. So remember this one. Now, in the different way, we did the diagrammatic presentation for this all. So can you see, sir, हमने पहले डायग्राम को ऐसे करके बनाया था, लेकिन फिर कुछ लोगों को इसमें जॉनी भैया दिख गए तो हमने इस फोटो को चेंज कर दिया, उसका हेयर स्टाइल बना दिया। कैन यू रिकॉल? सर, let's start the artery supply. There is a common carotid artery which is dividing into the internal and the external carotid artery. Okay, so what you can say, sir, this external carotid artery is giving the 8 branches. First question, sir, only medial branch, first branch of the external carotid artery and the smallest branch of the external carotid artery, answer is the ascending pharyngeal artery, APA artery. Next, sir, there are the 3 entry branches. Entry branches, superior thyroid artery, another is going to the tongue, so this is a lingual artery, another is going to the face, so this is the facial artery. So these are the 3 entry branches. Remember, this facial artery is palpable, so it is also known as the anesthetist artery because anesthesia doctor, they are palpating this artery. Next, sir, there is a posterior artery and another artery is running towards the occipital area. So this is the posterior artery and this is the occipital and this is the posterior artery. So this is the pa artery, papa. So here is the apa and here is the papa. And then 2 terminal branches. Can you see, this is superficial temporal and this is the, yes, transverse facial artery. So integrate with your clinical. This superficial temporal artery is involved in the temporal arteritis or giant cell arteritis. The drug of the choice for this condition is the steroid. So the patient will present with the pain over this area. Yes, he will have the jig tortuous artery at this area. And over the maxillary artery, remember it will give one very important artery, is sphenopalatine artery, which is the artery of the epistaxis. Maxillary artery, yes, it gives a total 16 branches. But one artery I'm telling you, the sphenopalatine artery, which is the artery of the epistaxis, is very important. That's why. Is it okay? Now, come to the next. So in this way, we revise all the things. Extracarotid artery, 8 branches, 1 medial branch, ascending pharyngeal artery, 3 entry branches, superior thoracic artery, superior thyroid artery, lingual artery, facial artery. 2 posterior branches, PA, posterior auricular and occipital artery, 2 terminal branches, superficial temporal artery and the maxillary artery. Got the point? Okay. Now we had seen the dangerous area of the face. One line only you have to remember, the lower part of the nose and upper lip. It carries the infection to the cavernous sinus. In the cavernous sinus, so many cranial nerves and intercarotid artery, which is the main artery of the brain, these all are involved. That's why there is a chance of the death. So remember this lower part, this is the dangerous area of the face. And this is having one another name, that is maxillofacial death pyramid. Both are same, involving the same area. Okay, so don't forget this portion. Next, the nerve of the face. Sir, there are the 2 types of the nerve, sensory nerve and the motor nerve. I told you the motor nerve, the facial nerve. If there is damage, there is a facial paralysis, Bell's palsy, you can say. Yes, but the sensory nerve, trigeminal nerve. So can you see ophthalmic division, maxillary division, and this is the area over the mandible. So the formula was the su lai jija MBA. जीजा जी सुसु करके लाई बोल दिए तो उनको MBA की डिग्री मिल गई। Can you recall this funny formula? Okay, so again try to recall the nerve supply. Su, supratrochlear, su, supraorbital, L for lacrimal. So this is the infratrochlear and this is the extranasal nerve, su, lai. And then jija, zygomatico, temporal, infraorbital, zygomatico facial. And then MBA, M for mental nerve, Rahman Dakat nerve, Rahman Dakat area, Rahman Dakat muscle, mental nerve. Are you getting? FMG 2026 question. And then buccal nerve, and this is the nerve auricle and temporal area, auriculotemporal nerve. Okay, now the next question, all are supplied with trigeminal nerve except this area. This is the angle of mandible, also you can say shaving area, surgery integration. When you will do the parotid surgery, parotidectomy operation, this great auricular nerve is getting damage. Yes, it is supplied with great auricular nerve. Remember, this is the GAN, GAN. Okay, don't add one more letter behind it. Okay, वो नहीं कहना ये क्या, ये गाना नर्व है ना, वो नहीं सोचना जो तुम्हारे दिमाग में चलता रहता है। यस, सो रिमेंबर दिस great auricular nerve, the Ghana nerve, very very important nerve. It is supplying the angle of the mandible. It is supplying the shaving area. Okay, what you have to remember, root value C2 and C3 both. But if you have to opt one, then remember this C2. Yes, this nerve is involved. It is getting cut in the Fresh syndrome. Now, what is the Fresh syndrome? In ENT and surgery, you had studied, sir, abnormal short circuit between the auriculotemporal nerve and the Ghana nerve is known as the, yes, you can say the Fresh syndrome. Also, you can say auriculotemporal nerve syndrome. So you can see, sir, this is a percutaneotomy operation. So what is happening? The auriculotemporal nerve and the great auricular nerve, they are doing chumma chumma to each other. Clear? Getting the point? So remember, whenever the patient is eating the food, the auriculotemporal nerve is getting stimulated, causing the salivation, but it is joining to the great auricular nerve. Now the great auricular nerve is supplying the blood vessel along with the sympathetic fiber. So blood vessels are getting activated. So dilatation is there. So blood supply is increased. That's why there is a redness. It is also supplying the sweat gland over this area along with the sympathetic fiber. So when we are eating, it is getting activated. So there is sweating. So there is a gustative sweating. Is it clear? So don't forget the GAN nerve. If you will forget, yes, that will create problem in your marks. It is very important. Okay. Now look further, the clinical. Sir, Bell's palsy. So you can see there is a WWW loss, wrinkling loss, white pulmonary fissure, and the whistling loss. Also, no contraction of the muscle. That's why there is a drooling of the saliva. This is all the situation. Fine. Yes, the mouth is deviating towards the normal side. So these are the things. But can you see this is the nucleus? So the facial nerve is having the two part. Yes, supranuclear part, infranuclear part. If there is a damage above the nucleus, then it is the upper motor neuron paralysis, or you can say supranuclear paralysis. And if there is a damage to the nucleus or below the nucleus, then it is a infranuclear lesion. Also, you can say lower motor neuron paralysis. Bell's palsy is lower motor neuron paralysis. This upper side damage is not known as the Bell's palsy. It is just simply known as the supranuclear palsy. Infranuclear palsy is the Bell's palsy. So what is the summary? Sir, lower motor neuron paralysis, all you can say the infranuclear palsy is the Bell's palsy. What will happen? Yes, in ipsilateral paralysis means if there is the right side facial nerve damage, right side paralysis, left side facial nerve damage, left side damage, left side paralysis. But if upper motor neuron paralysis, or you can say supranuclear palsy, then contralateral and lower half of the face means right side damage, left lower half of the face, left side is damaged, right lower half of the face is getting damaged. Facial nerve and the trigeminal, they are very important for all of you. So don't forget it. Okay. Now look here, the same thing. No? I told you the cranial nerve nuclei. If above the lesion, then upper motor neuron paralysis. If below the lesion, lower motor neuron paralysis. The same thing. No? Next, clinical for the trigeminal nerve. So trigeminal neuralgia, severe burning pain along the trigeminal nerve, that is a trigeminal neuralgia. So pharma integration, medicine integration, the drug of the choice for the trigeminal nerve, carbamazepine. Second drug of the choice, valproate. Nowadays, clinically, the gabapentin, pregabalin, they are used. But if not treated, then you will do the neurosurgery. So again, do the integration. Lala fool, Nilla fool, anatomy beautiful. Ye dialogue, Dr. Shrikant Verma ka. Yes. Look here, the beautiful three-dimensional orientation. Can you see? Sir, here we are going to do the surgery. Sir, trigeminal nerve is causing the too much pain in Sermon boy. So what we are doing? We are searching, we are looking the trigeminal ganglion. Sir, it is dividing into three parts. Now, sir, one is the ophthalmic, another is the maxillary, and one more is the mandibular division. So we have to destroy it. So what you will do? This is the H-shaped area, pterion. Very, very important. The thinnest part is the Sylvian point. You will drill here, burr opening. Yes, craniotomy operation. And now you will reach up to this part. You will inject the 90% alcohol. Yes, 90% alcohol is very, very irritative. Na rahega baans, na bajegi bansuri. It will totally destroy the trigeminal nerve ganglion. Is it okay? Fine. So this is the surgery for the trigeminal neuralgia. But nowadays, the better surgery is there. Hollywood, Bollywood, Tollywood, all are arising from the anatomy. Yes, I taught this topic to the Thanos, to the Hulk, to the Marvel team, and they created the Avenger Endgame. The gamma rays, they are very, very destructive in nature. You know, whenever we are making the snap, yes, half of the universe is getting destroyed. So actually, I taught them gamma rays are very destructive. So you have to use the MRI machine. You have to locate the brain tumor or the trigeminal ganglion. Just concentrate the rays, push the button. The gamma rays, they will concentrate and they will destroy. No drop of the single, no loss of the single drop of the blood. No need to do the craniotomy. This is known as a gamma knife surgery. Gamma knife surgery. Is it okay? Clear? So remember, like, ENT, you will see the best surgery for the acoustic neuroma. बट अगर आया ना तो मैं बोलूंगा हमारे एनाटॉमी के सेशन के साथ इंटीग्रेट हुआ था ना. Brain tumor, one of the very, very good surgery, the gamma knife surgery. Is it okay? Fine. Now look here further. Skin, micro, medicine, anatomy, integration. One question sure from the herpes simplex virus, one question sure from the human papilloma virus. Why? Because it will cause the cervical cancer, one of the most common cancer in female, in India, in world. But now the most common cancer in the female, in India, in the world, breast cancer. Human papilloma virus 16 and 18. Don't forget now. Also, the 6 and 8, the anal ward. Herpes simplex virus. So remember, painful vesicular eruption along the dermatome. Close your eye and say herpes. So can you see this patient? Supratrochlear, supraorbital, lacrimal, infratrochlear, extranasal. Can you see this all the point? Yes. So these are the things which you have to remember. Clear? Agree? Clear everybody? Fine. So now the neck area, we come to the scalp, we come to the face. Now we are going to look for this neck area. Okay, sir. So now again, catch this part. Sir, total this deep fascia is having the yes modification which is encircling the neck like the collar. Like the collar, that's why it is known as a colli. It is known as a colli. Colli means collar. Okay, sir. This is the deep cervical fascia. Total 6 modification are there. Okay. Yes, yes, we will do the break. Just wait. We will do the break. Don't worry. No? We will complete this head, then we will do the break. Don't worry. So, investing layer of the deep cervical fascia, prevertebral fascia, pretracheal fascia, BP fascia, PV fascia, and the carotid sheath. Okay. Now catch this one. This is the question. The BP fascia and PV fascia, they are making the bed of the tonsil. This is the FMG 2020, I think 26 question. Yes. ENT question. Okay. Yes, the mostly in the anatomy question are asked in the carotid sheath. So we are looking for this carotid sheath. Can you see this carotid sheath part? Sir, there is a common carotid artery, internal jugular vein. In between them, there is a vagus nerve, vagus nerve. Sir, external carotid artery is going outside. So God is creating one deep fascia modification around this carotid vessels to protect them. Okay. So what are the content of the carotid sheath? Sir, internal carotid artery, sir, common carotid artery, sir, internal jugular vein, and vagus nerve, vagus nerve. And on the front wall of the carotid sheath, can you see, sir, there is one loop of the nerve. Sir, loop means ensa, and it is in the neck. That's a cervicalis. FMG 2026. Yes. Can you see? Sir, there are the fascia. This is the pharyngobasal fascia, and this is the buccopharyngeal fascia. In which between these two, there is a supraconstrictor muscle. So these two fascia are making the bed of the tonsil. Got the point? This is the question which had been asked earlier. So now we are cutting it. So can you see this image? Sir, this is the intrajugular, this is the intercarotid artery, and the vagus nerve is in between. So it is having the anterior wall, it is having the posterior wall, and the ansa cervicalis is on the anterior side. So ansa cervicalis, AN for ansa, AN for anterior. And on the posterior wall, there is a sympathetic trunk. So only this fact you have to revise again and again. Carotid sheath is important. Okay. Now, look, ansa cervicalis. This question had been asked in your exam. Yes. Look here. What was the question? Recent question. Just observe here. Look at this part. Sir, just catch. Triangles of the neck. Submental triangle. One question. That's why. Answer cervicalis. Second question. Okay. And from the triangles of the neck, again, the cricothyroidotomy and the tracheostomy. These all are related with the triangles of the neck, directly or indirectly. 4 questions from this triangle of the neck. Okay. This was the question from the tonsil. And can you see? Yes, I told you. The cricothyroid is supplied by the external laryngeal nerve. It is a tensor of the vocal cord, larynx nerve supply. Okay. Tensor for the high pitch singing. Suppose I have to sing in the very, very high pitch. Like, yes, remember any the high pitch song like तू मेरा मिलना समझ लेना एक सपना था तुझको तो वो मिल ही गया जो तेरा अपना था तू मेरा मिलना समझ लेना एक सपना था, तुझको तो वो मिल ही गया जो तेरा अपना था। तेरी गलियों में न रखेंगे कदम, आज के बाद तुझसे मिलने को न आएंगे सनम, आज के बाद। आर यू गेटिंग द हाई पिच सॉन्ग? This high pitch singing is done by the cricothyroid. If external laryngeal nerve has gone, then there is the damage of which nerve? External laryngeal nerve. If cuff reflex has gone, cuff is controlled by internal laryngeal nerve in the smuggler fossa, piriform fossa. So if anyone is getting damage in the piriform fossa, fishbone, which nerve has gone? Internal laryngeal nerve. And if there is the breathing problem, hoarseness of the voice, then recurrent laryngeal nerve. Again, I want to tell you, the laryngeal nerves are important. Don't forget these things. Agree? Done. So these are important things. That's why I told you with singing the song. Okay, so look here. Ansa cervicalis, sir. Root value of the ansa cervicalis, this is the ansa cervicalis. It is having the two root, anterior and posterior. But when we do dissection, then it is extended in this way. So anterior is going superior and this posterior is going inferior. So this is the superior root, this is the inferior root. Answer. Root value C1, C2, C3. Now see, this C1 is running with the 12th nerve, while the C2 and C3, they are uniting and making the loop. So from this C1, the root is coming, the superior root, and it is joining this inferior root. So this superior root is also known as descendants hypoglossi, because it is descending from the hypoglossal nerve. ये hypoglossal nerve है, यहाँ से descend कर रहा है. That's why it is known as the descendants hypoglossi, also the superior root. And this inferior root is formed by the C2, C3. They are uniting and making the loop. That's why ansa cervicalis. Now see, what are the different nerves? What are the different muscles which are supplied by it? So you can see, you can observe easily. Yes, it is giving the branch to the superior belly of the omoid. It is giving the branch to the inferior belly of the omoid. Yes, it is giving the branch to sternothyroid, sternohyoid. So all the strap muscles of the neck, they are supplied by the ansa cervicalis. But sir, thyroid muscle is at the very top. Thyroid is very top. So it is supplied by the C1. FMG 2026 question. Okay. Fine. So this is very, very important topic. That's why we covered. Now, triangles of the neck. Look here. In the neck, there is a sternocleidomastoid muscle. So in front of the sternocleidomastoid muscle, in front of the sternocleidomastoid, this is the anterior triangle. Behind the sternocleidomastoid, this is the posterior triangle. Now here is the hyoid bone. So there is a one anterior belly, there is a posterior belly. Yes, there is an anterior belly and the posterior belly. So in between these two belly, this is the digestive triangle. And below the chin, this area is the submental triangle, which had been asked in your FMG 2026. In front of the sternocleidomastoid, this is the, yes, carotid triangle. And here you can see, sir, this is the muscular triangle, sir. This is the muscular triangle. Is it okay? And here you can see the inferior belly of the omoid, which is dividing the posterior triangle of the neck into the occipital triangle and subclavian triangle. Again, in easy way. Can you see this one? This is the sternocleidomastoid. In front of it, this is the anterior triangle. Behind it, this is the posterior triangle. So look here, anterior belly of the digastric, posterior belly of digastric. In between them, digastric triangle. Because here the main contains submandibular gland. That's why it is also known as submandibular triangle. Important. Sir, anterior belly of the digastric. It is the first arch derivative. So it is supplied with the nerve of the first arch, that is mandibular nerve. Yes, it is a nerve to mylohyoid. And it is the posterior belly of the digastric. It is the derivative of the second arch. So it is supplied with the nerve of the second arch, that is the facial nerve. So it is having the double nerve supply, that is a hybrid muscle, NEET PG 2025 question. Yes, what is a hybrid muscle? Every muscle is having the one nerve. Yes, one boyfriend, one girlfriend. Yes, this is the rule. But there are the few muscles which are having the two nerves. There are the few boys who are having the two girls. Yes, so they are doing threesome. Are you getting? So such kind of threesome, such kind of the muscles who are having the double nerve supply, known as hybrid muscle. क्यों अब तो नहीं भूलोगे ना? Okay, now you cannot forget. And this hybrid muscle, this threesome is very important. What are the different muscles? Composite muscle. What are the different hybrid muscle? Never forget, one hybrid muscle is going to ask in your exam. So in the neck, only one hybrid muscle is there. That is your digastric. Okay, fine. Now come to the next. Further, sir. Just below the mental area, this is a submental triangle above the hyoid. Okay, and below the hyoid, this is the muscular triangle. and this is the carotid triangle in front of the sternocleidomastoid. Okay. Now you can see inferior belly of the omohyoid. It is dividing the posterior triangle, yes, into the occipital triangle, and this is the subclavian triangle. Also, you can say supraclavicular triangle. Done. Okay. So these are the different things which we have to learn. Now we are going to look for the different brain section part. Okay. So do you remember this formula? Yes, we did the dance and we enjoyed this one. What? CSF, THP, MPM, VOT. Yes, CSF, THP, MPM, VOT. We did this down. And one question sure from here. Why? Because C for corpus callosum. Yes, look here, look here, look here. Cadaveric image. CSF. Corpus callosum, septum pellucidum, fornix. Do you remember? Corpus callosum. This is the one thin septa which is lucid. और फिर इस lucid septa को क्या कर देना? Pale देना. So this is septum pellucidum. And then just below to it, fornix. I am teaching you because one question sure from this particular zone. So again, you can observe here. Again, you can observe here. Look here, look here, look here, look here. Yes. Corpus callosum. The questions are asked from this zone. Don't forget. Very, very important. Okay. So that's why I'm telling you, sir, formula CSF. Then T for thalamus. Below the thalamus, hypo. Hypo means below. And then P for pituitary. Then do you remember MPM? Midbrain, pons, and medulla. Then VOT. V for vertebra, O for esophagus, and T for trachea. Yes, just behind the midbrain, superior colliculus and another elevation inferior colliculus. And above it, the third eye of the Lord Shiva, the pineal gland. Is it okay? Clear? Now you can observe easily. Sir, you can count the box. C1, C2, C3, C4, C5, C6, C7, T8, T1, not the T8, C8, not C8, C7, and then T1. Now can you see the esophagus is very collapsed structure, but at the level of the C6, it is getting wide opening. So this upper funnel-like dilate part, upper part of the esophagus is the pharynx, and this is a trachea. So upper part of the trachea is known as the larynx. Okay. Now see at this portion C6, there is a cricoid and the pharynx junction. So this is cricopharyngeal junction, which is the narrowest part of the GIT. So MCQs, can you recall? At this cricopharyngeal junction, pharynx ends. Esophagus starts at C6. Larynx ends at C6. Trachea starts at C6. Narrowest part of the GIT, C6. Cricoid cartilage is located at C6. Common carotid artery is palpable at cricoid cartilage. So common carotid artery is palpable at which vertebral level? C6. सबका मालिक एक है C6. Whatever I told you, everything is written. So remember, लब पे दुआएं, आंखों में आंसू, दिल में उम्मीदें, पर झोली खाली, शिरडी वाले साईं बाबा आया है तेरे दर पे सवाली. So remember, सबका मालिक एक है C6. MCQs are asked from here, sir. Malik C6 cricopharyngeal junction. Everything is written. Don't forget. Yes, it is difficult to remember each and every vertebral level, but it is easy to remember few vertebral level, and it is very difficult to forget this vertebral level. How can you forget? You cannot forget this vertebral level. Okay, fine. Agree? Okay, sir. So now come to the next. Whatever I taught you, everything is written here. Na? Fine. Now look, sir. There is a nasopharynx, oropharynx, laryngopharynx. It is difficult to remember the vertebral level, but see how it is easy. CBI anatomy है तो सब मुमकिन है. How? Sir, first part of the pharynx, first cervical vertebra. Second part, two cervical vertebra. Third part, three cervical vertebra. Is it okay? Three parts. Done. Agree? Okay. So now look. इमेजिनेशन पावर. लड़कों इसका सही सदुपयोग करो. सुपीरियलेशन ऑफ द नेसोफेरिंक्स, बेस ऑफ द इसका. इंफीरियलेशन ओरोफेरिंक्स. एंट्रिलेशन नेजल कैविटी. पोस्टीरियलेशन फर्स्ट पार्ट फर्स्ट सर्वाइकल वर्टिब्रा. सर सेकंड पार्ट सुपीरियलेशन नेसोफेरिंक्स. इंफीरियलेशन laryngopharynx. एंट्रिलेशन ओरल कैविटी. पोस्टीरियलेशन यस, सेकंड पार्ट टू सर्वाइकल वर्टिब्रा, वेरी इजी, जो दिख रहा है वो बोलना है. लैरिंगोफेरिंक्स सुपीरियर रिलेशन ओरोफेरिंक्स, inferior relation esophagus, anterior relation larynx. So it is the third part. So next three cervical vertebra C4, C5, C6. It is ending at which level? C6. Complete. Now see, sir, this is the tongue. So in the tongue, from the geniotubercle tubercle, one muscle is going to the tongue. So this is geniotubercle tubercle to the tongue. So this is a genioglossus. When this muscle will contract, it will protrude the tongue. So it prevents the backward falling of the tongue over the larynx. So this is the safety muscle of tongue. Very, very important. Do you remember, in a funny way, we remembered Goga surgery. Goga surgery is safety. So remember, safety muscle of tongue, Goga. GG. Genioglossus is the safety muscle of the tongue. Getting the point? And which muscle is the safety muscle of the larynx? Posterior which had been asked in the recent INICET exam. Yes, can you see the recent INICET exam? They ask only abductor of the vocal cord. Answer is the your B, green color, and this B is nothing. This is a posterior PCA. PCA. So directly indirectly they will ask the same question, na? Yes, sir. So these are the things which you have to remember. Now, sir, everything is written here. Whatever I taught you, sir, radiology integration. One question sure from this area. Radiology is nothing, it is a shadow of the anatomy. How? Scalp, skull, brain. Now can you see the C, S, F? Corpus callosum, septum pellucidum, fornix. Then thalamus, hypothalamus, pituitary, THP. Then M, P, M, midbrain, pons, and then medulla. And here you can see the cerebellum. Sir, this is the spinal cord. And can you see, sir, there are the vertebrae C1, C2, C3, C4, C5, C6. So in front of the C1, nasopharynx. In front of the C2, C3, oropharynx. In front of the C4, C5, C6, sir, there is a laryngopharynx. You can say the vertebra, esophagus, and the trachea. Okay, and yes, this is the hard palate and this is soft palate. So this is genioglossus. Are you getting? So this is the oral cavity, this is the nasal cavity part. Is it okay? Fine. So radiology will be easy when you are doing the anatomy portion. Now, again, the cranial cavity. Again, you can do the three-dimensional orientation. Lal full, nila full, anatomy beautiful. Ye dialogue Dr. Shrikant Verma ka. Yes. So now look further, sir. सर डिड यू लर्न एनाटॉमी बाय योरसेल्फ लाइक दिस और इट वाज योर टीचर? बेटा हमारे जो टीचर थे ना डॉक्टर सी के शुक्ला सर, मार मार के पढ़ाते थे, एक मजाक नहीं होती थी. ठीक है, टीबिया फिबुला फीमर जो मिलता उससे तोड़ से मारते थे, है ना. तो हम लोग की जो एनाटॉमी पढ़ाई वो तो बड़ी डर डर के हुई है कि भैया आज मार मत पड़ जाए. ठीक है. ओके यस बेटा, ये जो इतना स्ट्रेस से जो हम एमबीबीएस से गुजरे ना, तो उससे हमको लगा कि नहीं यार, इस तरीके से स्ट्रेस में लेकर पढ़ने का कोई मतलब नहीं है. पढ़ा जाए तो मजे के साथ पढ़ा जाए, जिससे और स्ट्रेस कम हो, पढ़ने में मन लगे. देखो, पढ़ने वाला बच्चा तो ऐसे ही पढ़ लेता है. असली टीचर तो वो है जो नहीं पढ़ने वाला बच्चा है, वो भी मजबूरी में कैसे, अरे यार सर की क्लास जाना ही पड़ेगा. गाने सुनने के लिए आएंगे, डांस करने के लिए आएंगे, वेज जोक और नॉन वेज जोक सुनने के लिए आएंगे. तो नहीं पढ़ने वाला बच्चा भी अगर क्लास में आ रहा है तो वो असली टीचर है. ओके, तो हमारा टारगेट बेटा, जो पढ़ने वाला बच्चा हो तो ऐसे ही पढ़ लेता है, जो नहीं पढ़ने वाला बच्चा है उसको पढ़ाना हमारा टारगेट है. ओके, सो नाउ लुक हियर फर्दर. सर, वी आर गोइंग टू लुक द cranial cavity. See the skull. So now we are looking the skull further. Can you see? Can you see this one? That one? That one? Anterocranial fossa. This is the middle cranial fossa, and that is the posterior cranial fossa. Got the point? Done? Okay. So the same thing. Can you see this is the largest foramen of the skull, foramen magna, and in front of it, this is the second largest foramen of the skull, that is jugular foramen. Okay? Clear? Okay, sir. So now the cranial nerves are very important. Sir, this is a cribriform plate of sigmoid from where the first cranial nerve is coming. Yes, sir. Olfactory bulb, olfactory tract, olfactory strap. Now the optic canal from where the second cranial nerve is arising. Sir, this is superior orbital fissure from where the 3, 4, 6 nerves are there. 3, 4, 6. Now this is the thickest cranial nerve, largest cranial nerve, bhaisa type का nerve. Do you remember buffalo like nerve? Trigeminal nerve. So it is dividing into the fifth one, fifth two, fifth three. Okay. Yes, the fifth one is passing through supraorbital fissure. Fifth two is passing through foramen rotundum. Fifth three from the foramen oval. One question show from the foramen cranial nerves show. Now this is the internal acoustic metres from where the 7th and 8th nerves are passing. Then this is the jugular foramen from where 9, 10, 11 nerves are passing. And this is the hypoglossal canal from where the 12th nerve is passing. Is it clear? Is it clear? So you can remember the Hollywood, Bollywood, Tollywood song. So just catch this one. So the song dedicated for this. 1 2 3 4 5 6 7 8 9 10 11 12 13. Don't. Yes, Madhuri auntie included 13. Otherwise, copyright issue and we will demand for the money. That's why. So what you have to remember, sir, check here. There is one nervite terminus, one nerve at the terminal end. Yes, it is considered as 13th pair cranial nerve. It is also considered as the 0 pair cranial nerve. Update for all of you. Okay, sir. Now catch here. These foramens are difficult to remember, especially the central one. So there is one funny formula to remember. What you have to remember? King, राजा होता है, महल में बीचों बीच बैठता है. So king at the center. Queens, queens are on each side of the queens. Okay, they are shy in nature. Yes, रानियां जो हैं वो लेती हैं और शर्माती हैं. So you can remember ले शर्म. So foramen ले शर्म is on each side of the king. राजा रानी को रोज देता है. राजा रानी को रोज देता है, इसीलिए रानियां लेती हैं और शर्माती हैं. आर यू गेटिंग? सो इन दिस फनी वे यू कैन रिमेंबर. Got the point? Okay. So what you have to observe? Who is the king? Pituitary gland. Pituitary gland is at the center. Queen, foramen lacerum on each side of the pituitary gland, and the rotundum, then oval, then spinosum. So look here. Look here. How to identify this foramen? So king is at the center. On each side, whatever the foramen on each side of the king. Yes, that is the foramen lacerum. And now what is happening? राजा रानी को रोज देता है. ROSE. R for rotundum foramen, O for oval foramen, and S for spinosum foramen. From this spinosum foramen, emissory vein may pass, may not pass. Is it okay? Got the point? Yes, sir. So in this way, you can remember this difficult kind of foramen. Fine. Now again, look here. Again revising the cranial nerves. Sir, 1 2 3 4 5 6 7 8 9 10 11 12. Okay, fine. So now see, cribriform plate of ethmoid, first cranial nerve. So optic nerve, optic canal, there is second cranial nerve. And then superior orbital fissure, there is a 3, 4, 5. Yes, this is dividing fifth one, fifth two, fifth three. So you can observe easily. Now this is the sixth cranial nerve. These nerves are related just lateral to the pituitary gland where the cavernous sinus is there. So when you will remove the cavernous sinus, these are visible. Now interacoustic metres from where the 7th and 8th nerves are passing. Then this is the jugular foramen from where the 9th, 10th and 11th nerves are passing. 9, 10, 11. The 12th nerve is passing through the hypoglossal canal. So cranial nerves are very important. Agree? Now one beautiful integration. Can you see? Anat, physio, patho, pharma, medicine, ops gynae, integration, 6 subject integration. Sir, ophthalmology, 7. This is the pituitary gland. Just above it, there is the optic nerve which is making the optic chiasma. So pituitary tumor, which is the most common pituitary tumor, pituitary adenoma. 2 types of the pituitary adenoma. Every line is MCQ, no? Microadenoma, macroadenoma. What is the millimeter? 10 millimeter. Less than 10 millimeter, microadenoma. More than 10 millimeter, macroadenoma. So if the pituitary tumor is there, sir, nasal fibers are damaged, but the temporal fibers are not damaged. So when the nasal fibers are getting damaged, then bitemporal hemianopia, ophthalmology, physiology, there's a tubular vision, MCQ. Now, which cell is getting proliferation most commonly? Answer is the lactotrop. Lactotrop is secreting which hormone? Prolactin hormone. So when the prolactin hormone is secreted, then it is leading to the galactoria. And due to the galactoria, there is amenorrhea. So this will lead to the galactoria amenorrhea syndrome. Yes, it is leading to the galactoria amenorrhea syndrome, gas syndrome. Ops gynae, ops gynae, ops gynae. Okay. Now what you will do? Yes, this prolactin hormone is dopamine antagonist. Yes, it is just opposite to the dopamine. So you will give such kind of the drug which is dopamine agonist, that is the bromocriptine. but better drug with the less side effect. That is the cabergoline. जब पक्का आएगा ना क्वेश्चन, पक्का आएगा. Okay. So cabergoline is the drug of the choice. But if not treated, then what you will do? Yes, you will do the transnasal, transsphincter surgery. Yes, you will approach through the nose. Look here. This is the pituitary gland. It is at the center, so you cannot go from here, 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 here. It is the best to go from the nose, break the sphenoid bone, and then remove it. So this is what? This is the transnasal transsphinodal hypophysectomy operation. Is it okay? Neurosurgery. Pakka, yes, for the acromegaly, for the pituitary tumor, it is the best approach because it is the king. It is sitting at the center. Okay, clear, beta? Okay, sir. So these are the things which you have to remember. Okay, sir. Also, the pituitary gland, sir, sella turcica. It is located as sella turcica. So this one, sella turcica. Turkish saddle. So remember, the Turkish saddle is same thing, which is a Sela Turcica. So this is the part of the what? Body of human. This is another question. Okay. Yes. R for rotundum, O for oval. The foramen oval is passing the MALE. Very, very important. M for mandibular nerve, A for accessory meningeal artery, L for lesser petrosal nerve, E for emissary vein. And foramen spinosum is passing the MEN. M for middle meningeal artery. Yes, E for emissary vein. Generally, it is not passing. Sometimes it is passing. And N for nervous spinosum. So don't forget one foramen is important. So this is the formula. Okay. Okay, sir. So now one more thing. Look here. There is a foramen spinosum. It is giving the middle meningeal artery, and this artery is coming here. Can you see this is the skull bone and this is the dura mater. So this artery is outside the dura mater. So whenever there is a fracture, rotator accident, the bleeding is here, bleeding is here, bleeding is here. Yes, it is getting mass and it is elevating the dura mater. So this is the biconvex idli shape, lens shaped, opacity on the lateral side. This is the extradural hemorrhage. Are you getting? Biconvex idli lens shaped. This is the middle meningeal artery rupture. This is the extradural hemorrhage. One question sure from this bleeding part. So look at this point. NEET PG 2026 question. So this is jugular foramen. Remember, the jugular foramen is like entry part, middle part, posterior part. For you, the middle part is important. Remember, the middle part, sir, the 9, 10, 11 cranial nerves are passing. Sir, this 10 and 11, they are sapphina. They are vagoaccessory complex. So the ninth nerve is having the separate dural sheath. Yes, separate dural sheath. Separate dural sheath is better word than the separate canal. No? Separate dural sheath. Is it okay? Fine. Now look, on the front, inferior petrous sinus, on the back, internal jugular vein. So you can remember the formula. आगे आई, पीछे आई, बीच में 9, 10, 11. Anterior eye, inferior petrous sinus, posterior eye, internal jugular vein. Between is the 9, 10, 11 cranial. So NEET PG 2025, 9, 10, 11 are passing through the middle part of the jugular foramen. Now look, very, very important. One of the most repeated question of this, your topic, sir. Central part of the pterion is on Sylvian point. Cranium is very thin here, so the craniotomy operation you can do here. Yes, middle meningeal artery is here, so it is getting ruptured easily, so it is resulting in extradural hemorrhage. So this is extradural hemorrhage which talked. Now look, sir, one question sure from here. Extradural hemorrhage, rupture of the middle meningeal artery, it is leading to the idyllic shape. Sir, subdural hemorrhage, so cortical bridging, so there is a banana shape or the crescent shape. Radiology question. Yes, if the bleeding is below the ethnoid matter, then subarachnoid hemorrhage, that is a berenianism. Sir, it will lead to the star-shaped death. And intracranial hemorrhage, sir, it is due to hypertension. So there is a lacunar infarction condition. So one question sure from here. Now I'm going to tell you the dural venous sinuses. Okay, so these all the things I'm going to tell you with the three-dimensional orientation. So look here, the beautiful three-dimensional orientation again. Lal full, nilla full, anatomy beautiful. Yes. Just after this we are going to do a little break ना, don't worry sir. इसके बाद कोई दूसरी क्लास है भी नहीं बेटा, है ना, तो हम एनाटॉमी को खत्म करके उठेंगे. Don't worry, we will do the break. So can you see this one, sir? We are doing dissection. Can you see? This is a fold of the dura mater. This is a fold of the dura mater. Fine. Okay, and within this fold of the dura mater you can see the large veins. So this is a superior sagittal sinus. एक चुटकी सिंदूर की कीमत तुम क्या जानोगे रमेश बाबू? Exactly at this location there is superior sagittal sinus. That dialogue from the Om Shanti Om by Deepika Padukone aunty is arising from the anatomy. So don't forget she is also the CBI agent. Okay, now cut it. This is the inferior sagittal sinus. Now look here, this is the, yes, Galen vein. Yes, do you remember Galen vein deformity? The radio, the pedia, the surgery question. This is the Galen vein. If abnormality in this location, if abnormality in this vein, then Galen vein deformity. So this is a Galen vein, dark area of the anatomy. You are right. So now inferior sinus plus great cerebral vein of the Galen is equal to straight vein, straight sinus. So this question had been asked in the FMGE 2022 radiology question. So remember, this is what this is the straight sinus. Now these all the sinuses, superior sinus, transverse sinus, sir, occipital sinus, and the stress sinus, all are meeting at this point. That is a torricular hierophyllae. That is a confluence of the sinus. Can you see? This is the delta, empty delta sign. Can you see? It is looking like the empty delta. So whenever cerebral venous thrombosis, again radiology 2022 question, which I 2023 or 2022, this is looking like the delta. So whenever cerebral venous thrombosis, there is an empty delta is visible. Radiology integration. Getting the point? Exactly. From the anatomy, you will get the clear concept of the every subject. Okay. So now here there is a meeting point of the different sinuses. TOS, T for transverse sinus, O for occipital sinus, S for superior sinus, and S for straight sinus. So these TOS are meeting together. So this is the confluence of the sinus. MCQ, TOS. Torcular Herophilus, father of the anatomy, meeting point of all the sinuses. TOSS, T for transverse sinus, O for occipital sinus, S for straight sinus, and S for superior sagittal sinus. Don't forget this one. Okay. Now you can see this transverse sinus is running as the S shape. So this is the sigmoid sinus, which is passing through the jugular foramen outside. Can you see? And now it will run as the internal jugular vein. Internal jugular vein is nothing, it is a continuation of the sigmoid sinus. Is it okay? Clear? Okay. So this is the flow of the blood in the brain. So you can remember superior sagittal sinus reaching to the torcular hierophyllae, then it is going to the right side, right transverse sinus, and then you will see this is going to make the right sigmoid sinus and then right internal jugular vein. While the inferior sinus, it is meeting with the great cerebellum gland, then it is making the straight sinus, then it is reaching to the torcular hierophyllae, then it is making the left transverse sinus, then it is making the left sigmoid sinus, then it is making the left internal jugular vein. Is it okay? Okay, sir. Now we are looking the cavernous sinus. Sir, the cavernous sinus is located on each side of the pituitary gland. So when you will remove the cavernous sinus, you will look on the lateral side, you will see 3, 4, fifth one, fifth two, sixth nerve is inside, and this is the internal carotid artery. I am showing you the different section. So when you will cut in the coronal section, pituitary gland is at the center. So this is the cave sinus, cavernous sinus, roof, floor, lateral wall, medial wall. On the lateral wall, third, fourth, fifth one, fifth two are related, but the mandibular nerve is outside. And what are the content? Sir, internal carotid artery, and there is the, yes, you can say the sixth nerve, which is having the durametric tunnel, that is the, yes, Dorello canal. So question, the Dorello canal, it contains which cranial nerve? Sixth nerve, abducens nerve. So remember, due to this durametric tunnel, wherever there is a high ICT, rest ICT, head injury, the most common cranial which is getting damaged, that is sixth nerve. MCQ medicine. Okay. Now, if there is an infection, these nerves, these structures are involved, so it is leading to the, yes, you can say very toxic condition, that is a cavernous sinus thrombosis. So it is important. Okay. So in case of the cavernous sinus thrombosis, this all the structures are affected. The intercarotid artery, they are affected. Also, this is a pulsatile exophthalmos, which you will learn in the clinical. Okay. So now we are looking the PYQ, PYT. Yes, the 2026, they are asking the extradural hemorrhage. Yes, they are asking the inferior nerve. So can you see the inferior nerve? It is passing and it is making the mental nerve. It is making the mental nerve. It is applying the lower jaw. So inferior nerve had been asked clinical. You will block this inferior nerve. Yes, in case of the dental surgery. Yes. Now again, they are asking the mental nerve, the Rahman-Dakat nerve. They are asking for the submental triangle, which we had discussed. Yes, they are asking about the ansa cervicalis. We discussed this one, thyroid. Yes, they are asking for the thyroid surgery, cricothyroidotomy. If any patient is can't intubate, can't ventilate, then you will do the cricothyroidotomy. Yes, they are asking again tracheostomy operation. Yes. So you are creating the opening in front of the trachea. During the regular class, I told you, but actually it is the ENT. So just I am telling you quick part. So it is made, tracheostomy is made on the second and third tracheal ring. Okay. Now they ask the palatine tonsil. Yes, she is unable to sing high pitch. High pitch note means which muscle? Cricothyroid. That's why external laryngeal nerve. Are you getting? Fine. Now there is the, yes, double halo sign, double ring sign. You know that is a within the esophagus. So this is very, very commonly asked question, button battery sign. Now they ask for the Jenkins diverticula also. Yes, superior constrictor, middle constrictor, and inferior constrictor. I taught you that inferior constrictor is having the hyropharyngeus, horizontal part, cricopharyngeus. So this weak triangular area is on scalial dehiscence. From here the pouch is coming, that is a Jenkins diverticula. Okay. And then they ask about the supraorbital fissure. So I told you the formula. Sir, there is a common tendinous ring within which is dividing the lateral part, middle part, and inferior part or medial part. Yes, within the optic canal, second nerve and the ophthalmic artery is there. And now the lateral part is passing one vein, one artery. So superior ophthalmic vein is here. Here is the inferior ophthalmic vein. Yes. Now this ophthalmic artery is giving the branch which is turning and giving the branch again to the meninges. So this is turning the direction. Turning the direction, that is known as the girlfriend. जो direction बदलती है उसे क्या कहते हैं? Girlfriend. Sorry, recurrent कहते हैं. So this is a recurrent meningeal branch of the ophthalmic artery. यस, ये पलट के पीछे चली जाती है और फिर हमारे मेनिंजेस को सप्लाई करती है. व्हाट आर द अदर स्ट्रक्चर्स? एल एफ टी. एल फॉर लाइक्राइमल नर्व, एफ फॉर फ्रंटल नर्व, टी फॉर ट्रॉक्लियर नर्व. एंड व्हाट आर द डिफरेंट नर्व्स एट दिस मिडिल पार्ट? सोनिया, एसओ, सुपीरियर डिवीजन ऑफ द oculomotor nerve. N for nasociliary nerve, I for yes inferior division of the oculomotor nerve, and A for abducens nerve. So these are the questions which had been asked. Okay. Now come to the next, superior orbital fissure syndrome. So if any tumor is affecting this structure, then it is superior orbital fissure syndrome. But suppose these both structures are affected, then it is orbital apex syndrome. Okay, so these are the topics. Now they are asking again the smuggler fossa, pariform fossa. There is an internal laryngeal nerve. The fish bone is getting trapped, so the cuff reflex is gone. Okay, so that's why it is important. Yes, coping muscle, cheating muscle, superior oblique muscle. So whenever any patient is having the downward and lateral, downward and lateral. So this is the coping position, cheating muscle, cheating muscle. This muscle is responsible for downward and lateral. Okay, so if the third nerve is damaged, so the fourth nerve is pulling down and lateral. So if any eye position is in this way, means third nerve is getting damaged. Okay. Then can you see the face syndrome? I told you the sweating over the flushing preauricular area. And they are asking again and again the great auricular nerve. Okay. Remember, in case of the leprosy, this great auricular nerve is getting thickened. And which cranial nerve is the most common cranial nerve? In leprosy, answer is the facial nerve. Next, they are asking about the lymph node. So this is the surgery topic. I taught you the lymph node. Yes, level 1, 1A, 1, 2. Then sternocleidomastoid, upper one third, middle one third, lower one third. So level 2, 3, 4. Yes, then 5 behind, then 6 anteriorly, and 7 in the entry mediastinum. So this is the surgery question. Yes, now the common carotid artery, I told you, C, just add the 6 cricoid cartilage. And then I told you the loss of sensation from the entry to the tongue. Tongue is important. So general sensation is carried by the lingual nerve. Okay, so tongue is important. Now they are asking for the extradural hemorrhage. Definitely the pterion is the answer. And they ask the question for the Allu Arjun. Yes, the trapezius. I will teach you in the upper limb. Now, trapezius muscle is supplied by the 11th nerve. This 11th nerve was getting damaged in the Allu Arjun, so shoulder was down. So remember this one, sir. The 11th nerve is the answer. Next, they ask about the great auricular nerve again and again. They are asking for the fourth dangerous area of the scalp, losal layer. They are asking about the vertebral level. I told you how to remember the vertebral level. This time they ask the C3, C4 junction, the upper border of the cardiac. Yes, again they are asking the 12th nerve. Cranial nerves are important. Yes, 12th nerve is supplying the genioglossus. If genioglossus is paralyzed, there is a deviation of the tongue on the same side. Next, they are asking the cranial section, epiglottis, and yes, thank you very much. Now we will start the neuroanatomy part. Okay, fine. So can you take a little break? No, no worry, beta. After this, no class, so we'll complete this all the session. Okay, so thank you very much. Take a little break, then we'll continue. So here's a magic for all of you. लाल फूल नीला फूल एनाटॉमी ब्यूटीफुल. कैसा लगा मेरा मैजिक? Hello, dear friends. Now again we are going to continue the session. Lol, full, lila, full, anatomy, beautiful. Yes, magic successful. So we are going to continue with this neuronal portion. अर्ज किया है, मान लो मेरी राय, इश्क से बेहतर है चाय। ये तो टपकता हुआ चाय है। गोविंदा 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 गोविंदा। Yes, any doubt till now? मान लो मेरी राय, इश्क से बेहतर है चाय। सर मजा आ गया अभी तक तो। ये कौन बोला? आकाश रंजन। अरे हमारा एक स्टूडेंट था यार, जो बार बार आता था, रंजन नाम ही था। यस, सौरभ। हेलो बेटा, कैसे हो? कौन सौरभ? ये एम्स वाला सौरभ है क्या? मेरा नाम आप सही से बोलते, क्या बोलते हैं? अच्छा, रे ऑफ होप। अच्छा अच्छा, उम्मीद की किरण। अच्छा। सर डर डर लग रहा है। मोटिवेट कर दो। देखो बेटा, डरना किस चीज का? डरोगे ना तो और उल्टा परफॉर्मेंस ना डिक्रीज होता है। जो होगा अच्छा होगा। बिल्कुल टेंशन न लो, है ना? क्यों डरे जिंदगी से? क्यों डरे जिंदगी से कि क्या होगा? अरे कुछ नहीं होगा तो कम से कम कम से कम तजुर्बा होगा। क्यों डरे एग्जाम से कि क्या होगा? अरे कुछ नहीं होगा तो कम से कम तजुर्बा होगा। आदमी या तो जीतता है या फिर सीखता है। आदमी हारता कभी नहीं है। आदमी हारता उस दिन है जिस दिन कोशिश करना छोड़ देता है। ओके। ओके, टोनी स्टार्क। दे दिया। ओके, तो बेटा हमने एक बहुत बड़ा हर्डल क्रॉस कर लिया। नहीं बेटा, उतना मैटर नहीं करता ना। मैटर क्या करता है कि जिस दिन आप एग्जाम हॉल में गए हो, उस दिन आपकी मेंटेलिटी कैसी है, उस दिन आप कैसा परफॉर्मेंस कर रहे हो। ओके। लेकिन ये जीटी में स्कोर अच्छा आता रहता है, तो इससे क्या होता है, एक कॉन्फिडेंस मिलता है कि हाँ, हम मेन एग्जाम में अच्छा करने वाले हैं। बाकी कई सारे ऐसे बच्चे होते हैं जो जीटी में उनका रेगुलर, लेकिन वो रेगुलर अटेम्प्ट करते रहते हैं ना। रेगुलर अटेम्प्ट कर रहे हैं, जीटी दे रहे हैं, लेकिन मार्क्स अच्छे नहीं आ रहे। इन फाइनल एग्जाम में जब बैठते तब तक ना रिवीजन इतना हो चुका रहता है कि क्रैक कर जाते हैं। ओके, so now we are going to continue with the neural anatomy. Hello, dear friends. Now we are going to continue with this amazing portion. Again, very, very important part. We are going to integrate this neuroanatomy part with our neurosurgery, neuromedicine, even the psychiatry, the pharmacology, the pathology, so many subjects. Okay. So look here, the basic concept, sir, cell body collection within the CNS known as nucleus and outside the CNS known as ganglion. Axon collection within CNS tract outside CNS, that is the, yes, nerve, like the radial nerve, medial nerve, this all. Okay. Now look, this cell body is giving the gray matter appearance, the axons are giving the white matter appearance, right, sir? Now this is the your question. The spinal cord is reaching up to the end of the vertebral column in the newborn baby. Okay, up to approximately up. Okay. Now in the adult it is shorter. So this is the point. And not medicine, the pedia integration. Sir, spinal cord is ending in adult at the level of the L1. Otherwise L1 L2 junction. Okay. Yes. In newborn at the L3. Otherwise L3 L4 junction. Best answer is the L3. So you can remember 1, 2, 3, 4. Now lumbar puncture site below the L1 L2. So L3 L4 is the best in adult for the lumbar puncture. It is the level of the iliac crest also. But in the newborn, L4, L5 will be better. Okay, sir. Now look, the spinal nerves 31 pair. Formula is the C8, T12, L5, S5, and coccygeal is 1. Right, sir. So now you are looking the ending of the spinal cord. What are the different layers which are getting punctured? So look here. This is the last end of the spinal cord, which is cone-like dilated. So this is conus medullaris. If there is a damage, then conus medullaris syndrome. And from this conus medullaris, the tail of the nerves are coming. These are the, yes, horse-like, yes, tail of the horse like, I mean, that's a cauda equina. If there is a damage in this nose, then it is a cauda equina syndrome. Now when you will do lumbar puncture, what are the different layers? So you will see this formula, yes, the summary, sir. 3S ilidas, S for skin, S for superficial fascia, S for supraspinatus ligament. So supraspinatus, so these are the structures which are pierced. Then yes, interspinous ligament, ligamentum flava, and then epidural space. So illi, 3S, then illi, and then you will pierce the dura mater, then arachnoid matter, then needle will reach into the subarachnoid space. So 3S ilidas was the formula. Okay. Yes, the spinal cord is ending at the L1, but the arachnoid matter and the dura mater is ending at the S2. Phylum terminal is the extension of the pyometer. So these are the different MCQs. Now we had seen the tract portion. So we had observed, sir, the neurons are either descending or the ascending. And the bundle of the neuron, bundle of the axon, that is known as a tract. So there is a descending tract or the ascending tract. Descending tract, they are going to supply the muscle and causing the movement. So descending tract is also known as a motor tract, while you will be able to observe the ascending tract, they are carrying the sensation to the brain. So the ascending tract, they are also known as a sensory tract. So remember, the sensory is afferent or ascending, motor is efferent or descending. So your formula is the SAME. Sensory is afferent, motor is efferent. Okay, got the point? So tracts are bundle of axon with similar origin, similar course, and the similar termination with similar function. Getting the point? Clear? Okay. Now catch further. Sir, I told you the story of the tract at that time. Okay. So the MBBS story I told you at that time. So right now try to understand further. The axons which are having the same function, same origin, same termination, they will take the same seat. Okay. In the similar way, the bundle of the axons are there who are occupying same kind of the position. So first we are looking the sensory tract. Sir, in the dorsal column, there is a fasciculus gracilis, fasciculus cuneatus. F for fascicle, F for fine. So remember, fine touch, the proprioception, tactile localization, tactile discrimination, tactile vibration, and stenosis. These all are carried by the fasciculus gracilis, fasciculus cuneatus. So clinical integration, medicine, tabes dorsalis, syphilis, subacute combined degeneration, they are including this dorsal contract. So these are getting lost. Now, sir, this is the lateral white column. So on the lateral side, this is the dorsal spinocerebellar tract. This is the ventral spinocerebellar tract, which are carrying the, yes, you can say the subconscious kinesthetic sensation. And you can see there is an anterior tract, lateral tract. The lateral tract is responsible for the pain and temperature, and anterior tract is responsible for the crude touch sensor. What is a crude touch? Yes, you're going to the garden to meet the GF. Then what is happening? Sir, GF is touching. That is a fine touch. But when you will come back and your father will touch, diffuse touch. Yes, that is a crude touch. Got the point? Fine. Okay, sir. So according to the position, whenever there is the involvement, there is the loss of the things. Okay. Now look the descending tract. Look at the descending tract. See, sir, this is the bulb-like part. Yes, bulb means medulla. So medulla is the truncated bulb-like structure. So this is a truncated bulb-like structure. Sir, central elevation is the pyramid. Lateral elevation is known as the olive. Yes. So the tract which are passing through the pyramid, known as the pyramidal tract, and tracts which are passing outside the pyramid, known as the extrapyramidal tract. These are the descending tract. Descending tract, motor tract, they are two types: pyramidal tract and extrapyramidal tract. Now see, pyramidal tract, they are crossing together and then descending down. So this is a FMG question. The pyramidal decussation, pyramidal crossing is the pyramidal decussation, is found where? Upper part of the medulla, middle part of the medulla, or lower part of the medulla? What is your answer? Very good, Dr. Wolf Dikti, lower part of the medulla. This pyramidal tract is coming from the cortex, going to the spinal cord. So this is a corticospinal tract. So corticospinal tract is also the same. I told you, sir, behind the olive, 9th, 10th, 11th cranial nerve, and behind the pyramid, sir, this is the 12th cranial nerve. Fine. Now look, yes, we had seen the tract. SAME, sensory tract, fasciculus gracilis, fasciculus cuneatus, dorsospinal cerebral tract, ventral spinal cerebral tract, lateral spinal cerebral tract, anterior spinal cerebral tract, and the motor or efferent tract, pyramidal tract, and extrapyramidal tract. Pyramidal tract, lateral side corticospinal tract and anterior corticospinal tract. But the extrapyramidal tract, yes, you will see in the physiology, the formula was ROVT. Yes, R for reticulospinal tract, R for rubrospinal tract, O for olivospinal tract, V for vestibulospinal tract, T for tectospinal tract. Are you getting? So what I told you at that time, I told you that reticulospinal descending, rubrospinal descending, but rubro, yes, spino-rubral ascending. Okay, olivospinal descending, but spino-olivary tract is ascending. So just break the name and think about it. Question had been asked in the FMG 2025. Vestibulospinal tract. Vestibular apparatus is related with the equilibrium and the balance. So vestibulospinal tract is responsible for the equilibrium and the balance activity. Tectospinal tract is descending, but spinotectal tract is ascending. Are you getting? Yes, everything is written in the name. Also, you can see, sir, midbrain, pons, and medulla. This is the cerebellum. So three peduncles: superior cerebral peduncle, middle cerebral peduncle, inferior cerebral peduncle. So superior cerebral peduncle is joining the cerebellum with the midbrain, middle is joining with the pons, and inferior is joining with the medulla. So these are the points which you have to remember. Now, the brain stem and the cranial nerves. For it, we had drawn this diagrammatic presentation. Again, can you see this medulla? Sir, in the medulla, central elevation is the pyramid, lateral elevation is the olive. Behind the olive, 9, 10, 11 cranial nerve, and behind the pyramid, sir, 12th cranial nerve is there. Okay. So in the medulla, 9, 10, 11, 12, medulla means bulb. So if these nerves are getting damaged, then it is medullary paralysis, and medulla means bulb. So you can say medullary paralysis is equal to bulbar paralysis. I think today you did the medicine class. Definitely the bulbar paralysis term is always used. What is the bulbar paralysis? Simple. Sir, medullary paralysis is also the bulbar paralysis. Means 9, 10th, 11th, 12th nerve damage is the bulbar paralysis. Is it okay? Fine. Now try to catch the further more point. Sir, if there is a damage to the midline part of the medulla, medial medullary syndrome. If there is a damage to the lateral part of the medulla, lateral medullary syndrome. Lateral medullary syndrome is also known as the Wallenberg syndrome, the pica syndrome, posterior inferior cerebral artery syndrome. Very, very important. Definitely today in the medicine class, you discuss about it. If the midline part is getting damaged, then medial medullary syndrome. So can you see pyramid is getting damaged? Pyramid is getting damaged. That's why contralateral paralysis. And 12th nerve is getting damaged because the 12th nerve is here. So 12th nerve is getting damaged. That's why ipsilateral tongue deviation. This is also known as Deserine syndrome. Got the point? Yes. Medicine morning class, anatomy evening class. Yes, anatomy medicine integration. Got the point? Beautiful connection. Now look further. Sir, this is the pons area. Fine. So you will see, sir, there is a fifth cranial nerve and there is sixth, seventh, eighth. So remember, the sixth, seventh, and eighth cranial nerve, they are attached at the pontomedullary junction. Pontomedullary junction. So here is the fifth cranial nerve. Is it okay? Fine. So last four in the medulla. Yes. More four in the pons. Thickest cranial nerve. Yes. So what you have to remember, this is the trigeminal nerve. Now catch this one. Sir, this is the midbrain. Yes. It is having the two cranial nerve, third and fourth. Medial to the crus cerebri, third, behind it, fourth. And now when you are going upside, so inferior surface of the frontal lobe, you will see the first and the second cranial nerve, which is making the optic nerve, optic chiasm. This is the space in between the two peduncles. So this is the interpeduncular fossa. So in this interpedocular fossa, you will see there is the breast-like elevation mammillary body, and this is the small stalk from which the pituitary gland is attached. So this is the yes pituitary stalk. Is it okay? So this is the interpeduncular fossa. So the summary of this all the things, look here in the midbrain, medicine integration. Sir, 2 2 4 4. Do you remember? AG, OG, लोजी, सुनो जी, मैं हूं मन मौजी, करता हूं मैं जो वो तुम भी करो जी. 1 2 का 4, 4 2 का 1. The real song is 2 2 का 4 4, 4 4 का 2 2. First two cranial nerve, first and second, they are attached at the frontal lobe, no nucleus. Is it okay? Next two cranial nerve, they are attached to the midbrain. Third and fourth are attached at the midbrain. So if any patient is having the midbrain syndrome, definitely there is a third and fourth nerves are getting damaged. Yes, if any patient is having the Pontine syndrome, means pons is getting damaged. So 5, 6, 7, 8 nerves are damaged, then it is Pontine syndrome. Now medulla. So if there is a damage to the medulla, medullary syndrome, then 9, 10, 11, 12 cranial nerves are damaged. So this is a beautiful integration of the medicine and anatomy. Remember, both are complementary to each other. तो देखना जब हम सेरिबेलम में मिलेंगे तो दिलीप सर और मैं कैसे डांस करेंगे. ओके, दिलीप सर मुझे अपने कंधे पे उठा करके डांस करेंगे, देख लेना. मेडिसिन जो है वो एनाटॉमी को अपने सर पर बैठा करके डांस करेगा. सो रिमेंबर फॉर दिस. ओके, यस, इट इज अ ब्यूटीफुल इंटीग्रेशन. If you will not have the proper knowledge of the anatomy, how you will deal with the medicine? Got the point? Clear? Okay, sir. So now look further. Yes. तो मेरा बेटा भी मस्त पढ़ रहा है, और उसने बढ़िया टेबल पर जमाया और वो बढ़िया पढ़ रहा है. तो मैं अकेले नहीं पढ़ रहा हूँ, तुम अकेले नहीं पढ़ रहा हो, हमारा बेटा भी साथ पढ़ रहा है. ओके, प्रथम बोल बोल के पढ़ो ना. चलो आगे बढ़ते हैं. नाउ कम टू द नेक्स्ट further. Sir, there are the few important things. Yes, remember, if you will do problem with the comma, if you are not reading properly words, then there will be the problem with the answer. So every full stop comma words, they are important. ध्यान से सुनना. In exam hall also you have to keep attention properly, you have to focus properly, give the GT properly. Okay, fine. Otherwise तुम्हारा पूजा हो जाएगा, कमरे में तुम्हारी ले ली जाएगी, तुम कमरे में जाकर के दे करके आ जाओगे, तुम्हारी जान ले ली जाएगी. ओके, सो गेट रेडी. लॉन्गेस्ट क्रेनियल, वेगनर, वेगस नर्व. लार्जेस्ट क्रेनियल, लार्ज इज डिफरेंट एंड लॉन्ग इज डिफरेंट. फिफ्थ नर्व, large cranial nucleus. Thickest cranial nerve, trigeminal nerve, fifth nerve. Smallest cranial nerve, fourth nerve. Shortest means different, na? First cranial nerve. Thinnest, fourth nerve. Sir, maximum number of the axon, fifth nerve. That's why it is thickest. Sir, least number of the axon, fourth nerve. That's why it is thinnest. Longest intracranial nerve, fourth nerve. Longest intradural cranial nerve, sixth nerve. Longest intraosseous cranial nerve, answer is the seventh nerve. Is it okay? Is it clear? Done? Okay, sir. So the cadaveric image practice also you can do. Sir, this is the pyramid. Behind the pyramid, 12th nerve. This is the olive. So behind the olive, 9th, 10th, 11th. Yes, sir. This is the bulb-like dilatation, medulla. Now you can see, sir, this is the pons area. So the thickest cranial nerve, भैंसा type का nerve, 5th nerve. Literally बता रहा हूँ. Suppose in exam the question is asked, भैंसा type का nerve, trigeminal nerve आया तो भैंसा type का nerve ये word याद आएगा ना. Okay. And then can you see 6th, 7th and 8th. Fine. अरे बेटा डिप्रेशन क्यों होगा डॉक्टर दीपांशु? जीटी में नंबर कितने आ रहे ये मैटर नहीं करता. जीटी में तुम कितना कॉन्सेंट्रेट होकर के जीटी दे रहे हो ये मैटर करता है. इफ यू आर गिविंग द जीटी थ्रू आउट द ईयर, ओके, properly, you are not getting the score, but you are learning how to concentrate, how to focus, how to rule out, how to get the correct answer, how to play in the two session, how to get rest in between the two session. That is important. Okay, when the results are coming out in the FMGE, INICT, NEET PG, we are taking the interviews. Students are saying, sir, मेरा जीटी में नंबर ना अच्छा नहीं आता था, लेकिन मैंने रेगुलर जीटी दिया. ये स्टेटमेंट होता है बच्चों का. जो रेगुलर जीटी देता है, भले ही कम नंबर आते हैं, पास नहीं हो पाता, लेकिन रेगुलर जीटी देते रहता है, ये प्रैक्टिस करता है. ओके, रणभूमि में युद्ध से पहले मनोभूमि में खेला जाता है. जो रणभूमि से पहले मनोभूमि में खेलता है, जीटी करता है, बेटा उसका सिलेक्शन होता है. तो डरने का नहीं ना. अरे नंबर कम आता है, आने दो. दर्द अभी सह लो तो बाद में दर्द नहीं होगा. अगर अभी आप जीटी में दर्द नहीं सहोगे तो बेटा मेन एग्जाम में दर्द होगा, और वो दर्द असहनीय होता है. इज ओके? फाइन. ओके सर. सो नाउ लुक, दिस इज द क्रस cerebri. So medial to the crus cerebri, third, and behind to it, the fourth cranial. Sir, there is the first cranial and optic nerve which is making the crossing, that is the optic chiasma, right, sir? Fine. So these all are the things, cadaveric image practice also. Now we are turning the brainstem and we are looking from the backside. So when you are looking the backside, sir, there is the medulla, then pons, and this is the midbrain. So in the medulla, yes, you'll see medulla and pons, there is the one rhomboid shape space. This is the floor of the fourth ventricle. Here, the BP, heart rate, respiratory center is there. That's why it is very sensitive zone. Now see, there is a one line, linear structure. This is the stria in the medulla. That's why you say stria medullaris. Now look here, sir, there are the few triangle. Hypoglossal triangle, here the 12th nerve nucleus is located. Vagal triangle, here the 10th nerve nucleus is located. Lateral to it, vestibulocochlear triangle, where the 8th nerve nucleus is located. So these are facial colliculus, where the 6th and 7th nucleus is located. So many cranial nerves are located here. That's why it is important. Now go upside. So when you are going upside, sir, there are the two superior colliculus, there are the two inferior colliculus. Superior colliculus, sir, there is the interstitial nucleus of the kahal. How we are applying kahal, kajal, in this way, kajal. So your eyes are going up. Sir, remember this kahal nucleus, kajal nucleus is responsible for the upward gaze. English is very funny language. Yes, लिखते काजल हैं नहीं पढ़ते कहाल हैं. अभी मैं जॉर्जिया की क्लास से आया, वहां पर हम तास मिंदा टावर गए. ओके, तास मिंदा टावर, जहां पर एम साइलेंट होता है. क्या बोलोगे? इंग्लिश इज वेरी फनी लैंग्वेज. ओके, तो इसको मतास मिंडा टावर नहीं बोलना, इसको तास मिंडा टावर बोलना. ओके, यस, मतास मिंडा टावर. लेकिन हम देसी लोग हैं, हम तो मतास मिंडा टावर बोलेंगे. हम तो इसको काजल न्यूक्लियस बोलेंगे. व्हाई? बिकॉज व्हेन वी आर अप्लाइंग द काजल, यस, आईज आर रोटेटिंग अपसाइड. ओके, फाइन. कौन कौन से बच्चे जॉर्जिया के यहाँ पर है? जॉर्जिया वाले अटेंडेंस दो. यस, गामरजुबा जॉर्जिया. अरे वाह, मोगेम्बो, सुधांशु, अब्दुल. कॉकरोच जनता पार्टी भी जॉर्जिया से. क्या बात है. चलो 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 चलो, बढ़िया बढ़िया, वेरी गुड वेरी गुड. पढ़ो 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 पढ़ो. यस, गामरजोबा गामरजोबा. मैं जॉर्जियन लैंग्वेज सीख के आ गया. गामरजोबा, मदलोबा. गामरजोबा, मदलोबा. यस, फाइन. सो नाउ कम टू द नेक्स्ट. Okay, so this is the superior colliculus. Remember, at this level, third cranial nerve nuclei and inferior colliculus, below it, fourth cranial nerve nuclei are there. So colliculus are important. Okay, now come to the next. Sir, above it, there is a pineal gland. Okay, so you can see there is only one cranial nerve is there, axon, fourth cranial nerve. So fourth cranial nerve axons are visible here. Okay, so this is the brainstem from the posterior side. This pineal gland is considered as a third eye of the Lord Shiva. Yes, so remember, जटाओं से है बह रहा प्रवाह माते गंग का, गले में जिनके सज रहा है हार विश्व भुजंग का, डमट 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 डमर कह रहा शिवय शिवम, तरल अनल गगन पवन धरा धरा शिवय शिवम. Remember, this is the pineal gland, which is actually located on the back side, represented in between the two eyebrows here. This pineal gland, yes, the true eye of the Agamotto, Hollywood, Bollywood, Tollywood integration. Sir, in this pineal gland, the biochemistry cycle is there. Tryptophan, 5-tryptophan, serotonin, N-acetylserotonin, it is making the melatonin. This is controlling the circadian rhythm, biological clock, and the sleep cycle. The activities which are not controlled by us, yes, they are controlled by the pineal gland. So remember, this pineal gland is very, very important. That's why Lord Shiva doing the Samadhi suspended animation, and he can control his visceral activity. That's why he is Devo Mein Dev, Mahadev, Har Har Mahadev, Jai Mahakal. महाकाल का आशीर्वाद आप सबके ऊपर बने रहे बेटा. आप सभी बहुत अच्छे से परफॉर्म करके आओ. आप एग्जाम क्रैक करोगे. खुद के ऊपर भरोसा रखो, बेस्ट दे करके आना है. आप एग्जाम क्रैक करोगे. अगर यहाँ पर घबराए तो बेटा एग्जाम क्रैक नहीं होगा. भगवान बोलेंगे, तीसरी शक्ति बोलेगी कि आपको फिर से प्रिपरेशन करना. वो नौबत नहीं आनी चाहिए. खुद पर भरोसा करो, अपने टीचर्स पर भरोसा करो, अपने नोट्स पर भरोसा करो, अपने पेरेंट्स पर भरोसा करो. ठीक है, अपना बेस्ट दे करके आओ. यू विल क्रैक द एग्जाम. Okay, so when this melatonin will be useful, sir, in case of the insomnia, it will be used. So medicine and psychiatry use of this melatonin for the insomnia, for the day night shift workers, for the jet lag effect. Getting the point? Okay, yes. Also in the medicine you will see the pineal gland tumor, that is known as the pinealoma. P for posterior part of the midbrain. This is the Perinaut syndrome. आज मेडिसिन में पढ़ा क्या? Perinaut syndrome. Yes, please tell me Perinaut syndrome. So this is a pineal gland. So if there is a tumor in the pineal gland, the superior colliculus is getting damaged, Cajal nucleus is getting damaged. Is it okay? Fine. So when it is getting the Cajal nucleus is getting damaged, so patient is not able to look upside. So patient will look downside. This is known as a doll's eye sign. Can you recall? Okay. Yes. So these are the things. Now this is the all the fact which I told you in the tabular form. Now look here, sir. When you are looking the you can say the midbrain. So in the midbrain, sir, there is one substance which is negro. Here again biochemistry cycle, sir, phenylalanine converting to tyrosine, which is making the dopa, dopa is making dopamine. So this dopa is converting the dopachrome, which is making the melanochrome, and this melanochrome is converting the melanin. Is it okay? Fine. So this is what? This is your yes cycle. Don't forget it. Okay. So this is the pigmented area. So if it is less pigmented, means it is the Parkinson. So yes, in Parkinson, what is happening? Dopamine is decreased. So relative level of the acetylcholine is increased. So for the treatment of the dopamine, pharma and the medicine integration, you have to inhibit, you have to decrease, the acetylcholine level. So anticholinergic or give the drug which are in stimulating the dopamine level. So you will give the dopamine agonist, dopamine facilitated, dopamine precursor, dopamine decarboxylase inhibitor, COMT inhibitor, the MAO inhibitor. Okay, and within the brain, the classical, the pathognomic sign for the Parkinson, you will see the Lewy body. So this Parkinson will be definitely asked in your exam. Do you remember? Son create a problem, daughter never create problem. In your exam, the Parkinson, yes, the Wilson, the Jacobson, the Jefferson, Morrison, any son will be definitely asked. Okay. Okay, sir. So this is the same, the different brain section which I told you. Yes, here one question is asked, that is the medulla. Central elevation is the pyramid, lateral elevation is the olive. Okay. And another midbrain section I told you. Now look, the cerebellum. Only what you have to remember, magic of the 1, 2, 3, 4, 5. Sir, one worm is 2 hemisphere, 3 types of the lobe classification. Yes, there are the 3 histological layer, 4 nuclei, and the, yes, you can say the 5 neurons. Fine. So now catch this one. When you are looking the important point, 3 histological layers. So whenever the fern tree like branching pattern, this is the cerebellum. Yes, it is known as the arbor vitae. It is a tree of the life. So we are using the microscope magnification. So tree fern like branching pattern. So you can see the molecular layer, the Purkinje layer, sorry, and the granular. मैंने छीका, एक क्वेश्चन जरूर आएगा, तुम चीखोगे, वहां से भी क्वेश्चन आएगा. ओके, लेकिन क्योंकि मैं टीचर हूं, मैं गुरुजी हूं, तो मैं चीखूंगा तो ज्यादा इंपॉर्टेंट है. वन क्वेश्चन श्योर फ्रॉम द सेरेबेलम. Okay, sir. Yes, also you can say every question from the cerebellum. Okay, now look here. Sir, there is a molecular layer. Sir, there is a Purkinje layer. There is a granular layer. Are you getting? So this is the largest neuron. Can you see this question had been asked? So molecular layer, Purkinje layer, and the granular layer. So remember the 3 questions from the physiology and the anatomy. Sir, only efferent of the cerebellum, you can say Purkinje. Yes, inhibitory to the deep cerebellar nuclei. Answer is Purkinje. Your formula is a DEGF. Yes, largest neuron of the cerebellum, Purkinje. So these are the 3 important lines from the cerebellum. Okay, now you will see the nucleus. So your formula is doctors eat good food. D for dentate nucleus, E for emboliform nucleus, then G for globose nucleus, F for vestigial nucleus. Otherwise your funny formula is DEGF. DEGF. Okay, so remember, yes, इस dentate nucleus के 2 L लगाने हैं. Fine. So L for lateral motion nucleus and L for largest nucleus. So don't forget this one. Otherwise, तुम्हारे एग्जाम में L लग जाएंगे. So remember this one. Lateral motion nucleus and the largest nucleus. These are the dentate nucleus. Fine. Now come to the next. Sir, there are the 5 neurons. What are the 5 neurons? Sir, their funny formula is the Bahujan Samaj Party, joined by the Goga Sarji. Okay, BSP Goga. Okay, B for basket neuron, S for stellate neuron, P for Purkinje neuron, G for Golgi cells, G for granular cells. Okay, so these 2 are located in the molecular layer. This is only cell located in the Purkinje layer, and these last 2 they are including the granular layer. So इतना ही पढ़ना है, बार-बार पढ़ना है. Okay, now look here. What is the function of the cerebellum? So I told you this story. This story what? Sir, the brain, the corticospinal tract, they are controlling the our body or the bus, and the conductor is helping. Who is the conductor? Cerebellum, basal nuclei, and system. So they are responsible for the coordination and the balance. Fine. So what you can see, if there is a damage to the cerebellum, then there is the loss of coordination, loss of your balance, that is ataxia, and loss of rate, range, direction, force, that is asynergia. Nidra is the formula. So there is a nystagmus, intentional tremor, dysdiadochokinesia, dysarthria, rhomboxine, and ataxia, asynergia. These are all of the condition. So this is all about the cerebellum. Okay. Now we are looking the brain. So when you will see the brain, again, you can observe the beautiful 3-dimensional orientation. Look here. Catch this one. Sir, this is the brain. Two cerebral hemisphere. We are looking one. This is superlateral surface. This is the medial surface. And here is the inferior surface. Three surfaces of the brain. Okay. Now look here. Look further. Fine. So now come to the next. Sir, you can observe this is the medial surface of the brain, this is the inferior surface, and this is the superlateral surface. The two cerebral hemisphere, they are joining the two cerebral hemisphere with the help of the corpus callosum. Okay. So now look here. Sir, on the superlateral surface of the brain, what are the different parts? Sir, frontal lobe, this is the parietal lobe, this is the occipital lobe, and this is the temporal lobe. Okay. Out of the point. Now see, this is central surface. In front of it, there is a Broadman area. Sir, this is the motor area. If it is getting damaged, hemiplegia. One question sure from here. Sure from here. Okay, fine. So this is what one question from the stroke or the transient ischemic attack. So don't forget. Clear? Okay. In front of it, there is area number 6. This is the premotor area. If it is getting damaged, then extrapyramidal clinical feature. Okay, sir. Now, superior frontal gyrus, middle frontal gyrus, inferior frontal gyrus. So there is the superior frontal gyrus 9, 10, 11, 12. This is a prefrontal lobe. If there is a damage, there is the prefrontal lobe syndrome, in which you can remember prefrontal lobe, P for personality. Personality, judgment, behavior, skill, all are lost. Anand Bhai from the Munna Bhai MBS, the prefrontal lobe syndrome. And then you can see this is the area number 8. So it is looking like the eye. This is the frontal eye field area. It is responsible for the conjugate saccadic movement. So you can see NEET PG 2025 question, the scanning movement. The both eyes move in the same direction. It is controlled by the frontal eye field. If it is getting damaged, there is a loss of scanning movement. Now, this is the inferior frontal gyrus. It is responsible for the articulation. So if this area is getting damaged, there is a motor aphasia. Do you remember? Can you recall? Yes. अरे अरे क्या गोलियां चली तुम पे? अरे नहीं रे अबे जल्दी बोल, कल सुबह पनवेल निकलना है। नंबर बोल उसका 9, 8, 2, बस 10 नंबर हो गए। अरे नहीं, अभी तो सिर्फ 3 ही हुए हैं। डू यू रिमेंबर? So Lakshman from the Golmaal 3, the classical example of the Broca's aphasia. Also you can see this is the area number 22. The poshy part is the Wernicke's area. This is the sensory speech area. If there is a damage, there is a sensory aphasia. Yes, you know the Tushar Kapoor from the Golmaal. Yes, you know, that is a classical example of the sensory aphasia. Fluently he will speak, but no sensation, no sense is there, no meaning is there, meaningless speech, fluent speech. Okay, now look here, sir, there is a area number 41, 42, which is the primary auditory area. If there is damage, hearing loss. And there is an area number 22 around it, that is secondary auditory area, which is responsible for the analysis of the heard sound. If there is damage, there is the, yes, auditory agnosia. Do you remember the ENT question? Auditory pathway: E. Colima, E for eighth nerve, C for cochlear nucleus, O for olivary nucleus, L for lateral geniculate body, and I for inferior colliculus, M for medial geniculate body. Sorry, L for lateral lemniscus. Na? This is the medial geniculate body, and A for auditory area. So this is the A for auditory area. This is the auditory pathway. Physiology ENT question. Now in the occipital lobe, sir, this is the area number 17, primary visual area, which is responsible for the vision. If it is getting damaged, then there is a blindness. There is a area number 18 and 19. So this is secondary visual area. If there is a damage, then visual agnosia. Now the sensory area is just behind the central sulcus. If there is a damage, then loss of sensation. Area number 5 and 7, this is responsible for the vibration and stenosis. It is not us. So these are the important area which will be useful in your particular medicine. Transient ischemic attack जरूर एक क्वेश्चन आएगा, स्ट्रोक से क्वेश्चन आएगा. Another funny way, yes, motor aphasia, Broca's aphasia. So remember, the husband, they are having the Broca's, they are speaking, मैं मार्केट गया था लेकिन, yes, this is what, this is a fluent, this is non-fluent, motor aphasia. But wife, they are speaking, मैंने तुमको कितने मार कर, मैं ऐसे जाना है, ऐसे जाना है, लेकिन तुम्हें बात नहीं मारता. Yes, so wife is speaking very fluently. So this is what, this is a sensory aphasia, no sense is there. So don't forget it. Anominal aphasia, when there is a no nomenclature, no, yes, patient will remember everything, but he will forget the name. सब याद आएगा लेकिन नाम याद नहीं आएगा. That is a anominal aphasia. And when the both are found, then it is a global aphasia. Motor plus sensory aphasia is equal to global aphasia. One question from the speech area. Don't forget, na? Fine. Okay, sir. Now the homunculus representation. This is the homunculus presentation. You can see the face and the body on the superlateral surface. And this is supported the middle cerebral artery. Transient ischemic attack and stroke. So if this artery is getting blocked, Yes, patient cannot speak, upper limb is getting paralysis, and this is a medial surface. So here the blood supply by the antecerebral artery, don't forget. So the perineum area and the lower limb is supplied by the antecerebral artery. So transient ischemic attack or stroke, today you studied. If there is damage in this artery, blockage in this artery, lower limb paralysis and उसका खानदान आगे नहीं बढ़ेगा. Yes, the perineum area will not work, the genital activity will not work, the bowel bladder activity will be lost. And the inferior surface, the posterior cerebral artery, this posterior cerebral artery supplying the occipital lobe, so occipital lobe will not work, so there is a visual problem. Now one more thing, sir, this is the central sulcus. Yes, corpus callosum, septum pellucidum, and fornix. Around it, there is a paracentral lobule. So remember this paracentral lobule, P for paracentral lobule, it is controlled with the perineum. So if this area is getting damaged, yes, it is supplied by the antecerebral artery. The medial surface is supplied by the antecerebral artery. So if this artery is getting blocked, then bowel, bladder, and genital activity is lost. So this is what is a, yes, paracentral lobule, antecerebral artery. So it is again important. Fine, clear? Now, blood supply of the brain. Fine. So you can see, sir, there is the internal carotid artery and there is a vertebral artery. These are meeting together and making one circular anastomosis, that is a circle of Willis. Okay. Yes. You can see the two vertebral arteries are uniting and they are meeting together and making the posterior cerebral artery. And here is the internal carotid artery. The internal carotid artery is making the, yes. Very good. दिखाना बेटा, बाद में दिखाना है. ठीक है बेटा. There is an antecerebral artery, this is an interior communicating artery, and this is a posterior communicating artery. So this is the circle of Willis. Okay, fine. Okay, sir. Now the same thing, magic of five. Five components of circle of Willis, five branches of this internal carotid artery. So again, look here. Two vertebral arteries are uniting and they are making the vesicular artery. Now it is dividing into the two posterior cerebral artery. So here's the internal carotid artery. So internal carotid artery is giving the branch, that is the antecerebral artery. It is meeting together with the help of the anterior communicating artery, and on the backside posterior communicating artery. So five components of the circle of Willis. Anterior communicating artery, next antecerebral artery, next internal carotid artery, next posterior communicating artery, and this is the posterior cerebral artery. Yes, these arteries are anastomosing together. Chumma chumma artery. Okay, so remember the song dedicated for this by the Amitabh Bachchan uncle. Yes, chumma chumma de de, chumma chumma de de chumma. अरे जुम्मे के दिन किया चुम्मे का वादा, जुम्मे को तोड़ दिया चुम्मे का वादा, ले आ गया तेरा जुम्मा चुम्मा चुम्मा दे दे. So can you see? These are the two arteries which are kissing together. So this is known as anastomosis. It is very important. Why? Look here. Suppose there is a blockage in this part. Now the blood is going from here, here, and through this anastomosis, it is supplying to the opposite side. Is it clear? Fine. So this is the इंपॉर्टेंस ऑफ द सर्कल ऑफ लिस्ट. चलो एक शायरी हो जाए. शायरी क्या है? रहने दे आसमां जमी की तलाश कर, सब कुछ यही है कहीं और नहीं तलाश कर, हर आरज़ू पूरी हो तो जीने का क्या मजा है, जीने के लिए कम से कम एक कमी की तलाश कर. तो बच्चों याद रखना, हम सभी की लाइफ में कुछ ना कुछ कमी होती है और उस कमी को पूरा करने के लिए हम शिद्दत से, मेहनत से दिन रात लगे रहते हैं, और जिस दिन वो पूरी होती है तो वो दिन हमारी दिवाली, ईद, क्रिसमस से भी बड़ा दिन होता है. बस उसी दिन के लिए हम पढ़ रहे हैं, अपने इस एग्जाम को क्रैक करने के लिए पढ़ रहे हैं. ओके, सो नाउ कम टू द नेक्स्ट. सर, देयर इज द, यस, internal carotid artery. It is giving the five branches. What are the five branches? Sir, this is the anterocerebral artery. Then you can see this is the ophthalmic artery. Sir, this is the middle cerebral artery. And here you can see the anterocarotid artery, and this is the posterior communicating artery. So these are the five branches of the internal carotid artery. Magic of five is important. Yes, five components of circle of Willis, clinical. If there is the rupture, then barionism, it will result to subarachnoid hemorrhage. That is the, yes, worst headache of my life. It will represent the star of death. Why? Can you see, if this artery is getting ruptured, it will take the shape of bleeding in this way. Yes, it is looking like the star. Are you getting why there is a star shaped star of death is seen? Radiology, medicine, surgery, anatomy integration. So elegant, so beautiful, just looking like a wow. Yes. Now come to the next. Sir, these are all the things I told you. Now come to this white matter of the brain. So one white matter is going to ask in your exam. Right now they ask the corpus callosum. So we had seen the gray matter, then white matter, then basal nuclei. Okay. So look here, three types of the white matter. Your formula is ACP, ACP Rathore, ACP Rathore. Okay. Association, commissural, and the projection fiber. Fine. Now look, what is the association which are joining the nearby area? Commissural, which are joining the two different cerebral hemisphere, and projection, which are projecting from inside to the outside, outside to the inside. These are the projection fiber. Remember, all the tracks are projection fiber. Okay, sir. Now look, the corpus callosum, the FMG 2026. Sir, this is the largest band of the white matter in the brain. It is having the rostrum, genome, trunk, and the splenium. So your funny formula is the RTGS. मैं तुमको अपना अकाउंट नंबर दूंगा, उसमें RTGS कर देना. Okay, rostrum, then genome, then trunk, then splenium. Okay, so this corpus callosum had been asked in your recent exam question. So remember the formula CSF, then THP, then MPM, and then VOT, which is not shown. Yes, this is cerebellum. Fine. So mark this question. C for corpus callosum, C for commissural fiber. Yes, it is the largest band of the white matter in the brain. Right, sir. Now, fornix. So within the brain, there is a one very small structure, sir, that is the fornix. Here is the hippocampus. Remember, hippocampus is the site for the short-term memory conversion to the long-term memory. Yes, this hippocampus was damaged in the Sanjay Singhania uncle. So he forgotten to the Kalpana auntie. Hollywood, Bollywood, Tollywood, all are arising from the anatomy. So remember, hippocampus is the site for the short-term memory conversion to the long-term memory. And if it is getting damaged, then Gajini movie is there. Okay, short-term memory loss. Now look, sir, hippocampus, due to the fornix, it is sending the fiber into impulse into the fornix, then to the mammillary body. So remember, this is the hippocampus. Now this is the posterior column of the fornix. They are uniting and they are making the body. Now they are dividing into the anterior column and reaching to the mammillary body. Yes, close to it there is the amygdala also. So remember this fornix. One fact: all type of the fibers, ACP Rathore, who is the real Rowdy Rathore? Fornix is the real Rowdy Rathore because it is in the association, commissural, and projection, all the three types of the fiber. So this fornix is important. Okay. Now look, this is a Pappy circuit. Just one funny formula: A, Chale, Himachal, Manali. Yes, A for anterior nucleus of thalamus, C for cingulate gyrus, then hippocampus, then mammillary body, then again anterior nucleus of thalamus. So in this pathway, the hippocampus is there. So when you will run this pathway again and again, your short-term memory will be converted to long-term memory. And here there is a cingulate gyrus. This is the satisfaction center, pleasure center. So whenever we are doing the food or whenever we are doing the sex, after that there is a satisfaction and pleasure. Why? Due to this cingulate gyrus. So when you are doing any activity again and again, again and again, again and again, again and again, you are joining the CBI anatomy classes. First time enjoyed, second time enjoyed, third time enjoyed. So you are enjoying the study again and again, again and again. Your short-term memory is converted into the long-term memory and you are getting satisfaction, you are getting the pleasure, and now you will perform very well in the exam. So this is a Pappage circuit. Don't forget, the questions may be asked from the physiology. Okay, fine. Okay, sir. Now come to the next. Sir, now we are looking for the basal nuclei. So what are the parts of the basal nuclei? Yes, remember ACC, cement and stainless steel. A for amygdala, C for corpus callosum, C for claustrum, S for substantia nigra, and S for subthalamic nucleus. Is it okay? This amygdala is very small almond-like structure which is controlling the food and sex activity. So if there is a damage in the amygdala, there is a hyperphagia and hypersexuality. You can see this image. Yes, इस बिल्ली ने डॉग को नहीं छोड़ा. ये बिल्ली इतनी खतरनाक है कि वो बंदर को भी नहीं छोड़ रही है. सो दिस इज व्हाट दिस द यस हाइपरसेक्सुअलिटी, यस हाइपरफेजिया. तो तुम्हारे दोस्तों में अगर कोई बहुत खबड़ू हो, बहुत खाता हो, समझ जाओ उसको आधा क्लोवर-बुशी सिंड्रोम है. और अगर ये भी मिल गया तो पूरा कंप्लीट क्लोवर-बुशी सिंड्रोम है. दिस इज द क्वेश्चन इन द एफएमजी 2021. हाइपरफेजिया एंड हाइपरसेक्सुअलिटी, दिस इज नोन एज क्लोवर-बुशी सिंड्रोम. ओके फाइन. अब अपना अपना तुम जान लो भाई. ठीक है. What you have to remember, Hollywood, Bollywood, Tollywood, all are from the anatomy. So the song over this almond-like structure, that is the amygdala. Amygdala is almond-like structure. So the song dedicated for it again. अर्ज किया পায়ের তোড়া হাতের বালা থাকে যোগী সিটি গোল্ডেন চেন দিয়ে জবেন তাতে সমান সমান দাদা কাঁচা বাদাম ও বাদাম বাদাম দাদা কাঁচা বাদাম. So this is a funny way to remember this amygdala. FMG 2021, the students told us, sir, जब ये क्वेश्चन आया तो हमको आपका वो गाना याद आ गया and we solved the question. So remember बेटा, when you will enter in the exam hall, आपको एनाटॉमी के हमारे जोक्स याद आएंगे, हमारे कॉन्सेप्ट याद आएंगे, आपको हमारे ये बोले हुए जो ट्रिक्स निमोल से याद आएंगे और आप एनाटॉमी को क्रैक करके आओगे. If you are joining all the sessions, yes, so definitely you will crack the exam. Okay, जस्ट इंजॉय करो बेटा स्टडी को. फाइन. अगर आप किसी भी चीज को इंजॉय करते हो तो वहां परफेक्शन से कोई चीज नहीं रोक सकती. नाउ कम टू द कॉर्पस स्ट्राटम. कॉर्पस स्ट्राटम is having the two part, caudate nucleus and the lentiform nucleus. Caudate nucleus, sir, it is having the very long tail. So it is having the head, it is having the body, and it is having the tail. At the tail there is a amygdala, and within the concavity you can see the thalamus. Is it okay? Now catch. Lentiform nucleus, it is a lens-shaped nucleus. Lateral part is a potamen, तूने चुराया मेरा दिल का चैन. Yes, and medial part is a globus pallidus. Okay. Now, if there is a damage in this lentiform nucleus, that is a lenticular degeneration. Yes, in this disease, liver is also involved. That's why it is a hepatolenticular degeneration. In this disease, there is the accumulation of the copper. Yes, it is nothing. It is a Wilson disease. So remember, chromosome number 13 mutation, ATP7B gene mutation. Yes, ceruloplasmin is decreased. So copper is getting accumulated. Copper is excreted through the urine. Copper is accumulated in the lentiform nucleus. That's why Parkinson-like feature. Copper is accumulated in the limbal area, Kesher-Fleischer ring. Copper is getting accumulated in the skin, bronching of the skin. Yes, in the gonads also. Yes, also you can see it is getting involved in the liver. That's why hepatolenticular degeneration. Khatam, tata, bye bye gaya. One question from the Wilson disease, Parkinson disease. Son create problem, daughter never create problem. So this is one funny way how you can remember. And now the subthalamic nucleus, there's a damage in the subthalamic nucleus. It will result into the hemiplegismus. Yes, there is a projectile throwing movement of half of the body. That is a hemiplegismus. Okay, so these are the things which you have to remember. Now come to this brain section. But एक question brain section से जरूर आएगा. Fine. So look here. This is the coral section. So your formula is it C S F. Corpus callosum, septum pellucidum, fornix. Then at the middle line there is the third ventricle. On the each side of the third ventricle, sir, this is the thalamus. Yes. Now see M P M, midbrain, pons, medulla. Within the midbrain, this substance which is negro, substantia nigra. Sir, the septum pellucidum is the septum between the two lateral ventricle. So the floor of the lateral ventricle is formed by the caudate nucleus, head of the caudate nucleus. And now you can see, sir, from the cortex, the fibers are going to the spinal cord. So this is the cortico-spinal tract. So it is making the, yes, fan-like, radiation-like fiber arrangement. So this is the corona radiata. Yes, it is passing lateral to the thalamus and making the inside capsule, internal capsule. Sir, there is one part of the brain which is sleeping inside, in a sula. In a sula. This part of the brain is sleeping inside, in a sula. Just one way to remember, no? Clear? Okay. Now see, sir, there is a fifth lobe of the brain. This fifth lobe of the brain is also known as the hidden lobe of the brain, which is known as sixth lobe of the brain. Sir, limbic lobe is known as the sixth lobe of the brain. Is it clear? Done. Now apply the same thing in the radiology. Radiology is nothing, it is the shadow of the anatomy. So again, scalp, skull, gray matter, white matter. So you can see the C, the S, then F. Corpus callosum, septum pellucidum, fornix, then thalamus. In between the two thalamus, this is the third ventricle. Then can you see M, P, M? Sir, midbrain, pons, and then medulla. Sir, this is septum pellucidum. On each side, there is the lateral ventricle. The floor of the lateral ventricle is formed by the caudate nucleus. Right, sir. Now catch. Sir, again, compare with the anatomy. Cortex to spinal cord. So cortex spinal tract making the coronary radiata, and then lateral to the thalamus. This is the internal capsule, which is going to the medulla part. And this is the hidden lobe of the brain, insula. Yes, this lateral part of the thalamus is the internal capsule. I think it is very easy. Nothing you have to do. Just correlate the anatomy and the radiology. So elegant, so beautiful, just looking like a wow. आहा एनाटॉमी बड़ा मजेदार, वह एनाटॉमी बड़ा मजेदार। एक दिन श्रीकांत सर ने पढ़ाया, एनाटॉमी हमें समझ में आया। आहा एनाटॉमी बड़ा मजेदार, वह एनाटॉमी बड़ा मजेदार। यस बेटा देखो, पढ़ने का नजरिया बदलो। ठीक है। पढ़ाई लिखाई बहुत बोरिंग काम है, बहुत घटिया काम। दुनिया का सबसे घटिया काम अगर है तो क्या है? पढ़ाई लिखाई। लेकिन पढ़ना तो पड़ेगा, चाहे या तो हंस के पढ़ो चाहे रो के पढ़ो। तो जब पढ़ना ही है तो एक काम करते हैं, हंस के पढ़ते हैं, खुश होकर पढ़ते हैं। क्योंकि अगर हम खुश होकर के कोई चीज को करते हैं तो हम ज्यादा उन चीजों को कैप्चर कर सकते हैं, ज्यादा उसमें हम स्किल ला सकते हैं और हम दुनिया में और आगे निकल सकते हैं। तो पढ़ना तो पड़ेगा भाई। ओके, तो बेटा यस, पढ़ाई लिखाई बहुत घटिया चीज है, बहुत बुरी चीज है। लेकिन जब पढ़ना है तो रो के पढ़ना है या हंस के पढ़ना है? तो एक काम करते हैं, हंस के पढ़ते हैं। ओके, यस। सो नाउ कम टू द नेक्स्ट। Okay, another section. Can you see? Sir, this is the transverse section. Fine. So what you have to see? So this is gray matter, this is the white matter, and this is a corpus callosum. So CSF, yes sir, corpus callosum, septum fornix, and the narrow cavity is the third ventricle. So any part which is having on each side, sir, that is the what? That is a thalamus. Is it clear, beta? Now look here, the concavity on the lateral side of the thalamus. This is the boomerang shaped structure, sir. This is the inside capsule. This is the internal capsule. Yes, sir. Now this is the lens shaped nucleus. That is the lentiform nucleus. Lateral part is the putamen and medial part is the globus pallidus. Okay, sir. Sir, this is the lateral ventricle. The floor of the lateral ventricle is formed by the caudate nucleus. And laterally you will see eyes. This is the hidden lobe of the brain, insula, then claustrum, and then thin white matter strip. That is the external capsule. Is it okay? Now just correlate with the radiology. Can you see? Radiology is nothing, shadow of the anatomy. So can you see? Sir, there is a scalp, there is a skull, there is a gray matter, there is white matter. So you can see the CSF. Yes, you can see, sir, this is the lateral ventricle. The floor of the lateral ventricle is formed by the caudate nucleus. At the midline, there is third ventricle. On each side of the third ventricle, sir, there is thalamus. And here you can see the inside capsule, the internal capsule. And laterally, you can see the lens-shaped nucleus, lentiform nucleus. Medially, there is a globus pallidus, and laterally, there is a putamen. And here is the insula. Then you can see the claustrum, and then you can see the external capsule. Is it clear? Easy, right? So now we are going to face with the PYQ PYTs of the neuroanatomy. So they are asking about the speech area, Wernicke's area. They are asking about the corpus callosum. Yes, they are asking about the touch, which is responsible for touch, fifth cranial nerve. So cranial nerves are very, very important. Now they are asking on the Bell's paralysis. Okay, fine. Now they are asking about the again Bell's paralysis. Bell's paralysis is very important. Yes, they are asking again about the tract, vestibulospinal tract. They are asking about the yes dysdiadochokinesia, cerebellum. One question from the cerebellum. Okay. Yes, then they are asking about the speaking fluently problem there. Again, speech is important. Okay, now come to the next. Sir, they are asking about the 3S illidas. Yes, it is your layers pierced during the lumbar puncture. They are asking about the internal capsule, radiology image. Yes, they are asking about the P for paracentral lobule, P for perineum area. So, broadband area of the brain. They are asking about the yes spinal cord L3 level in the newborn, it is ending. Yes, they are asking about the cadaveric section, pyramid, and this is the olive. Okay, now they are asking about the spinal cord ending in newborn at which level? L3 level. Yes, they are asking about the dermatome. I will teach the dermatome. The grade 2 is supported by the L4. So now we are going to start the upper limb portion. Are you ready for the upper limb? Okay, so now we are going to look for this upper limb. ओके, एक छोटा सा ब्रेक कर ले बेटा, ब्रेक फॉर द 5 मिनट्स, क्योंकि इसके बाद कोई क्लास नहीं है. ठीक है, कोई क्लास नहीं है तो विदाउट टेंशन वी कैन डू. सो टेक अ ब्रेक, देन वी कंटिन्यू. थैंक यू. Hello everyone. Can we continue the session? If you want to get extra, you have to do extra. If no pain, no gain. If you want to shine like a sun, then first you have to burn like a sun. So dear friends, अभी जो हम लंबी लंबी क्लासेस कर रहे हैं, इससे तकलीफ तुमको होगी, मुझे भी होगी, लेकिन आज हम तकलीफ झेलेंगे, आज हम दर्द झेलेंगे। तो जिस दिन रिजल्ट निकलेगा उस दिन खुशियों भरा माहौल रहेगा। ओके, और उस दिन हमारे जो पेरेंट्स हैं जो खुश होंगे, उनकी आंखों में जो आंसू आएंगे, वो हमारी जिंदगी का सबसे बड़ा मेमोरेबल डे होगा। तो उस दिन के लिए, उस खुशी के लिए, अपने पेरेंट्स के लिए चलो अब हम फिर से स्टार्ट करते हैं अपने इस सेशन को। यस, दिस पोर्शन ऑफ द अपर लिम्ब, the 50% of the syllabus, the head, neck, face, and the neuro part we completed. Okay, so now look at the bones of the upper limb. Yes, these all the things I'm going to cover with the beautiful three-dimensional orientation. ये सारी चीजों को मैं आपको 3D में शो कर रहा हूँ. So look here again, lal full, nila full, anatomic, beautiful. How you can see here. Look for this one, sir. The upper limb part. Sir, this is the beauty bone, the clavicle, which is having the medial 3/5 and lateral 2/5 part. Yes, this is the shoulder blade, the scapula. Okay, so now look at this is the funny bone, the humerus. What are the important things? I will tell you one by one. This is the preaxial bone, the radius. This is the postaxial bone, the ulna, and then you can see the carpal bone. So you can see, sir, she looks too pretty. Try to catch her. Scaphoid, lunate, triquetral, pisiform, trapezium, trapezoid, capitate, hamate, and then 5 metacarpal, then phalanges are there. Okay, so you can observe here. Sir, what are the important questions from here? Sir, one another mnemonic, Sham, Lal, टिंडे पकाओ तुम्हारे टिंडे कच्चे हैं. Otherwise, one romantic mnemonic, some lover try position that they can't handle. Okay, sir, questions. Is for most common carpal bone getting fracture. Next question. Second most common bone getting avascular necrosis in the body. Next question. Floor of the anatomical stump box is formed by scaphoid. Glass holding cast is used for the scaphoid bone. So these are the MCQs. Agree? Now come to the next. Sir, lunate, only one question. Most common carpal bone which is getting dislocated. Yes. Next question, pisiform. Sir, it is the seed-like bone, sesamoid bone, which is ossified in flexor carpi ulnaris. Sir, large carpal bone to ossify pisiform. Next, the important question, sir, capitate. It is the first carpal bone which is getting ossified. So this is the largest carpal bone. Remember, the last carpal bone to ossify, that is the smallest carpal bone, means the pisiform. So these are the important MCQs. Now, the muscles of the upper limb. These all the things are list. Now I'm going to tell you. Yes, in the cadaveric image based. Last time we did the proper practice with the 3D also, but this is the revision session, so we are going to look directly the questions. So hybrid muscle, the threesome muscle, you can see the hybrid muscle of the upper limb. The form is the Bahujan Samaj Party joined by the Phupa. Yes, Mr. Brachialis. It is having the double nerve supply, M for muscularis and R for radial nerve. Then subscapular, it is having the upper and the lower subscapular nerve. Sir, pectoris major, pectoris minor, so lateral and the medial pectoral nerve. Sir, flexor profundus, so there is an anterior nerve and the ulnar nerve. Yes, flexor posterior, two nerve supply, median nerve and the ulnar nerve. So these are the hybrid muscles of the upper limb. Important. Next, look here further. Sir, this is the cadaveric image for the pectoral region. So four muscles. Do you remember? Pectoris major, pectoris minor, subclavius, and serratus anterior. So you can see this is the clavicle, this is the sternum. So here's one big muscle on the pectoral region. So this is the pectoris major, which is having the lateral and medial pectoral nerve. Sir, it is the climber's muscle. Sir, this is the extensor at the shoulder joint. This is the spiral and twisted muscle. Sir, it is the most common muscle which is congenitally absent in the body. And this congenital absence of the pectoris major is known as the Poland syndrome. These are the MCQs. इससे बाहर का कोई क्वेश्चन नहीं आएगा, इतना ही करना, बार बार करना है. Is it okay? Now, on the chest, on the lateral side, this is the zigzag muscle, serratus anterior. Sir, over the shoulder, there is a delta shape muscle, deltoid muscle. Sir, this is a funny bone, humerus. So you can see one groove between the deltoid and the pectoris major. This is the deltopectoral groove. Yes, it is below the clavicle, so that's why it is the infraclavicular fossa. Okay, sir, this space is filled by the one fascia, that is a clavipectoral fascia, which is pierced by the fourth structure. You can remember the formula TALC. T for thoracoabdominal artery, 2L lateral pectoral and the lymphatic, and C for cephalic vein. Okay, now come to the next. When we are cutting the pectoris major, then you can see below the clavicle, sir, this subclavius muscle, and below the pectoris major, this pectoris minor muscle. So remember, the pectoris minor is pierced by the medial pectoral nerve. This is a NEET PG 2024 question. And this is the clavipectoral fascia, which is pierced by the lateral pectoral nerve. MCQ. Now we are looking at the deep. Sir, this is a serratus anterior. This serratus anterior is located on the lateral side. So when it will contract, it will cause pushing and punching action. So look at this image. Sir, this is a transverse section of the thorax. So this is the sternum. This is the vertebra. So this is the rib. So here you can see the scapula. Sir, serratus anterior is taking origin from the lateral part of the rib and getting insertion into the medial part of the scapula. So if this muscle is getting paralysis, the medial part of the scapula is getting elevated, which is known as the winging of scapula. Very, very important question. And you can observe, sir, laterally it is articulated with the humerus. So when this muscle will contract, apply the law, where muscle goes, there movement flows. It will protrude, it will move the scapula forward, it will move the humerus forward. So the forward movement of the scapula known as a protraction. It is causing pushing and punching action. That's why it is the boxer's muscle. Remember the 2B, B for boxer, B for Bell's nerve. Sir, it is having the nerve supply Bell's nerve. Yes, it is supplying in the thorax with the long course. That's a long thoracic nerve. So if this nerve is getting damaged, then there is a winging of scapula. Now see, one funny way to remember this protraction retraction. Hollywood, Bollywood, Tollywood, all are rising from the anatomy. So you can observe here, so protraction retraction. So dhak dhak karne laga, dhak dhak the Madhuri auntie. She's doing dhak dhak. Protraction, it is done by the serratus anterior and pectoris minor. And backward movement, that is a retraction. Trapezius, rhomboid major and rhomboid minor, they are doing the retraction. Is it clear? Agree, everybody? Fine, sir. So these are the facts which you have to remember. Now we are looking the back area. So in the back area, 5 muscles. What are the 5 muscles? Trapezius, latissimus dorsum, and then you will cut it. Then you will see the levator scapulae, rhomboid minor, rhomboid major. Yes, 1, 2, 3, 4, 5. So look here, the trapezius. Sir, upper fiber will cause shrugging of the shoulder, middle fiber will cause retraction, and lower fiber will cause the overhead abduction along with the serratus anterior. Sir, this is the scapula and here is the latissimus dorsi. So one triangle is formed. One triangle is formed here. So you can see this is the triangle of auscultation. What are the boundaries of the triangles of the auscultation? Medial border is formed by the trapezius. Lateral border is formed by the scapula. And the base is formed by the latissimus dorsi. Nothing you have to do. जो दिख रहा है वो बोलना. Whatever you're looking, you have to observe, you have to say. Okay. Now, when we are cutting, there is the levator scapulae, rhomboid major and rhomboid minor. Which nerve is running here? Sir, dorsal scapular nerve, root value C5. जो नर्व जहां रहती है, जहां बहती है, उसे सप्लाई करती है. So this particular, yes, 3 muscles are supplied by which nerve? Answer is the levator scapulae. Is it okay? Yes. Now, catch this one. Sir, on the back, there is one very big wide muscle. This is the latissimus dorsi. Sir, this is the extensor at the shoulder. Sir, it is a climber's muscle. Sir, the latissimus dorsi and pectoris muscle both are twisted and spiral muscle. Both are, yes, extensor, both are climber's muscle. But if one answer you have to opt, then latissimus dorsi. Extension is done during the swimming activity. So this latissimus dorsi is also known as a swimmer's muscle. Okay. Now, when we are looking backside, very big muscle is observed. Yes, this is the lata dorsi muscle. Lata means white, dorsi means back. This is the best muscle for the muscular graft. So it is used for the mastectomy operation. Yes, now supply thoracodorsal nerve. Remember, it is the best muscle. Give the best number 786. 786, yes, Bismillah. अल्लाह के नाम से शुरू करता हूं. अंतलहादी अल्लाह हौसलहादी या अल्लाह गोप्य वल्लभ राधे श्याम जान की जीवन सीताराम. So remember 786 means C6, C7, C8 is the root value. Don't forget this formula. And there is an extra oblique muscle, EO muscle. So there is one triangle is formed here. This triangle is known as the lumbar of the petit. So the medial boundary is formed by latissimus dorsi. Lateral boundary is formed by the extra oblique muscle, and the base is formed by the iliac crest. Yes. In old age, in weakness of the muscle, the intestinal loop can come out from here. So this is a lumbar hernia. So remember, this is important for the surgery. Hope you did the surgery. Surgery में बताइए फिर से आएगा. याद रखना, anatomy में हमने एक learning की है. Okay. Now come to the next. Scapular region. Sir, there is a delta shaped muscle, deltoid, and then SIT, sits muscle. Sir, supraspinatus, infraspinatus, and teres minor, not the teres major. And then subscapularis. These all are making the rounded cuff around the shoulder joint. So these are known as the, yes, you can say the rotator cuff, These are the muscles, then become tendinous, that's why muscular tendinous cuff, and then also it is giving stability, that's why dynamic stabilizer of the shoulder joint. Okay, now when you will see the cadaveric image from the back side, you can see the spine. Above the spine, supra spinatus, below the spine, infra spinatus. This is a teres minor. Here you can see the teres major. This is longer the triceps. Yes. So in between this muscle, can you see one triangle, one quadrangle, and another triangle? So these are the interscapular space. So catch this one. You can remember this one with the fingers. Do this two finger, do the another two finger. So now cross it. So you can see, sir, quadrangular space and two triangular space. Okay. So you can observe the upper triangular, lower triangular, and the quadrangular space. What is important? Sir, in the quadrangular space, the main cutter is the axillary nerve. So if there is a fracture at the neck of the humerus, axillary nerve is getting damaged. Sir, the lower triangular space, the main content is the radial nerve. So if there is a fracture of the shaft, the radial nerve is getting damaged. And now when you will see the scapula from the front, yes, you will be able to observe, sir, this is the thin muscle, supraspinatus. Because it is thin, that's why it is the most common muscle which is getting injury in the rotator cuff. And there is one very thick muscle, sir, this is the subscapularis. So this subscapularis, yes, it is a multipenetrating muscle. It is having the double nerve supply. Sir, it is the least commonly injured muscle in the rotator cuff. It is the forgotten muscle of the rotator cuff. Got the point? Okay. Now see the bursa. Yes, we sung the song over the bursa. Tip tip bursa pani, mohabbat bursa dena tum ki sawan aaya. Yes, in this funny way we learned. So bursa is a small sinus pouch separate from the main cavity. It is responsible for the shock absorption. Yes, for the cushion activity, this all. So there is the one bursa just to do the acronym process. Sir, this is a subacronym bursa. So inflammation of this subacronym bursa is the subacronym bursitis, which is characterized by the Dobbin sign. So if any patient is doing the adduction and pain present, and when doing the abduction and pain is absent, then this is the positive Dobbin sign. It is indicating the, yes, subacronym bursitis. Is it clear? Right, sir. There is one more sign, na? That is a impingement syndrome. What you have to do, sir? 0 to 60 degree, no pain. 60 to 120 degree, pain. Now 120 to 180 degree, no pain. So 60 to 120 degree, the pain. This is a painful arc syndrome. That is a painful arc syndrome. Agree? Impingement syndrome. That is a different condition. Now this is the Popeye sign. There is a fracture. There is the rupture of the longer the biceps. So this is the one very interesting sign, Popeye sign. Yes, rupture of the longer the biceps. Now look here, entry compartment. So in that entry compartment, BBC, biceps brachii, brachialis, and coracobrachialis, which is the nerve musculocutaneous. So all are supplied with the musculocutaneous nerve. On the back side, only one muscle, triceps. Yes, which nerve? Radial nerve. So these all are supplied with the, yes, radial nerve. Again, you can see the cadaveric image, clavicle, subclavius, pectoralis minor, coracoid process. On the lateral side, zigzag muscle, serratus anterior, supplied by Bell's nerve. So on the back side, latissimus dorsi, supplied by thoracodorsal. Yes, over the shoulder, you can see deltoid muscle. Longer the biceps, shorter the biceps. This is the biceps muscle. Rupture of this long head, it will result into the Popeye sign. One muscle from the coracoid process ending into the brachium, sir, that is the coracobrachialis. Next, sir, on the posterior side, only one muscle, that is the triceps. Sir, over the shoulder, deltoid. So one is the long head, another is the, yes, lateral head. Medial head is at the down, on the depth. One nerve is there, radial nerve. Sir, these are getting insertion into the olecranon process. Are you getting the point? Okay, fine, sir. Now look, there are the different signs. In the orthopedics, I created one mnemonic for all of you. Mahatma Gandhi ki lathi. M for medial, G for golfer's elbow. Medial epicondylitis is the golfer's elbow. L for lateral epicondylitis, T for tennis elbow. Is it okay? So medial epicondylitis is the tennis elbow. Lateral epicondylitis is the golfer's elbow. We remember, man plays golf. M for medial, yes, M for man. And L for ladki, L for lateral epicondylitis, tennis elbow. I also told you the olecranon bursitis, which is also known as the student's elbow, minor's elbow. Yes. And one more condition, the pulled elbow. Fine. Ortho mein aayega beta. This is also known as the nurse-made elbow. Goal, goal, rani, itta, itta, pani. The head of the radius is coming out through the annular ligament. So this is a pulled elbow. Yes. And now we are going to look for the cubital fossa. So look here, triangular depression in front of the elbow joint is known as the cubital fossa. Is it okay? जाग रहे हो कि सो रहे हो? मजा आ रहा है कि नहीं? मजा आ रहा है तो चलो दिल उड़ा दो। यस 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 यस, ये देखो बच्चों, कितने सारे, तुम अकेले नहीं पढ़ रहे हो ना। कमेंट से पता चलता है, इमोजी से पता चल रहा है कि कितने सारे लोग पढ़ रहे हैं। फाइन। Okay, sir. So now can you see the cubital fossa? This is the medial epicondyle. This is the lateral epicondyle. And here is a brachium to the radius one muscle. This is the brachioradialis. Here is the pronator. So this triangular muscular depression is the pronator, yeah, cubital fossa. Getting the point? So just catch this one. Sir, here और भी पढ़ना है बेटा, है ना? हिरना थोड़ा स्टेबल, फिर पढ़ने बैठना, फिर सुनना है, ठीक है? चलो sir, this is the lateral border. Lateral border is formed by the brachioradialis. Sir, medial border is formed by the protectoris. Sir, the apex is formed by the meeting point, and the base is formed by the, yes, imaginary line which is passing through the medial and lateral epicondyle. Okay. Now, what are the content? Very easy. M, B, B, R. M for median nerve, B for brachial artery, B for biceps tendon, R for radial nerve. Okay, now when you will remove these things, then you will see the content. Sir, brachialis, supinator, they are making the flow. So BSF is your formula. Border security force is your formula. Sir, radial nerve, it is having the superficial branch and deep branch. Sir, this deep branch is known as a posterior interosseous nerve. Important. Okay. Now come to the next. Okay. Further. Sir, Varum and Valgum. So Ritik Roshan is also the CB agent. When I taught this topic, he opted this one and he became the very good dancer. So whenever you will see the joint is coming close, joints are getting gum, then it is a valgum. This is a genu valgum. Yes. And when there is a rum means outside. So this is genu varum. And when the both joints are together, then it is a wind sweep deformity. Sir, it is the vitamin C deficiency. This is the vitamin D deficiency. Yes, this is the wind swept deformity. Sir, junior NTR sir is also the CBI agent. Okay, sir. Now catch this one. Welcome, where I told you. In the similar way, in the upper limb. Can you see when the joint is coming close? Gum, valgum. This is a cubitus valgum. And when the joint is going away, that is a cubitus varum. Normally, there is a carrying angle which is 13 to 17 degree. It is more in the female. Okay. Yes. This is the cubitus varus condition. Very important. Yes, this is the gun stalk deformity found in case of the supracondylar fracture. Okay. Now, again, entry compartment forearm. So during the class, we had drawn this image. Yes, Preeti and Kabir, they are also the CBI agent. I had drawn during the regular class by making lining over the hand. Okay. So look here further. Sir, this is the medial epicondyle. Catch here. The first muscle in the entry compartment, flexor compartment, pronator teres. Next muscle from the flexor point going to the carpal bone towards the radial side. Sir, flexor carpi radialis. Next muscle is going to the palm and it is very long. So palmar is longest. Yes. Next muscle is going to the digit, 4 in number. So flexor to the digit digitorum above, that's a superficialis. And last muscle is going towards the carpal bone, towards the ulna, flexor carpi ulnaris. It is a seed-like bone, smart bone. So these all muscles are supplied to the median nerve, but this is supplied to the ulnar nerve. Why? जो nerve जहां रहती है, जहां बहती है, उसे supply करती है. Second CBI magic. But on this side, sir, there is an ulnar nerve. So ulnar nerve will supply this particular muscle. Is it okay? Clear, beta? Fine. Right? Now look further. Sir, on the lateral side, cadaveric image practice brachioradialis, the pronator teres, they are making the boundaries of the cubital fossa. Now any tendon which is going to the carpal bone towards the radius, flexor carpi radialis, any muscle which is towards the ulna, flexor carpi ulnaris, and in between them there is a flexor digitorum superficialis. Okay. Now we are looking the more muscle. Sir, the muscle which is going to the thumb, flexor pollicis longus, the muscle which is going towards the digit, flexor superficialis. What is the ulna, flexor carpi ulnaris? Yes, there are the 3 deep muscles in the entry compartment. Whatever I'm teaching, everything is in the tabular form. Yes, protector the brother of it, pronator quadratus. Sir, flexor digitorum superficialis, the brother of it, flexor profundus. And one more for the thumb, flexor pollicis longus. These are the deep muscles, so they are supplied by the deep branch of the median nerve. But exception are there. Sir, the flexor digitorum profundus is the hybrid muscle, which I taught you. And the also remember the medial half is supplied by the ulnar nerve. Latter part by the deep branch of the median nerve, that is the entry interosseous nerve. Okay. Now we are looking the posterior compartment. See the cadaveric image. quadrangular muscle. So this is protractor quadratus. Can you see the radius? Can you see the ulna? So there is the one membrane, interosseous membrane. So in front of it, anterior interosseous nerve and vessels are there. Is it okay? Clear, everybody? Next, we are looking for the posterior compartment of the forearm. So here, abe sale muscle, ABE. A for anconius, B for brachium to the radius, and then E for extensor carpi radialis longus. These all muscles are not supplied by the pin. They are directly supplied by the radial nerve. So this is important question. Yes, anconius only one question. This is the screwing muscle. Now, the other muscle, all other muscles are supplied by the posterior interosseous nerve. Okay. Now, catch. Sir, there is an extensor carpi radialis, but it's small muscle, brevis. Next muscle is coming from the extensor point and it is going to the digit. So this is the extensor digitorum. Next muscle is coming from the same point and going to the little finger, pinky finger. So this is the extensor carpi ulna side. That's why ulnaris. Last muscle is going to the yes ulna side. That's why extensor carpi ulnaris. And if it is going to the little finger, then extensor digitium. If you see the cadaveric image, again any muscle which is dividing into the multiple tendon, extensor digitorum. Any muscle which is going towards the ulna side, extensor carpi ulnaris. Little finger, then extensor digiti minimi. Okay. Now, hand muscles. Can you see? This is the palmaris longus tendon which is making the triangular aponeurosis. This is the yes palmar aponeurosis. Towards the thumb, thenar muscles. Towards the little finger, hypothenar. जो नदी जहां रहती है, जहां बहती है, उसे सप्लाई करती है. Sir, he is a median nerve. So all thenar muscles are supplied with median nerve. Here is the ulnar nerve. So all hypothenar muscles are supplied with the ulnar nerve. Simple way. Now see. Sir, we had seen the wrist cut injury, forensic medicine integration. So Aishwarya auntie is cutting the wrist in हम दिल दे चुके सनम मूवी. यस, रिमेंबर बेटा, सच्चे प्यार की क्या परिभाषा है? जो प्यार अधूरा रह जाता है वो सच्चा प्यार कहलाता है. जो प्यार पूरा हो जाता है उसे तो हम हवस कहते हैं. ओके, सो द ट्रू लव डन बाय द Salmon boy. Try to understand further. Sir, whenever we are doing wrist cutting, so 5 structures are getting injured. What? Sir, wrist cut injury. Sir, there is a flexor retinaculum. 5 structures are passing above it. First is palmaris longus. Then there is a ulnar nerve, ulnar artery. Then cutaneous branch of the median nerve, cutaneous branch of the ulnar nerve, cutaneous branch of the ulnar nerve and the median nerve. So if there is a wrist cut injury, because these are superficial. Okay. Fine. So these structures are getting cut. That's why this is known as these are the superficial structure above the flexor retinaculum. Okay. The median nerve is passing below to it. That is the carpal tunnel syndrome, carpal tunnel part. Right, sir? Now, look here. Fibrosis of this palmar aponeurosis is known as a dupuytren's contracture. The most common site is the medial half of the hand. Most common finger is the ring finger. ऐसे लोग engagement नहीं कर पाते, डायरेक्टली शादी करते हैं क्योंकि उनका ring finger yes ऐसा हो जाता है. Is it okay? Now come to the next. Short intrinsic muscle of the hand, very very important. Catch this one, sir. There is the muscle which is above flexor digit above. That's a superficialis. But deep to it, another muscle, flexor digitorum deep. That's a profundus. Is it okay? One muscle is going to the thumb. That's a flexor pollicis long muscle longus. Sir, the tendons are arising from the flexor profundus. So these are the L1, L2, L3, and L4. L1, L2, L3, L4. First lumbrical, second lumbrical, third lumbrical, fourth lumbrical. Okay. Now again, first lumbrical and the first lumbrical, second lumbrical, they are unipinnate, supplied with the median nerve. Sir, third and fourth lumbrical, they are bipinnate, supplied with the ulnar nerve. Right? Very important, now. And what is the function? These are responsible for the pain holding position, Babaji Katulu position. So you can do this one. Sir, these are causing flexion at the metacarpophalangeal joint and extension at the interphalangeal joint. Yes, sir, this is the pain holding position. Fine. So if there is a damage to the L1, L2 due to the median nerve damage, as well as ulnar damage L3, L4, so just do opposite of it. At side of flexion, do extension. At side of extension, do flexion. So this is a complete claw hand. This is a complete claw hand. And you can see, sir, if there is a ulnar nerve is getting damaged, L3, L4 is getting damaged. So this is a ulnar claw hand. Yes. And if the median nerve is getting damaged, so L1, L2 getting damaged, so median claw hand. Fine. So this is very important topic, the short intercostal muscle of the hand. Okay. Now catch the interossei, two type, on the palmar side, on the dorsal side. So palmar interossei and dorsal interossei. Palmar interossei, sir, question had been asked in the FMGE exam. Can you see these are unipennate? And when these will contact, they will pull the fingers towards the midline. Where muscle goes, their movement flows. So these are causing the adduction. Which finger is not having the palmar interossei? बोलना नहीं, दिखाना है. जब बेटा लास्ट बार मैं क्लास ले रहा था तो यहीं पर आग लग गई थी और यहीं से क्वेश्चन आया था. कौन कौन था जब मैं टॉपिक पढ़ा रहा था और घर में आग लग गई थी, लेकिन हमने पढ़ा नहीं रोका था. कितना डेडिकेशन है. घर में आग लग गई लेकिन पढ़ा रहे थे. यस. और यहां से क्वेश्चन भी आया ना, जो था वो फायर का इमोजी बना के भेजो. जो जानता है वो जानता है, जो नहीं जानता वो नहीं जानता. यस, कॉकरोच जनता पार्टी. फाइन, लास्ट सेशन में हुआ था, है ना. और यहाँ से क्वेश्चन आया. चलो, यस यस, थैंक यू थैंक यू थैंक यू एवरीबॉडी. ओके सर. नेक्स्ट. See, these are four or three in number. These are causing the pad. Palmar interossei, they are adductor. These are supplied by the ulnar nerve. So if you will put the card, so that is a card test. Card test is done for the palmar interossei. Yes, it is responsible for the ulnar nerve. Fine, right, sir? Now look, three questions for the middle finger. It is the finger which is having the two dorsal interossei, FMG 2026. It is having no palmar interossei, and the best finger for the sensory examination because it is supplied median or radial ulnar all. Otherwise, one funny formula, बेटा सबसे अच्छा सेंसेशन इस मिडिल फिंगर से ही होता है. जो समझ गया वो समझ गया, जो नहीं समझा वो पोगो देखो. यस, दिस इज द वन फनी वे टू रिमेंबर. नाउ लुक हियर फर्दर. सर, dorsal interossei. So dorsal interossei, they are four in number. These are bipinnate muscle. Okay, yes. So when this muscle will contract, they will cause abduction. Dorsal interossei are abductor. Fine. So the Igawa Fallava, dorsal interossei, they are responsible for the Fallava Igawa test. Okay, fine. So this is what, this is the dorsal interossei, they are abductor. So the same question had been asked in your exam. Can you catch the FMG exam? Yes. This particular part. Yes. This question. Identify the muscle with its correct pair of the action. Dorsal interossei, they are abductor. They are abductor. Is it okay? Clear, everyone? Right, sir. Now, catch this one. Artery supply of the upper limb. It is very easy. Sir, subclavian artery, it is making the axillary artery, then brachial artery. Brachial artery is dividing the radial and the ulnar artery. Then it is making superficial and deep palmar arch. What are the important questions? Look here. Subclavian artery and their branches. Indirect questions are asked. Your formula is vitamin C D. VITCD. V for vertebral artery, which is giving the pica branch. If this artery is affected, then Wallenberger syndrome. Lateral medullary syndrome. I for internal mammillary artery, which is the artery for the breast surgery. Yes, and it is the best artery for the coronary artery bypass grafting. MCQ. T for thyrocervical trunk. Your formula is the Indian Standard Time. I for inferior thyroid artery, S for supraescapular artery, T for transcervical artery. Okay. Then C for costocervical trunk and D for dorsal scapular artery. So the inferior thyroid artery is the branch of the thyrocervical trunk. Again, it is important. इतना ही याद रखना है, बार बार पढ़ना है. Next, axillary branches. Again, your formula is hit. Sata, ata, data, acha, pacha, sasa. Do you remember? The axillary artery, it is divided by pectoris minor into the three parts. First part, second part, third part. First part is giving the one branch. Second part is giving the two branches. Third part is giving the three branches. Sata, ata, lata, acha, pacha, sasa. Sata, superior thoracic artery. Ata, acromiothoracic artery. Lata, lateral thoracic artery. Acha, anticircumflex femoral artery. Pacha, posterior circumflex femoral artery. Sasa, subscapular artery. Is it okay? Fine. Yes. The surgery question. Breast main arteries. Your funny formula is the Sali. जीजा कहाँ थे? फेस में थे. साली कहाँ है? ब्रेस्ट में है. So remember, yes, the superior thoracic artery, acromiothoracic artery, lateral thoracic artery. These are the main branches from the axillary artery. While the internal mammillary artery is branched from the subclavian artery. So whenever you are doing the mastectomy operation, you have to ligate these arteries. Is it okay? Getting the point? Okay, sir. So after this all, come to this Allen test. Do you remember? For the arterial blood gas analysis, we did this test. So what you have to do? Yes. make a tight fist. Okay, and compress the radial artery, compress the ulnar artery. Okay, tight मुट्ठी बनाओ and open it. Can you see? Sir, it is pale. अब ulnar artery को छोड़ दो. Yes, it is turning into the red. क्या जादू है? Means ulnar artery is okay. Means superficial palmar arch is okay. Now reverse saline test. Again make a tight fist. जोर से मुट्ठी बनाओ. Now compress the radial artery, compress the ulnar artery. Open it. Pale. Now leave the radial artery. Can you see it is turning red? क्या जादू है? Fine. So remember this one. Your radial artery is okay. Means the palmar arch is okay. Fine. So remember this fact. Clear? Is a beautiful integration of the anatomy with the surgery, medicine, as well as you can say the yes anesthesia. ABG. One question from the ABG जरूर आएगा ना. Alkalosis, acidosis, metabolic, respiratory. Sure short question. लिख के ले लो. नहीं आया तो तुम्हारी प्रॉपर्टी मेरी. Now we are looking the brachial plexus. The nerves of the upper limb is very, very important. Okay, sir. सर मुट्ठी ज्यादा टाइट हो गई. बेटा मुट्ठी ज्यादा टाइट होगी तभी तो मिथुन हंसेगा. जो समझ गया वो समझ गया, जो नहीं समझा वो पोगो देखो. यस. नाउ लुक हियर. सर ब्रेकियल प्लेक्सस. The brachial means arm, plexus means bunch. So bunch of the nerve which is supplying the upper limb, that is a brachial plexus. Okay. Now look, parts of the brachial plexus. The concept of brachial plexus is coming from the anatomy. Okay. Your formula is Russian tailor drinks cold beer. R for root, T for trunk, D for division, C for cord, B for branch. So these are the parts of the, yes, you can say the parts of the brachial plexus. So now during the our detailed classes, we had drawn the image, we had learned all the concept, which takes approximately half an hour. But this is a revision session, so we are going to make the summary. This is a summary. Sir, brachial plexus, it is having the root, trunk, division, cords from where the branches are emerging. Roots, yes, it is giving the dorsal scapular nerve, root value C5, which is supplying the levator scapulae, rhomboid major, rhomboid minor. Then long thoracic nerve, nerve of Bell, C5, C6, C7. And also the diaphragm is supplied to the phrenic nerve. So phrenic nerve is also participating. Do you remember the formula? 3, 4, 5 keeps the diaphragm alive. Okay. So the phrenic nerve is also in the contribution from the, yes, the brachial plexus part. Next, trunk. Sir, only upper trunk gives branches, 2 S branches. S for suprascapular, S for subclavius nerve. Division, it is giving not any branch. Then cord. Cord is giving the 3 types of branches. Lateral cord, then posterior cord, then medial cord. Lateral cord formula is the LML. L for lateral pectoral nerve, M for musculocutaneous nerve, L for lateral root of the median nerve. Yes, these all are giving the C5, C6, C7 branches. Okay. Clear? Now come to the next. Sir, posterior cord ULTRA. U for upper subscapular nerve, L for lower subscapular nerve, T for thoracodorsal nerve, R for radial nerve, A for axial nerve. I will tell you the formula to remember all the root value. Then medial cord 4M and 1U. M for medial pectoral nerve, M for medial rotation of the arm, M for medial rotation of the forearm, M for medial root of the median nerve. And here is the ulnar nerve. So remember, these are the branches LML, Ultra, 4M and 1U. Now how to remember the formula for the root value? Look here. Only 2 nerves with all the root value, radial and the median nerve, C5 to T1. Okay. During the main session, we drawn the image diagram and I told you how the fibers are coming. Every root value we remember. But this is the, yes, bullet train anatomy session, the rapid revision session. That's why we are covering the important points. Okay. So now look here, sir. Almost all the branches of the brachial plexus C5, C6, C7, except radial nerve C5 to T1, medial nerve C5 to T1, dorsal scapular nerve C5, thoracodorsal nerve 7, 8, 6, 786. All branch of the medial cord C8, T1, but the ulnar nerve is having the contribution from the C7 also. And now in the brachial plexus, thickest cord is the posterior cord. So thickest nerve is the branch of the posterior cord, that is the radial nerve. Then second number, lateral cord. So second thick nerve is the median nerve. And in comparison to it, the medial cord is thin. So ulnar nerve is thin. So this is the sequence. Gray's Anatomy 42nd edition. The musculocutaneous nerve is having the C5, C6, C7 root value. Axial nerve is having the C5 and C6 only root value. Ulnar nerve is having the C7, C8, T1 root value. Is it okay? Next, now the clinical. See, sir, if there is a C5, C6 damage, head and shoulder damage, then it is os paralysis. And if there is a damage in the axilla, lower trunk damage, then it is ulnar nerve damage. So this is the Klumpke's paralysis. Is it okay? Is it clear? क्या क्या हो गया भाई, क्या चीज? एनी प्रॉब्लम बेटा, प्लीज प्लीज टेल मी. क्वालिटी? क्या हो गया भाई क्वालिटी? अच्छा, अगर क्वालिटी अच्छी आ रही है तो थम्स अप दे दो. देखते हैं कितने लोगों को अच्छी क्वालिटी या बुरी क्वालिटी आ रही है भाई. अब देखो भाई, नहीं आ रही है, यानी कि, है ना, बेटा तुम्हारा डाटा खत्म हो गया है. तुमने जरूर कुछ दूसरे वेबसाइट में, तुम कुछ दूसरे साइट में गए होगे, वहां पर डाटा खत्म कर लिए होगे, है ना. फाइन. इसलिए बोलते हैं एटलीस्ट एग्जाम तक डाटा बचा के चलो. एग्जाम के बाद डाटा कहीं पर वेस्ट करो. ओके. फाइन. जो समझ गया वो समझ गया, जो नहीं समझा वो पोगो देखो. चलो आगे बढ़ो. सर, os paralysis. So can you see there is an injury at the head and shoulder area, then it is os paralysis. So in case of the os paralysis, you will see the policeman tip hand, waiter tip hand position. So os paralysis very important again, na. Yes, there is the one, two, three, four, five, six nose meeting point at the C5, C6 part, upper trunk. So this is os point. So there is a damage to the nose. Sir, in the os paralysis, C5, C6 is getting damaged. Axon now gone. Axon now is supplying the deltoid and teres minor. So deltoid paralysis, deltoid is causing the abduction. Abduction gone. So patient is presenting with the adduction. Teres minor gone. Teres minor is causing the lateral rotation. So that's why patient is presenting with the medial rotation. Yes, muscular now it is supplying the brachialis and the biceps. Brachialis is the chief flexor. So patient cannot flex. So patient is presenting with the extended elbow. Biceps is the powerful supinator. So the patient is presenting with the pronated hand. Yes, radial nerve, it is a supinator. So patient is getting damage in the radial nerve. So patient is presenting with this weak supinator. Again, pronated hand. So this is your adducted, extended, medial rotated, and pronated hand. This is the policeman tip hand or waiter's tip hand. So don't forget this one. No? Okay, sir. Now another Klumpke's paralysis, claw hand. Yes. If any patient is having the damage in the lower trunk, then C8T1 has gone. C8T1 is the root value of the median or ulnar nerve. So median or ulnar nerve gone, that's a claw hand. And T1 has gone, that's why Horner syndrome. So the patient is presenting with the ptosis and the meiosis. This is the Horner syndrome. Okay. So look here, the Horner syndrome, important. Ophthalmology integration. Okay. So catch this one. Sir, the T1 is getting damaged. Klumpke's paralysis, Wallenberg, or the pancreas tumor, here you will get. So can you see, due to the damage in the T1, superior tarsal or molars muscles, they are paralyzed. So the patient is presenting with the ptosis. Sir, there is the dilator pupillae muscle. T1 is getting damaged. So dilator pupil is gone. So meiosis is there. Okay. Sir, this is the orbitalis muscle. If T1 has gone, orbital is paralyzed. So there is a sunken eyeball, that is anophthalmosis. Sir, there is a sweat gland. So if T1 has gone, sweat gland, they are getting problem. So there is a dryness, anhydrosis. T1 is also participating in the cilio-spinal reflex. So these are one. So due to the damage in the T1, these symptoms are there. So remember, ptosis, meiosis, anhydrosis, and ophthalmosis. Also loss of cilio-spinal reflex. This is your what? Klumpke's paralysis. Don't forget. Next. Further. Yes, one question sure from here. Don't forget, don't miss the upper limb and the lower limb nose. Why? See. Again, can you see? Upper limb, 5 question. So catch upper limb question. Can you see axillary nerve? 1. Can you see medial nerve or introsseous nerve, deep branch of the medial nerve? Yes, this is the question, the middle finger question, dab. Okay, and this one, ulnar nerve. Among the 5 question, 3 questions are from the nose of the upper limb. Yes, very good. FMG 200 plus. You can see 3 question: axillary nerve, anterosseous and ulnar nerve. तो बेटा क्यों क्यों छोड़ के जाना? बेटा क्वेश्चन पेपर तो ऑलरेडी लीक होता है ना. 80% टॉपिक्स आर ऑलवेज आस्क्ड फ्रॉम द पीवाईक्यूज एंड द पीवाईटीज. आप कभी का भी पेपर उठा के देख लो. इज इट ओके? फाइन. क्लियर? गेटिंग द पॉइंट? So these are the things which you have to remember. Fine. So now catch this one. Sir, this is the surgical neck of the humerus where you will see the axial nerve. This is shaft of the humerus where you will see the radial nerve. This is supracondylar where you will see the median nerve. So your formula is the arm, ARM, and behind the middle epicondyle ulnar nerve. Simple. So either fracture of the surgical neck of the humerus, axial nerve gone, fracture of the shaft, radial nerve gone, supracondylar fracture, sir, median nerve and the brachial artery gone, fracture of the middle epicondyle, yes, ulnar nerve gone. You know relation MBBR. Yes, median nerve, brachial artery, biceps tendon, radial nerve. Is it okay? Done? Yes. Now look, the clinical question, how they are asking. Atrophy of the shoulder joint. On X-ray, there is a surgical neck is getting damaged, axial nerve damage. Sir, wrist drop, shaft is getting fractured. Sir, ulnar claw hand, yes, you will see the fracture behind the middle epicondyle. One patient is presenting with the cubitus virus, that is the, yes, you can say gunshot deformity. Yes, this is the supracondylar fracture. So median nerve and the brachial artery, they are affected. Is it okay? Mark this slide, very very important. But इस slide को छोड़ करके जाना ही नहीं. एक क्वेश्चन यहाँ से आएगा ही आएगा. एक क्वेश्चन एक्स्ट्रा ड्यूरल हेमरेज, सबड्यूरल हेमरेज, सबएनाइड हेमरेज, इंट्रासेरेब्रल हेमरेज वहां से आता है. Okay, fine. Now look, median nerve, this is the course. The questions they are not asking from the branch or the course, they are asking the question from the clinical. So look here, dermatome of the hand, very important. Derma means skin, tom means segment. So the skin segment which is supplied to the particular nerve, that is the dermatome. On the palmar side, remember the base of the thumb, anatomical snub box area, very small area by the radial nerve. Now towards the thumb, medial nerve, towards the little finger, ulnar nerve. जो नर्व जहां रहती है, जहां बहती है, उसे सप्लाई करती है. So 1, 2, 3 and half. These are supplied by the median nerve. Yes, ulnar nerve is towards the ulna. So 1 and half is supplied by the ulnar nerve. Simple. But on the dorsal side, on the back side, again, the radial nerve is occupying the half, ulnar nerve is occupying the half. Adha adha marti. Now the median nerve is supplying the same 3.5, but only the nail beds, only the distal part. So which is the best finger for the sensory examination? बोलना नहीं, दिखाना है. Sir, this middle finger is supplied by the median nerve, radial nerve, and the ulnar nerve. So this is best finger for the, and which is the best finger for the motor examination? Thumb. When you will go for the exam, we'll say all the best, thumb. So if you are doing the abduction, means median nerve is okay. If you are doing the adduction, means ulnar nerve is okay. And when you are doing the extension, means radial nerve is okay. Okay. Yes, sir. So these are the things which you have to remember. Now look for this particular, yes, you can say the clinical for the median nerve. So your formula is the Captain America is the bachelor in physiotherapy. CAP, bachelor physiotherapy. Carpenter syndrome, Eptham deformity, Ponting index, Benedict hand, Pope hand deformity, Phelan test, Pain test, Tinel sign. These all are related with the median nerve. Okay. So look here, one by one. Sir, this is a flexor reticula. Compression of the median nerve below the flexor reticula is known as carpal tunnel syndrome. So how you will treat? Cut it, release the pressure. Okay, releasing the pressure, that is a permanent surgery. Fine. Now see, for 3 tests for the carpal tunnel syndrome, the formula is tinel, tapping, fall, Phelan, Durkan, compression. So these all the 3 tests, tinel test, Phelan test, Durkan test, all are the test for the median nerve carpal tunnel syndrome. So when you're tapping, pain is increased along the lateral 3.5. This is the carpal tunnel syndrome tinel sign. When you're doing the excessive flexion, pain is increased on the same side. Yes, median nerve compression, carpal tunnel syndrome. And when you're doing just only compression, okay, then the same feature. This is a Durkan test. D for Durkan, D for Dabana. Okay, so this is the best test for the median nerve. Now you can see if there is the any patient having the atrophy of the thenar eminence, so this is an aphthous deformity, median nerve is damaged. Sir, if there is a damage to the median nerve in the cubital fossa, so patient is not able to flex these 2 fingers. Due to the ulnar nerve supply, these 2 fingers are flexed, but these 2 fingers are not able to flex. So this is a Pope hand deformity or the Benedict hand deformity. When the patient is causing the abduction and touching the pain, so this is the, yes, abduction test, pain test. Sir, abductor pollicis longus is okay, abductor pollicis brevis, which are supplied with median nerve. So this is the median nerve test. Now Ponting index, if there is damage at the middle of the forearm, so patient is able to flex these 3 fingers, but one finger is pointing towards the doctor. So this is a Ponting index. The same is the Clark test. We are making the Yes, clasp, but it is the same, na? Yes, it is a finger test, quantic index, it is a clasp test. Both are same. Next, this is the Sigmund Freud test. Yes, Kilo-Nevin sign. So this thumb is supplied by flexor pollicis longus. This index finger is supplied by flexor digitorum. Yes, profundus. Both are supplied with the anterior of deep branch of the median nerve. So if you are able to do this one and that one, means your anterior nerve is okay. But if anterior nerve is damaged, you can, your flexor pollicis longus is paralyzed, your flexor profundus is paralyzed. So you will do this one. So this is damage to the anterior nerve syndrome or Kilo-Nevin sign. Two questions had been asked here, na? Okay, sir. Now we are talking about the ulnar nerve. So clinical A, B, C, D, E, F, G. A for ulnar nerve, you can say. B for book test, C for car test, D for Dr. Paul's test, E for Igawa test, F for Froment sign, G for Guillain syndrome, and H for handlebar palsy. Is it okay? Clear, everybody? So look here, one by one. Sir, this is the carpal area. One question from this hand portion. She looks too pretty. Try to catch her. He is a flexor atribula. Below it, carpal tunnel, the main structure which is passing, that is median nerve. Compression of the median nerve in this carpal tunnel is known as the carpal tunnel syndrome. And above it, 5 structures. Can you see? Sir, this is palmaris longus. Sir, this is median nerve. Sir, there is the palmar cruciate branch of the ulnar nerve. Yes. And this is the palmar cruciate branch of the median nerve. Here you can see the ulnar artery and ulnar nerve. So above this carpal tunnel, can you see there is one more tunnel? This is the Guillain tunnel. What is the content of the Guillain tunnel? Sir, ulnar artery and the ulnar nerve. So when any person is doing bicycle riding for the long time, so this ulnar nerve, ulnar artery, they are getting compression in this carpal, in this Guillain tunnel. So this Guillain tunnel syndrome is the handlebar palsy. Now look, sir, this is the book test. So when we are holding the book, we are doing the adductor pollicis use. Adductor pollicis is the graveyard of the ulnar nerve. It is applied to the ulnar nerve. Yes, it is okay. But if ulnar nerve is getting damaged, then patient is not able to adapt, but he's doing the flexion and holding the book. So there is the damage to the ulnar nerve when he's flexing. The same is a Froment sign. F for Froment, F for flexion. So patient is doing flexion, so the Froment sign positive. Yes, ulnar nerve is damaged, adductor pollicis is damaged. Okay. Now look, the radial nerve. So in the radial nerve, clinical are important. Sir, this is a crutch palsy, radial nerve damage. Saturday night palsy, radial nerve damage. Radial nerve is the extensor. If this nerve is getting damaged, patient is not able to extend, so there is a wrist drop. Okay, patient is not able to extend the finger, so there is a finger drop. And in the market, the new syndrome is there, honeymoon palsy. Is it okay? Honeymoon palsy. So what is happening? Nibba Nibbi, they are going to celebrate the honeymoon. So Nibbi is sleeping over the hand of the Nibba. So this is a neuropraxia condition, compression of the nerve. Permanent treatment, cut the hand of the Nibba or cut the throat of the Nibbi. Na rahega baans, na bajegi bansuri. Okay. So don't forget to follow me at Insta for very interesting. Okay. At the Georgia. Yes, at the Georgia. The Chronicles of the Georgia is also based on the, yes, anatomy. Okay. Zorab Zaratani, who created the particular Chronicles, the beauty of the Georgia, he was also the CBI agent. Yes. This is the honeymoon paralysis. Okay. Honeymoon paralysis. Also, you can see the different position, flexion, extension. Yes, one hand is flex, another hand is extended. So this is what? This is the anatomical position. Can you see flexion, extension? Okay. Yes, I'm teaching the anatomy in new way so that you can remember. Everywhere you can find out. You can find out the anatomy. No? Sir, this is the supination pronation. Okay. The king's pronate and the beggar's supinate. So supination pronation position. Okay. Fine. Now, in this way, you can learn the anatomy. Everywhere you can find the anatomy. Okay. Now, come to the next further. Anatomical snub box, another very important topic. So, this is the anatomical snub box. You have to take the drug abuse substance, you have to put here, you have to rub here, and then, yes, you have to do snuffing. So, this is the anatomical snub box which is used for the snuffing. So, can you see? anatomical slump box. Here is the entry boundary, this is the posterior boundary. So entry boundary is formed by the abductor pollicis, long muscle, longus. Sir, this is the extensor pollicis, small muscle, brevis. While the posterior boundary is formed by the extensor pollicis, longus. So anterior longus, posterior longus, between is brevis, the formula. Sir, roof is formed by skin, superficial fascia, deep fascia. In the superficial fascia, sir, there is a radial nerve and cephalic vein. So if radial nerve is getting compressed, then it is the wristwatch neuropathy. You can see Salmon Boy hand. Yes, this is a Salmon Boy farmhouse in the dial, wallpaper. So if there is a compression of the, yes, you can say the radial nerve at the anatomical box, this is the wristwatch neuropathy, also known as the chiralgia paresthesia, which is also known as the Wartenberg syndrome. Yes, remember Wartenberg sign is the ulnar nerve compression you will see in the orthopedics. So chiralgia is not too much important, but meralgia paresthesia is very important. Okay, we did one funny correlation. एक funny story हमने बनाई थी. हम जिया से रिक्वेस्ट कर रहे हैं मेरा ले ले. Yes, तो क्या बोलेंगे? मेरा ले जिया paresthesia. So remember this is the NEET PG 2025 question. What is the root value of this meralgia paresthesia? Yes, the lateral quadrant of thigh is compressed. Root value is L2 L3. Important. Yes, in laparoscopy, in one hernia surgery, which nerve is most commonly compressed? Answer is the lateral quadrant of thigh. That is the meralgia paresthesia. Okay. So remember, now flow, touch this portion. Yes, here is the cephalic vein which is used for the intravenous injection. Flow. Sir, is blood process of the radius. Sir, then scaphoid bone, then trapezium, and then base of the first metacarpal. You can feel it. Sir, here is the scaphoid bone, most common carpal bone getting fracture, second most common bone getting avascular necrosis, and for it we are using the glass holding cast. So these are the question. And only one content, sir, radial artery is the content. Okay. Now the clinical. Sir, there is an inflammation of the tendon. This is another decoherent tendinosynovitis for which the Finkelstein and ECOF test we do. Okay. Now let's start the PYQs and the PYTs. So can you see this question? Regimental badge anesthesia, there is a loss of sensation, surgical neck of the fracture, surgical neck of the humerus is getting fractured. Axial nerve. Sir, here the supracondylar fracture, median nerve, if not given, anterolateral nerve. Yes, can you see the abductor bipennate muscle arrangement? So this is a dorsal interosseous. Sir, middle finger is having the two dorsal interosseous. Dorsal interosseous, they are causing the abduction. Dab is your formula. Next, fracture of the medial epicondyle, ulnar nerve. Sir, there is a fracture. Yes, they identify. So this is a clavicle. This is the acromion process. This is the coracoid process, and it is the humerus. So they ask about the acromioclavicular joint. They ask about the acromion process. They ask about the coracoid process. Okay, sir. You will see the tendon. So there was the question. Sir, this is the mid-palmar space. This is the thenar space. Fine. So the mid-palmar space is connected with this middle finger and ring finger. So infection here, it will affect this two finger. Thenar space, it will affect the thumb. Next. Sir, this is the house paralysis, C5, C6 damage. Sir, this is the shaft is getting fractured, radial nerve is affected. Sir, this is the ulnar nerve course. So ulnar nerve is the answer. July 2025 question. And you can see the clawing of the hand. So ulnar nerve is the answer. Fourth, fifth, ulnar nerve. They are asking for the nerve. Now base of the thumb. So remember, whenever the base of the thumb is asked, the anatomical snub box, yes, your answer will be the radial nerve is better answer than the median nerve. So now are asked. Now there is the question over the breast surgery. Pectoris major is here. Here is the serratus anterior. Serratus anterior had been asked. Now they're asking about the ring finger. Ring finger supported which nerve? Answer is the ulnar nerve. So nerves are very important. Yes, there is the base of the thumb. So which carpal bone is affected? Scaphoid bone. Sir, there is a fracture. So whenever there is the oblique fracture, Bennett's fracture, and whenever there is the yes Y-shaped fracture, then it's the Ronaldo fracture. No, it's not the Ronaldo. It's the Roll-Ando fracture. Okay, so anyhow you can remember, sir. Now the anatomical slump box they are always asked. So they ask the extensor pollicis longus. Okay, extensor pollicis longus. Okay, next. Can you see? They ask the question about the flexor carpi radialis. Okay, so flexor carpi radialis to identify. Yes, shaft में अगर बेटा आया ना तो रेडियल नर्व को पहले मार्क करना. Yes, they are asking the scaphoid bone. They are asking about the biceps rupture Popoy sign. Yes, they ask about the एक कोई इमेज छूट गया बेटा है ना तो इमेज के बेस पे बता सकते हैं. But yes, now are asked. Okay, they are asking again the vera and valga. So this is the cubitus valgum because joint is close. Now they are asking again the nerve. तो बेटा now से हर बार क्वेश्चन आया January 2023. Can you see again the anatomical slump box is important. They are asking the extensor pollicis longus. Okay. Now they are asking about supraspinatus. Supraspinatus, where muscle goes, their movement flows. So they are crossing upside. So they will cause upside movement. This is the abduction. Yes, they're asking about the parts of the clavicle. So 80% of the fracture in the clavicle at the middle one third. But if it is not given, then you can say the medial two third and lateral one third. This is again in the middle one third part. They're asking about the leprosy. In the leprosy, there is a claw hand, ulnar claw hand. Yes, they're asking about the ability to extend his wrist. Extension, loss means wrist drop. Yes, shaft is shown. So this is the radial nerve. They are asking about the winging of the scapula, the serratus anterior. And yes, now we are going to deal with the lower limb portion. So dear friends, now this lower limb will take one third of the upper limb. Now the remaining portion are small. Majority of the questions they are asked from the your head, neck, face, neuro, and 5 questions from the upper limb. That's why we did this one. Okay. Yes, dinner break. Can we do the dinner break? डिनर ब्रेक कर लेते हैं. डिनर ब्रेक. यस, कितना मिनट का? 15 मिनट, ज्यादा टाइम नहीं. 15 मिनट ना. ओके. यस, थैंक यू. सो आफ्टर द 15 we will come back. Okay, thank you. ओके. अकॉर्डिंग टू द इंडियन स्ट्रेचेबल टाइम, तो 15 मिनट 20 हो जाएगा. 20 मिनट को अगर मान लो बोलेंगे तो आधा घंटा हो जाएगा. ओके, फाइन. थैंक यू. हेलो एवरीवन। मैं डॉक्टर दिलीप कुमार कैसे बन गया? मैं भी ऐसी था क्या? कोई बात नहीं। मेडिसिन ही एनाटॉमी है, एनाटॉमी ही मेडिसिन है। नाउ होप ऑडियो एवरीथिंग इज ओके। 10, आई थिंक 11:30 तक हो जाएगा। 10 बजा हुआ, जल्दी भी हो सकता है। बिकॉज ऑल द डेंजरस थिंग वी कंप्लीटेड ना। फाइन। सो कैन वी स्टार्ट? काम करो ऐसा कि पहचान बन जाए, चलो तो ऐसे कि निशान बन जाए। अरे जिंदगी तो हर कोई काट लेता है मेरे दोस्त, अगर दम है तो जियो ऐसे कि मिसाल बन जाए। So dear friends, now we are going to look for this next part of the anatomy, that is the lower limb portion. Okay, so in the lower limb, one question show from the arterial disease, one question show from the venous disorder, and sometimes yes, you will see one question from the lymphatic disorder. Okay, तो ये देखो, sir, there is external artery which is continuing as a femoral artery, then popliteal artery. Popliteal artery is dividing in the anteritibial and the posterior artery. The anteritibial artery is making the dorsalis pedis artery, and the posterior artery is dividing the medial plantar artery and the lateral plantar artery. Remember, this posterior artery is most commonly asked, very frequently asked question. Okay, now come to the next, sir. This venous drainage. If there's a problem in the vein, then varicose vein due to the abnormal superficial vein, and if the deep veins are involved, then deep venous thrombosis. So these topics will be asked. Okay, superficial vein, great saphenous vein, short saphenous vein, and deep veins, they are following the deep arteries. Okay, so what is the important factor that is asked? So look at this diagnostic presentation. Do you remember our song Wah Wah Ram Ji, जोड़ी क्या बनाई बड़े भैया? Great saphenous vein is accompanied by the badi bhabhi saphenous nerve. Yes, the longest vein of the body, great saphenous vein, is accompanied by the longest nerve of the body, that is saphenous nerve. So if you will cut the great saphenous vein, the saphenous nerve is getting cut. MCQ. That is the veiny section. Also is the phlebotomy. And now we are cutting the short saphenous vein. Then sural nerve is getting cut. Rule 12, the sural nerve S1. Very important fact. You have to do this procedure in the clinical. So now the bones of the lower limb. So I'm going to tell you about this all the bones and the muscles also with the three-dimensional orientation, and then we will see the each compartment. So look here. First, the bones of the lower limb. Look at this part. Yes, lal full, near full. Anatomy, beautiful. Just observe, sir, this is the hip bone, which is articulating with the longest bone of the body, strongest bone of the body, that is a femur. Now femur is articulating with the, yes, strong, you can say the pre-axial bone of the leg, that is a tibia, and this is the post-axial bone of the leg, that is a fibula. And then you can see the foot bone. Important. One question from the foot zone. Sir, this is a calcaneum. Above the calcaneum, there is a talus. In front of the talus, this is a navicular bone. Navicular is articulating with the medial, intermediate, lateral cuneiforms, and these are articulating with the first, second, third metatarsal. Here on the latter side, sir, this is a cube-shaped one, cuboid. Then there is a fourth and fifth metatarsal, and here you can see the phalanges. Is it okay? Getting the point? Okay, sir. So now catch the things, the muscles of the lower limb. So look here, sir, this is the thigh, here is the leg, and here you can see the foot. So can you see the thigh? There is an entry compartment, then medial compartment, and here's a posterior compartment, right, sir? In the entry compartment, sir, this is the longest muscle of the body, the sartorius. Yes, it is supported the femoral nerve because nerve is the femoral nerve. Then this is the rectus femoris, then cut it. So you can see vastus medialis, then you are able to see the vastus intermedius, then you can see the vastus lateralis. Yes, these are the muscles. These four muscles are uniting together and they are making the ligamentum patelli, in which the largest seed-like bone of the body, smart bone, is getting articulated. Okay, so these are the things. Now, what are the questions which are asked? Look here, sir, entry compartment thigh. So you can see in the entry compartment, the longest muscle of the body, that is a sartorius. This is known as a Taylor's muscle. This is known as a honeymoon muscle, supplied by the femoral nerve. Now your formula is the SIPPA, SIPPA. S for sartorius, I for iliacus, P for psoas major tendon, P for pectineus, A for adductor longus. Okay, so this triangular muscular depression in front of the thigh is known as the femoral triangle. So lateral border is formed by the medial border of the sartorius. So medial border is known as the, yes, the medial border is formed by the medial border of the adductor longus, and the base is formed by the inguinal ligament. Apex is formed by the meeting point. So roof is formed by skin superficial deep fascia, and the floor is formed by the IPPA, 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 or you can remember the epi, whatever you want to do. So floor is formed by the iliacus, psoas major, pectineus, and the adductor longus. Got the point? Okay, sir, this is the EO muscle. Sunny Leone auntie, do you remember? EO. Oh, bit dull. Yes. The lower free margin is known as the inguinal ligament, right? Now, what are the content? So when you will see inside, yes, एनाटॉमी में डाइसेक्शन होता है, एक वेन होती है, एक आर्टरी होती है, एक नर्व होता है और लिम्फ होता है. So there is a femoral vein, then femoral artery and femoral nerve from medial to the lateral side. Okay, so the femoral vessels are covered by the modification of the deep fascia known as the femoral sheath, and its medial most compartment is known as the femoral canal. What is the content of the femoral canal? Answer is the deep inguinal lymph node, which was studied by the Rosenberg clockwork. Okay, so this is your answer. Remember, femoral nerve is not the content of the femoral sheath. So in case of the increase in intracranial pressure in female especially, through this femoral canal, the intestinal loop is coming down into the femoral triangle. This is the femoral hernia. Okay, so these are the important fact. Remember the question: most common hernia in male, inguinal hernia. Most common hernia in female, inner direct inguinal hernia, then direct inguinal, then femoral hernia. But if they are asking, femoral hernia is more common in then female, but inguinal hernia is more common in male. So each full stop comma they are important. ध्यान से पढ़ना, अदरवाइज तुम्हारा पूजा हो जाएगा, तुम्हारी जान ले ली जाएगी, तुम कमरे में दे करके आ जाओगे. ये नहीं करवाना है. ओके, सो now look here, another important thing, the muscles with the double nerve supply. So you can see in the upper limb, BSP, pupa. Yes, in the neck we had seen the digastric. So now in the lower limb, answer is the BAP, BAP. B for biceps femoris, A for adductor magnus, and P for pectineus. Yes, hybrid muscles are important. So biceps femoris is supported tibial part and the common part of the sciatic nerve. That's why it is hybrid muscle. Adductor magnus is supported obturator nerve and sciatic nerve. NEET PG 2024 question. That's why it is hybrid. Pectoral is supported the obturator nerve and femoral nerve. That's why it is hybrid muscle. So this list is important, very most important. Next, when you are looking the medial compartment, once I'm showing you the muscles of the medial compartment, so the medial compartment is the adductor compartment. So long muscle, adductor longus, cut it. Small muscle, adductor brevis, cut it. Very, very big muscle. So this is the adductor magnus. This is the very adductor magnus. Now cut it. Now can you see there is another muscle? So this is the pectineus. Sir, it is the pectineus. Cut it. Now you can observe, sir, this is the gracilis. Sir, this is the anti-rape muscle, also responsible for the custodian of virginity. Okay, custodian of virginity. So these are the muscles of the medial compartment supplied by the obturator nerve. Now look here on the back side. So this is gluteus maximus, then gluteus medius, then you can see the gluteus minimus. Now this muscle is tensing the fascia lata, so that's why this is the tensor fascia lata. Okay, so cut this muscle. Now can you see this is the pear shaped muscle piriformis. Now cut this muscle. You can see this is the obturator internus. Above the obturator internus you can see the superior gemelli, and this is the inferior gemelli. Yes, it is the obturator internus. And once in the NEET PG 2016, they asked this quadrangular shaped muscle attached to the femur. So this is the quadratus femoris. Yes, sir, it is the quadratus femoris. Is it okay? Clear? Okay. Yes, sir. So again, you can see the gluteal area. Yes. So you can see this is the very big muscle, gluteus maximus. Now supply inferior gluteal nerve. Action extensor at the hip joint. Remember, the National Board of Exam loves gluteal region. So one question from this gluteal area, either the clinical, okay, or you can say the Trendelenburg sign. Yes, if it is getting damaged, then Gore sign is positive. Now look, sir, there is a pear-shaped muscle, piriformis. Above it, superior gluteal nerve. Below it, inferior gluteal nerve. So superior gluteal nerve is supplying gluteus medius, gluteus minimus, and tensor fascia lata. Inferior gluteal nerve is supplying the gluteus maximus. The thickest nerve of the body, just below the piriformis, that is a sciatic nerve. Right, sir? These are the same gluteal muscle. Here I told you the same thing. Okay. See, the gluteus medius, minimus, and tensor fascia lata, they are supplied by the superior gluteal nerve. If this nerve is getting damaged, yes, then positive Trendelenburg sign. Sir, there is a positive Trendelenburg sign. Okay. So the patient is not able to proper abduct, so abnormal gait. So if unilateral paralysis, lurching gait, bilateral paralysis, duck-like gait, waddling gait. So remember, Shapni Mama gait, yes, he was tilting at one side. That is a lurching gait due to the paralysis in the abductor process, due to paralysis in this abductor mechanism muscle, gluteus medius, minimus, and tensor fascia lata. Yes, if both side is damaged, then one side lurching, other side lurching, one side lurching, other side, both side lurching. So duck-like gait, that is the waddling gait. So don't forget, no. Now, this is a Gower sign due to the gluteus maximus paralysis, and which is found in the Duchenne muscular dystrophy. This is the Trendelenburg sign. How can you remember the Trendelenburg sign? Drop of opposite and lurching ipsilateral. Dolly is your formula for the Trendelenburg sign. Now, the NEET PG, they ask the question from this portion. That's why we are looking the lumbar plexus. See, L1, L2, L3, L4, L5. So L1 is making the iliohypogastric and ilioinguinal nerve. So both are having the root value L1. Now important thing. Can you see the L1 and L2? They are making the yes GF nerve, genitofemoral nerve. Remember, genitofemoral nerve, girlfriend nerve, is responsible for the premasteric reflex. What is this premasteric reflex? Try to understand in this funny way. Girlfriend जब हमारे मीडियल साइड ऑफ द थाई को टच करती है, जेनेटल ऑर्गन के पास को टच करती है, तो yes, this genitofemoral nerve is getting activated. It will send the impulse to the L1 and L2, and then impulse will coming again to the genitofemoral nerve, and it will cause the contraction of the cremasteric muscle, and it will cause elevation of the testis. So when the girlfriend is touching the medial side of the thigh, there's an elevation of the testis. This is known as a cremasteric reflex. Don't forget this one, sir. This genitofemoral nerve is participating in the cremasteric reflex. अब तो नहीं भूलोगे, अब तो नहीं भूलोगे. It is important. Got the point? Right, sir. Now, can you see the L2, L3, L4? Ventral division is making the obturator nerve, and L2, L3, L4. The dorsal division is making the femoral nerve. Fine. So nerves of the lower limb, they are important. Okay. मरते दम तक याद रहेगा, क्या बात है. दिक्कत ये है कि गलत टाइम पे याद आएगा. ये बात तुमने बहुत सही कही चंद्रेश. ओके, एग्जाम हॉल में नहीं याद आएगा, लेकिन जब गर्लफ्रेंड बैठे रहेगी तब याद आएगा. Okay, sure. Sir, now come to this one. Nose of the lower limb again. Sir, you can observe this particular part. Sir, there is a L4, L5, S1, S2, S3. So L4, L5, S1, they are meeting and making the supraegluteal nerve, which is supplying the gluteus medius and tensor fasciolata. If it is getting damaged, then positive tendinous sign. Now infragluteal nerve L5, S1, S2. If it is getting damaged, yes, it is supplying gluteus maximus. If it is getting damaged, then Gower sign is positive. Now look, sir, L4, L5, S1, S2. They are making the common pelvic part and L4 to S3. Yes, yellow color part. These are making the tibial part. Now the tibial part and the common pelvic part, they are uniting and they are making the thickest nerve of the body, that is sciatic nerve. Now this sciatic nerve is coming down, and at the superior angle, it is dividing into the tibial nerve and lateral side running common peroneal nerve. Sir, this common peroneal nerve, it is dividing into the deep peroneal nerve, which is going on the entry compartment, and this is your lateral compartment. Sir, this is the, yes, superficial peroneal nerve, while the tibial nerve is running on the back side. This tibial nerve is dividing into medial and lateral plantar nerve. So the summary, don't forget the nerves of the lower limb important. Sciatic nerve is dividing into the kapana and tamanna. Okay, tamanna is the nerve of the posterior compartment of the leg. Tibial nerve. Then kapana is dividing into sapana and dapana. अर्ज किया है आपका, तो लगता है बस यही सपना, राम नाम जपना, पराया माल अपना। यस, ये सच्चे दोस्त की पहचान है, जो कहता है कि जो तेरा है वो मेरा है, जो मेरा है वो मेरा ही है, तेरा कुछ नहीं है साले। यस, so you can kapana, sapana, dapana. Common peroneal nerve is dividing into superficial peroneal nerve and deep peroneal nerve. The superficial peroneal nerve is the nerve of the lateral compartment. Deep peroneal nerve is the nerve of the anterior compartment. Okay, fine. So these are the things which you have to remember. Okay, sir. Now look, in the popular, yes, this sciatic nerve is running on the back of the thigh, back of the leg, and lateral part of the leg. So in case of the sleeping foot, there is a neuropraxia, so the pain is felt here, or tingling sensation felt here. But if there is permanent pain due to disc prolapse, so permanent pain on the same side, that is a sciatica. Now, in the popliteal fossa, only one thing you have to remember, here the AVN relation is there. AVN. Yes, there is a popliteal artery, popliteal vein, and the nerve, that is a tibial nerve. So not the VN relation is followed, but here the AVN relation is followed. Same on the middle part. Remember, the artery is deep, then vein, and then nerve. Okay. Yes. Now at the neck, there is the common peroneal nerve. So if there is a fracture, common peroneal is getting damaged. So look here. One thing, hamstring muscle, the runner's muscle. Sir, semitendinosus, semimembranosus, long of the biceps femoris, and the striate of the adductor magnus. These are the runner's muscle. Again, you can see further. Can you see? Sir, on the back of the thigh, you can observe this muscle is a half tendon, half muscle. Semitendinosus, cut it. This muscle is half membrane like, semimembranosus, cut it. Can you see this muscle? This muscle is having the, yes, one long head, another is the short head. So this is the biceps femoris, cut it. And you can see one more part, that is the ischial head of the adductor magnus. These four muscles are having the common features. What? All these four muscles are taking origin from the ischial tuberosity and inserting the leg muscle. So where muscle goes, their movement flows. So when they will contract, they will decrease the angle of the knee, means flexion. They will increase the angle of the hip, means extension. So they are causing, yes, extension and flexion. So they are helping in the running activity in the lower limb portion. Is it okay? Clear? Done? So these are the things which you have to remember. Okay. So now look for the more. Sir, in case of the fracture of the neck of the fibula, like the bumper's fracture, sir, there is a damage to the common peroneal nerve at the neck of the fibula. So it will result into the foot drop. Hope you all are aware about this. We had seen in detail this very important topic, now foot drop. Now look the leg compartment. So in the leg, sir, again 3D orientation you can see. Entry compartment, deep peroneal nerve. Lateral compartment, superficial peroneal nerve. Posterior compartment, sir, there is a tibial nerve. Okay. So I'm going to tell you the muscles. Sir, this is the first muscle. In front of the medial malleus, tibialis anterior. Cut it. Can you see? This is the muscle going to the great toe. So this is the, yes, extensor hallucis longus. Yes. Next is the extensor digitorum longus. And the next muscle is the peroneus tertius. Okay. So how can you remember the formula? The formula for the entry compartment, sir, the hospitals are never dirty places. T for tibialis anterior, H for hallucis longus, A for artery, which is the artery in the entry compartment, definitely the anteritibial artery, and N for nerve, which is the nerve, deep peroneal nerve, and then D for digitorum longus, and last the peroneus tertius. Now in the lateral side, only two muscles, peroneus longus, peroneus brevis. Who is the nerve of the lateral compartment? Sapna. So question, peroneus longus is supplied by the sapna, the peroneus brevis is supplied by the sapna. Yes, now the posterior compartment. Look here, again, 3D orientation. Sir, this is the peroneus longus, long muscle, and this is the peroneus brevis, short muscle. Is it okay? Fine. Okay, this is a peroneus tertius. Now, posterior compartment. The posterior compartment, two group, superficial and deep. So this is the GSP, G for gastrocnemius, S for soleus, and this is the P for plantaris. Okay, so these are the three muscles. Yes, these gastrocnemius, soleus, and the plantaris. You can see here, posterior compartment, tibial nerve is the nerve, GSP, gastrocnemius, soleus, plantaris. This gastrocnemius is having the lateral head, medial head, and soleus. So these are one, two, three. Three muscles are uniting and making the triceps suri, which is getting attached to the calcaneum. So this is the tendocalcaneum. Also, you can say tendoachilles, which is the strongest tendon of the body. We had seen the story of the Achilles at this part. Hollywood, Bollywood, Tollywood, all are from the anatomy. Plantaris is in the short belly and long tendon. That's why it is used for the tendon grafting operation. Now for the deep group, you can remember the formula Tom, Dick, एंड नर्वस हैरी. ये वो वाला डिक नहीं है जो तुम सोच रहे हो, ये नाम वाला डिक है. ओके. टी फॉर, यू कैन रिमेंबर टिबियस पोस्टीरियर. डी फॉर डिस्ट्रोम लॉन्गस. A for artery, which artery? Positibial artery. N for nerve, the tibial nerve, and H for hallucis longus. So again, I'm showing you the three-dimensional orientation, sir. This is the medial malleus. Just behind it, sir, this is the tibialis posterior. This is behind the tibia. So this is tibialis posterior. Is it okay? Yes. Now cut this one. Can you see this tendon? Sir, this is a flexor compartment and going to the foot digits. That's a flexor digitorum longus. Cut it. Can you see this one? So this is going to the great toe. It is reaching to the great toe. So this is a flexor hallucis longus. Complete. So we had seen all the muscles of the leg. One more muscle is there in the popliteal fossa. That is the popliteus muscle at the floor of the popliteal fossa. Okay. So you can remember that the doctors are never hungry, or Tom, Dick, and nervous Harry. Tibialis posterior, flexor longus, positibial artery, nerve is the tibial nerve, and flexor hallucis longus. Okay. Now on the medial side, no muscle except at the upper part. So you can remember the sartorius, gracilis, and semitendinosus. One ligament is there, that is a tibial collateral ligament. How can you remember? The funny formula is Salman Gadhe se takraya. Yes, among these three muscles are known as the gyre muscles. It is a ligament, so you can leave it. Done. Now, few extra question. Look here. Movement at ankle joint. There's an extension and flexion. Entry compartment is causing the extension. It is supplied by the deep peroneal nerve. Okay. Flexion is done by the posterior compartment muscle, and tibial nerve is the answer. Okay. While at the subtalar joint, there is an inversion and eversion. Which muscles are powerful inverter? Answer is tibialis anterior, tibialis posterior. And which muscles are powerful everter? Peroneus longus and peroneus brevis. Okay. One special movement at the knee joint. Okay. That is a unlocking muscle, popliteus, locking muscle, quadriceps femoris. So your formula is the UPLQ. UPLQ. Okay. Fine. Done, everyone. Fine. Now, after this last topic of the lower limb, that is the arches of foot. So in the leg, in the foot, there is a medial longitudinal arch, lateral longitudinal arch, anterior transverse arch, posterior transverse arch. Is it okay? So we are going to look for the foot bone identification. Yes, look here. Again, the food bone identification, they are important. Look here. Sir, question. Largest food bone of the largest food bone, calcaneum. Above the calcaneum, whatever the bone, say the talus. In front of the talus, sir, boat-shaped bone, that is the navicular bone, articulating with the medial, intermediate, lateral cuneiform, which is articulating with the first, second, third metatarsal. And on the lateral side, can you see, this is a cube-shaped bone, cuboid bone, which is articulating with the, yes, fourth and fifth metatarsal. And here you can see the phalanges. Is it okay? Fine. Okay, sir. So these are the facts which you have to remember. Now see, the medial longitudinal arch is formed by the magic of three. 1, 2, 3. Three metatarsal. Yes, medial, intermediate, lateral. Then navicular bone, talus bone, and medial half of the calcaneum. Three tarsal bone. And the cuboid bone, lateral longitudinal, which magic of two. Fourth and fifth metatarsal. And two cuboid and lateral half of the calcaneum. Okay. Yes. Here you can see the inversion and eversion, which I already taught you. Okay. And whatever I told you, the arches of foot, all the magics are written here. Okay. Now look here, sir. If there is a problem, there is a, yes, identification of foot bone, that is important. That is easy also. But if there's problem in the foot bone, then most common congenital abnormality of the world, you will see, that is the, yes, foot deformities. So congenital talipes equinovarus, it is the most common congenital abnormality of the world, which is the club foot. The order of the correction, you know, CAVE. First you have to treat the cavus, then adduction, then varus, and then equinus. Okay, so just observe this one. Just observe this one. Yes, look at this part. Yes, see, when you are walking on the toes, this is the equinus, घोड़े की तरह कूद कूद के चलेगा. And when any person is walking on the heel, then it is the talipus calcaneus. When any person is walking on the outer border, outer side means rum, so this is the varum. And when anyone is walking on the inner side of the foot, then it is a valgum. And most common congenital deformity is the, yes, equinus and the varum. So look here, equinus as well as outer side, so varum. So this is the, yes, CTEV. Fine. When concavity is more, this is the, yes, cavus deformity. When it is flat, then planus deformity. Okay, is it clear? Fine. So these are the things which you have to remember. Yes sir. तो इसको भी मैं स्टोरी पे शेयर कर देता हूँ ताकि तुम लोगों को आराम से मिल जाए. राइट सर. जिस तरीके से तुम लोग का एग्जाम आ गया है, वैसे ही इनका भी एग्जाम आ गया है, तो आधे बच्चे एग्जाम के प्रिपरेशन कर रहे हैं. ओके, फाइन. ओके, ओके सर. नाउ कम टू द नेक्स्ट. राइट सर, क्वेश्चन आंसर. So they are asking about the sciatic nerve posterior dislocation of the hip. Yes, car dashboard injury. They are asking about the varicose vein. Yes, grade 7 vein. They are asking about the, yes, navicular bone, bone identification. Okay. They are asking about the nerves of the lower limb, common pelvic nerve, foot drop. Okay. They are asking about the foot drop again, the neck of the fibula. They are asking again and again about the dermatome. I will teach you the dermatome, don't worry. Sir, they are lateral part of the leg. So lateral part of the leg, better to say the L5. Okay. Now, can you see, again, they are asking the varicose vein, great saphenous vein. They are asking the bursa. So remember, housemaid knee, yes, formula, housemaid knee, preparator bursitis, clergyman knee, infraparator bursitis. Fine. So remember, sometimes they are asking the bursa. Na? Next, identify the structure palpated behind the medial malleus. There is a posterior artery. Yes. Again, they are asking the your tender sign. So gluteus medius minimus, tensor facial artery, they are abductor. Can you see the great saphenous vein? Sir, these is the related with the saphenous nerve. Again, they are asking the saphenous nerve. So the venesection, phlebotomy, lower limb, they are important now. Sir, they are asking about the iliacus and the sauce measure, the iliosauce attached to the laser trochanter. Yes, they are asking again about the bursa. So housemaid knee is there. Okay. Yes. Again, they are asking about the gia, mera, lele, gia, meralgia paresthesia. It is due to the lateral cutis of thigh. Yes. They are asking about the talus ossification. So 6 is also right, 7 is also right. So remember, in the your ready 7 month is given in the Grey's Anatomy 6. Clinical answers are better. So 7 is better answer. Okay, now look here further. Sir, they are asking about the obturator nerve. The scissoring gate. Scissoring gate is due to the obturator nerve. So nose of the lower limb is very important. Again, they are asking about the DOLI, the gluteus medius minimus tensor fascial lata tendon sign. So you have to read that gluteal area. Again, 2022, 2022, one, they're asking about the posterior tibial artery. Again, they are asking in the 2020, the posterior tibial artery where it is palpable between the medial malleus and the medial border of tendocalcaneus. So these are the your topics. इतना ही पढ़ना बेटा, 12 पढ़ना. नाउ वी आर गोइंग टू लुक फॉर द एब्डोमेन पोर्शन. यस, उड़ा देती है नींद कुछ जिम्मेदारियां घर की, रात में जागने वाला हर शख्स आशिक नहीं होता. ओके, वो एफएमजी स्टूडेंट भी होता है. ओके, तो देखा बेटा, लोअर लिम्ब में भी ज्यादा कुछ नहीं है, एब्डोमेन कुछ नहीं है ज्यादा. तो ये सभी चीजें ना ऐसा है कि 15-15 मिनट में खत्म हो जाएंगी. ओके, कोई ज्यादा चीज नहीं बचा हुआ है. यस, आपको लगेगा स्लाइड ज्यादा है, लेकिन क्या है ना, ये इजी पोर्शन है. हेड नेक एंड न्यूरो में बहुत ट्विस्टिंग होती है ना. फाइन, नाउ कम टू द नेक्स्ट. यस, हाँ ये बात भी है, वो एनाटॉमी का टीचर भी होता है. थैंक यू. ये कौन बोला? डॉक्टर वुल्फ. 2 पैक रेडी करो डॉक्टर वुल्फ के साथ. खोपचे में हमारे लिए भी पैक रेडी करो. यस सर. नाउ वी आर गोइंग टू लुक फॉर दिस एब्डोमेन पोर्शन. Okay, so here you will observe the abdomen, anterior abdominal wall, posterior abdominal wall. So here is a linea alba, here is a linea semilis, and you can see the rectus abdominis muscle. Yes, six pack is there, and this is umbilicus. Umbilicus is having the vertebral level L3, L4, and it is supported with the teat and dermatome MCQ. Yes, umbilicus is having the urethral fistula and the fecal fistula. So you'll see this one. Okay, so when you are doing the dissection, you will see the outside muscle, extra oblique muscle. When you will cut internal oblique muscle, then you will cut transverse abdominis muscle. Yes, and at the midline, you can see this is the rectus abdominis muscle. So you can observe the lower free margin of the external oblique muscle, that is the inguinal ligament. So it is dividing in 3. Yes, lacunar ligament, then inguinal ligament, and then pectineal ligament. So these are the 3 ligaments. Okay, now you can observe here, sir, incisional hernia. So when you are giving the incision, the intestinal loop is coming out. So this is incisional hernia. So that's why we have to learn the anterior abdominal wall. See, 8 layers: skin, superficial fascia, deep fascia is absent, then external oblique muscle, internal oblique muscle, then transverse abdominis, then fascia transversalis, then outside the peritoneum, the fat, extra peritoneal fat, and then this is the peritoneal cavity. Question had been asked, neurovascular bundle is located between the internal oblique and transverse abdominis. Now can you see at this lower part, sir, the lower free margin of the external oblique muscle, it is becoming flat. Flat tendon is known as aponeurosis, and its lower free margin is known as the inguinal ligament. So inguinal ligament is the part of the eo muscle. Okay, the viscera which are behind the peritoneum, like the kidney, they are known as the retroperitoneal organ. Okay, and the viscera which are within the peritoneum, they are known as the intraperitoneal organ. Okay, so now we are going to look at this portion, inguinal canal. Yes, it is a topic of the surgery, but once we are going to do, mark my word, hernia is very important. Definitely one question from the inguinal hernia or the diaphragmatic hernia. Okay, so catch this one, sir. 8 layers: skin, then superficial fascia, this one, then external oblique muscle, internal oblique, transverse abdominis, fascia transversalis, yellow fat, then peritoneum. So this is the canal at the inguinal region, inguinal canal. Content: spermatic cord, ilio-inguinal nerve, important. But remember, in female, the spermatic cord is absent. खुदा की बनाई हुई कानात को नहीं बदलना. Okay? Female में spermatic cord नहीं पाया जाता. Yes, it is replaced by the round ligament of the uterus. So these are the content. Now look, what are the boundaries of this inguinal canal anteriorly? So you can see skin, then superficial fascia, then extra oblique aponeurosis. What are the structures making the roof? Internal oblique and transverse abdominis. You can see these two muscles are uniting and they are making the combined joint tendon, conjoint tendon, which is arching back. Yes. It is also participating in the posterior wall. So posterior wall is formed by the conjoint tendon, fascia transversalis, fat, and then peritoneum. While the floor is formed by the your inguinal ligament. Is it okay? Clear, everybody? Okay. Now look, the hernia. Sir, there is a oblique pathway just above the medial half of the inguinal canal, that is the inguinal hernia. So there is a triangular opening. This is the external inguinal ring. 3 questions. It is triangular external, that's why it is in the external oblique aponeursis. It is above the pubic crest. Sir, this is the deep inguinal ring, which is above the, yes, it is oval. यहाँ पर सस्ता नशा हो गया था और ये ओरल हो गया था. ये ओरल नहीं है, ये ओवल है. जो समझ गया वो समझ गया, जो नहीं समझा वो पोगो देखो. ओके, सो दिस इज द ओवल. फाइन. इट इज फाउंड इन fascia transversalis and it is above the mid inguinal point. Got the point? Okay, so this is the inguinal canal, right sir? What are the content, sir? There is the, yes, you can say the spermatic cord, and there is the ilioinguinal nerve, root value L1. Clear? Fine. Right, sir. Now try to understand, sir, two types of the hernia. In old age, muscle wall is weak, so due to the increase in intra-abdominal pressure, the intestinal loop directly they are reaching into the scrotum. This is a direct inguinal hernia. This is medial to the infraepigastric artery. It is within the Hasselbeck triangle. Whatever I told you, it is written in this table. Hasselbeck triangle, can you see the boundary? Medial boundary is formed by the rectus abdominis. Lateral boundary is formed by the infraepigastric artery. Base is formed by the inguinal ligament. Now, indirect inguinal hernia. Indirect inguinal hernia, yes, it is found in the children. Muscle is strong, so it will go first to the deep inguinal ring. So the main bulk is lateral to the infraepigastric artery and outside the Hasselbeck triangle. Then it will reach to the inguinal canal, then superficial, then it will reach to the scrotum. So this is indirect. So mark my word, inguinal hernia and diaphragmatic hernia, they are important topics. One hernia is definitely going to ask. And then we came to the topic of the peritoneum. So I taught you that there is the GIT and there is the peritoneum. So there is a two cavity equally, but then there is a rotation of the GIT. So GIT is falling on one side. So you will see, sir, there is one bigger cavity in front of the stomach, that is a greater sac, and a small cavity behind the stomach, that is a lesser sac. So there is a one, yes, opening between the greater sac and lesser sac. This communication between the greater and lesser sac is known as the foramen of Winslow. Is it okay? Whatever the meso-omentum or ligament in the abdomen, they are nothing. They are the modification of the peritoneum. Is it okay? Now, after this all, I taught you the boundaries of the foramen of Winslow. For that, we did the Pringles maneuver from the surgery. Okay. Sir, this is the foramen of Winslow, which is communicating the greater sac and the lesser sac. So above this foramen of Winslow, liver. Yes, this is the first part of the duodenum, second and third part of the duodenum. So inferior bond is formed by the first part of the duodenum. Entry bond is formed by the free margin of the laser omentum, where the portal vein, hepatic artery, bile duct are located. Means VAD. And posterior bond is not visible. So the same thing we did here. Sir, this is the foramen of Winslow. Superior bond is formed by the chordate lobe or chordate process. Inferior bond is formed by the first part of the duodenum. Entry bond is formed by the vein artery duct. Posterior bond is formed by the inferior vena cava, suprarenal gland, and T12 vertebra. Is it okay? Clear? So this epiploic foramen is important. Yes. Questions, we did this all for the proper concept, but finally you have to know this one. Okay. So look here. This is the falciform ligament attached to the liver. This is the stomach. So here's the laser omentum within the free margin of laser omentum. Just try to understand this is the portal vein. Yes, hepatic artery and the bile duct. So this is looking like the face of the Mickey Mouse. So can you recall? I told you portal vein, hepatic artery, bile duct. But when the portal vein pressure is increased, so portal vein is increased, but both are normal in size. So this is looking like the face of the Mickey Mouse. That is a Mickey Mouse sign. The many places you will see the Mickey Mouse sign, but one portal triad in the free margin of the laser omentum. Okay. Now this is the question of the radiology. For this one, we practice the anatomical image. So this is the liver on the right side, falciform ligament. This is the laser omentum, free margin. Yes. Now see, this is the spleen and here is the kidney. So the ligament between the stomach and spleen is known as the, yes, spleno, you can say spleno, gastrosplenic ligament, gastrosplenic ligament. Within the gastrosplenic ligament, which vessels are there? Sir, short gastric vessels. And this is the ligament between the kidney and spleen. So you can say splenorenal ligament. Also, you can say lenorenal ligament, in which the splenic artery is running. So whenever you are performing the splenectomy operation, you have to ligate this one. Whenever you are doing the stomach surgery, you have to ligate this one. Okay, so these are the things which you have to remember. This is the epiploic foramen. So the greater sac is communicating with the laser sac through this epiploic foramen. This is a transverse section. At which vertebral level this is located? Remember, T12 vertebral level, the epiploic foramen is located. Now you can see easily the image: liver, left side is stomach, bed of the stomach is formed with the spleen. Yes, so vertebra and aorta you can identify. Here is the inferior vena cava, and at the hilum of the spleen, the pancreas tail is there. Is it okay? Is it okay? Fine. Okay, sir. अभिषेक गजुला, छी 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 छी, कितना अश्लील है ये लौंडा, कैसा अश्लील क्वेश्चन करता है, छी 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 छी। कौन है? ले खोपचे मिले इसको। छी 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 छी, बहुत गंदा लड़का, बड़ा अश्लील है, बड़ा अश्लील है ये। जा, मैं तेरे से बात नहीं करूंगा। यस, आएगा आएगा। तुमको बड़ा इंटरेस्ट आ रहा है ना उसमें, आएगा, बताऊंगा भी, आएगा। ठीक है। ओके। ये कौन है? आएगॉन टारगारियन। इसको बड़ा अभिषेक का साथ देने का मन कर रहा है। ले इसको भी खूब चमेली। ओके, yes. So now see, we are going to look the branches, the artery supply. Okay, foregut is supplied with celiac trunk, midgut is supplied with supramesenteric artery, hindgut is supplied with the inframesenteric artery. Celiac trunk 3 branches, supramesenteric artery 6 branches, inframesenteric artery 3 branches. So 363 is your formula. Okay, clear? हाँ, ट्राइसोमी 69। ये कौन सा ट्राइसोमी आ गया भाई? ये तो गजब का ट्राइसोमी है। सेरिबेलम में पूछना पड़ेगा कि ये ट्राइसोमी 69 साला कौन था। ट्राइसोमी तक तो ठीक है, उसके बाद वाला नंबर बड़ा डाउटफुल है। ओके। अच्छा, पार्शियल मोड में होता है क्या? अच्छा, 23 23। अच्छा, ये है, अब समझ में आया। मेरा कॉन्सेप्ट क्लियर कर दिया भाई। अच्छा, ठीक ठीक है, ऐसा भी हो सकता है। ओके, नाउ कम टू द नेक्स्ट। Okay, celiac trunk, 3 branches: left gastric artery, splenic artery, and common hepatic artery. Sir, supramesenteric artery, it is supplying the duodenum, then jejunum, then ileum. So duodenal artery, jejunal artery, ileal artery. Then ileocecal junction, ileocolic artery. Then right colon, right colic artery, and then middle part of the colon, middle colic artery. While the inframesenteric artery, it is supplying the left side of the colon, left colic artery, sigmoidal artery, and this is superior rectal artery. Right, sir? Now, these are the branches of the celiac trunk. Hope you all had studied in the surgery. Surgery में पढ़ोगे? Okay. So look here. This is celiac trunk, left gastric artery, splenic artery, common hepatic artery. Yes. This left gastric artery is supplying the lower end of the esophagus by the esophageal branches. Yes, it is giving the short gastric artery. It is giving the one big branch, that is the left gastroepiploic artery, important for the surgery. And this common hepatic artery is dividing into the proper hepatic artery and the gastroduodenal artery. This proper hepatic artery is dividing into left hepatic and right hepatic artery. Right hepatic artery is giving the cystic artery, which is supplying the gallbladder, which is the end artery. While this gastroduodenal artery is dividing into the superior pancreaticoduodenal artery, and another is your right gastroepiploic, which is anastomosing with the left gastroepiploic artery. Is it okay? Clear? Right. Now look, few important relation for the surgery. So look here, esophagus, stomach, D1, D2, D3, D4. D1 is at the L1, D2 is at the L2, and D3 is at the L3. Is it okay? Fine. Now within the C loop of the duodenum, the head of the pancreas is located, and at the hilum of the spleen, the tail of the pancreas is located. Okay. So whenever you are doing the splenectomy operation, the tail is sacrificed. It is reaching the beta islet cell. Insulin secretion is done. So if it is gone, then diabetes is the complication. Now, one very, very nice formula to remember the vertebral level. Okay. Okay. Yes. D1 is at the L1, D2 at the L2, D3 at the L3 vertebral level. And length, you can see 1, 2, 3, 4 inches, total 10 inches. 1 inch means 2.5 centimeters. So 10 inches means 25 centimeter. MCQ. What are the structures having the 25 centimeter length in the body? Your form is a DUDES, dudes. D for duodenum, U for ureter, D for descending colon, E for esophagus, and S for stomach. Sometimes such questions are asked, that's why. Okay. Now, look here, the D1, L1. So, foramen of Winslow at the T12 level. Okay, sir. So, look here, the pancreas. One question from the pancreatitis. Acute pancreatitis is more commonly asked. Sometimes the chronic pancreatitis and rarely the pseudopancreatic cyst may be asked. But get ready one question from the pancreatitis. So, you can see the head, neck, body, and tail. Head is having the one projection uncinate process, and tail is having the tubal omental. Celiac trunk is here, which is giving the splenic artery running along the upper border. So whenever there is acute pancreatitis, this splenic artery is showing the aneurysm. Is it okay? It is showing the aneurysm. Okay, right, sir. Now, about the portal vein, three statement you have to remember. Portal vein is equal to splenic vein plus supramesenteric vein, S plus S. It is formed behind the neck of the pancreas at which vertebral level? L2. No excuse with these three lines. So catch this one. Again, sir, splenic vein plus supramesenteric vein is equal to portal vein. It is dividing the right and the left division. So it is draining to the right lobe and the left lobe. Is it okay? Sir, right lobe is small and left division is longer. So whenever there is an infection, yes, maybe liver disease, hepatocellular carcinoma. So supramesenteric vein, yes, inframesenteric vein, splenic vein, the blood is coming into the right side, portal vein. Now it is having the two pathway. Remember, everyone likes what? मोटा भले ही वो रहे छोटा. So the infection, it is going to the right side. Yes, left division ये पतला है लेकिन लंबा है. But they will not go in this way. So right lobe is more commonly infected and getting cancerous cell. Okay, so these are the things which you have to remember. Now look, clinical integration. Alcoholism, one question जरूर आ रहा है ना. In case of the alcoholism, there is a fibrosis, cirrhosis, which is leading to the portal hypertension. And in medicine, you had studied splenomegaly, ascites, hematemesis, capitomedusi, piles are common. How? See, sir, in case of the cirrhosis, it is getting fibrous. So the blood is getting filled within the portal vein. So there is a portal hypertension in cirrhosis. Now the blood is getting filled in the splenic vein. So spleen is getting enlarged. That's why splenomegaly. Now blood is reaching filled into the supramesenteric vein as well as inframesenteric vein. So there is a ascites in the abdomen. Now it is having the branches which is anastomosing at the lower end of the esophagus. So it is getting rupture and causing the hematemesis. So it is going to the umbilicus. So the umbilicus veins they are getting, so there is a capitomedusa. Sir, this inflammatory vein is reaching to the rectum. So the rectum is also having the blood, that is a piles bowel. Is it okay? Clear? Again, can you see the portocaval shunt? Sir, this is the portal vein, this is the vena cava vein. They are meeting at the lower end of the esophagus, around the umbilicus and the piles and the anal canal. So if it is getting dilated, there is a hematemesis. If it is getting dilated, then there is a capitomedusa. And if it is getting dilated here, then there is the, yes, you can say piles. So hope you know the Hollywood story, the medusa, it is coming from the anatomy, the capitomedusa. Okay, sir. Now the last part. Sir, this is the inferior vena cava anti and this is the abdominal aorta uncle. Yes, Rajmouli uncle got inspiration from aorta and the inferior vena cava from the anatomy. Rajmouli uncle is also my student. Yes, Bahubali uncle, Devsena auntie, all joined the CBI classes. So they got inspiration for the movie. So you know this scene. Yes, you know this famous Hollywood movie. Both are my student. In this movie, you can see the heroine is enjoying the ship and hero is enjoying the heroine. Okay, fine. So remember this, all the Hollywood, Bollywood, Tollywood, they are arising from the anatomy. So you can see this is the Bahubali uncle, the aorta. Fine. So you can see the eye, nose, mouth, ear. ये फेस है हमारे aorta का. This is the upper limb, this is the lower limb, and this is the nipple of the bahuli. This is the, yes, umbilicus of the bahuli. Okay. और यहाँ पर बेटा बीडी चौरसे सर ने, है ना, बाहुबली का पेनिस बनाना भूल गया था, वो एक्चुअली क्या है, मीडियन सैक्रल आर्टरी. सो इन दिस वे यू कैन डू इमेजिनेशन ना. अब भूल के दिखाओ, अब भूल के दिखाओ द ब्रांचेस ऑफ द एओर्टा. ओके. Is it okay? Is it clear, everyone? Right, sir. So you can see the abdominal aorta, ventral branches, lateral branches, terminal branches, and the dorsal branches. So ventral branches, celiac trunk, supramesenteric artery, inframesenteric artery. Look here, sir. There is a celiac trunk, then supramesenteric artery, and then if they will arise on the front side. So celiac trunk is between the titular L1, supramesenteric artery L1, inframesenteric artery L3. Every point is MCQ. Sir, here is the right kidney, left kidney. During the development, they are sometimes having the fused lower lobe. So this is the horseshoe-shaped kidney. Now, when it will ascend, the inframesenteric artery will stop the ascent. So this is at the L3. That's a horseshoe-shaped kidney. Horseshoe-shaped kidney is at the level of the inframesenteric artery, which is having the yes flask-shaped or shaking hand pattern. Are you getting the radiology integration, medicine, surgery, radiology? Okay. Also, the lateral branches. Your formula is the IMRT, Imrati, the brother of the jalebi. Okay, so you can see infraphrenic artery, middle suprarenal artery, renal artery, and testicular artery. Remember, testicular artery is replaced by the ovarian artery in the female. Okay, now terminal branches. Common iliac artery is dividing into right and left, two common iliac artery. The aorta is dividing into two common iliac artery. Okay, sir. And last, the dorsal branch, that is median sacral artery. Yes, it is the most important artery for the obs gynae, for the colporrhea surgery. दिस इज द पेनिस ऑफ द बाहुबली. तो बेटा बीडी चौरसी सर ने इसको नहीं बनाया, लेकिन ये इंपॉर्टेंट है. ये इंपॉर्टेंट है देवसेना के लिए, और सॉरी ये इंपॉर्टेंट है बाहुबली के लिए, और बाहुबली से भी ज्यादा इंपॉर्टेंट है देवसेना के लिए. यस, दिस द मीडियन सैक्रल आर्टरी. जो समझ गया वो समझ गया, जो नहीं समझा वो पोगो देखो. सो नाउ सी, दिस मीडियन सैक्रल आर्टरी इज एट द मिड लाइन. Sir, in front of it, there is the uterus and vagina, rectum, and behind there is a sacrum. So whenever you are doing the colporrhea, posterior colporrhea, at that time it is in front of the sacrum. So avoid the ligation of this artery. If you will compress this artery, there may be the ischemia. तो बेटा इसका इकलौता यूज वहां पर आएगा. You will see there ना. Now look the interiliac artery branches. So remember this Sunny auntie. जब हम लोग छोटे थे तो बस यही कलाकारी करते थे. ओके, फाइन. सो व्हाट यू हैव टू रिमेंबर, सर, the intellic artery is having the anterior division, posterior division. Posterior division is having the I love Sunny. I for iliolumbar, L for lateral sacral, S for superior gluteal artery. Remaining all are, yes, you can say the branch from the anterior division. So what are the arteries for the anterior division, for the this particular anterior division part? Okay, sir, there is superior vesical artery and inferior vesical artery. These are supplying the bladder. These are branches of the anterior division. Sir, uterus and the vagina, uterine artery, vaginal artery, very important for the obs gynae. These are branches from the anterior division. Can you see the rectus of the superior rectal artery, middle and inferior rectal artery? Superior rectal artery was a branch from the inframesenteric artery, but middle rectal artery is the direct branch, and inferior rectal artery is the indirect branch of the anterior division. Anterior division is giving the interpudendal artery, which is giving rise to the inferior rectal artery. Optic artery, inferior gluteal artery are also there, but these are not important. So just remember the viscera of the lower part of the abdomen, pelvis cavity. Okay, these are the things. Now come to the next CBI-19 PYQs and the PYTs with the bullet train analysis. So can you see the questions are asked from the hernia, indirect inguinal hernia? Yes, this is the one bouncer question. See how you can solve the postulation of the kidney. Doctor prescribed quinine tablet. D for diaphragm, P for sauce major, Q for quadratus lumborum, and T for transverse abdominis. This is the sequence. So look here, the posterior abdominal wall. Sir, kidney is located here. So it is related with the diaphragm. Then sauce muscle. Rarely the sauce minor is also found. So medial is the sauce minor, lateral is the sauce major. Then can you see this quadrangular muscle at the lumbar area, quadratus lumborum, and this muscle is running transversely in the abdomen. So this is the transverse abdominis. So doctor prescribed quinine tablet. This is the formula you can remember. Doctor prescribed quinine tablet. Okay. Next, child presents with the congenital defect. So diaphragmatic hernia, bowel hernia. I will teach you later. Can you see radiating to the back, severe alcohol? So this is pancreatitis, serum amylase. Yes. तो ये आ गया, कौन था वो? अभिषेक था ना? अभिषेक, हाजिरी दो। ये आ गया भाई तुम्हारा चहेता। ओके, तुम इसे ही खोज रहे थे। चलो, सो कैन यू सी सर, this is the liver, here is the common hepatic duct, right and left hepatic duct, and this is cystic duct. So 3C, they are making the Carlos triangle. What are the 3C? Sir, C for common hepatic duct, C for cystic duct, and C for cystic artery. So these 3C are making the Carlos triangle. Don't forget, huh? Sir, content is the cystic lymph node of वही जो तुम्हारे दिमाग में चलते रहता है। ओके, फाइन बेटा, ये वो प्रोनाउंसिएशन नहीं है जो तुम करते हो, ये है लुंड। दिस इज सिस्टिक लिम्फ नोड ऑफ लुंड। ओके, क्या करोगे, अंग्रेजों के नाम ही ऐसे होते हैं। फाइन, गाली देने की जरूरत ही नहीं पड़ती, नाम ही ऐसे ही है। ओके, सो व्हाट यू हैव टू रिमेंबर, सर, इफ इट इज गेटिंग इन लार्ज, देन इट इज कॉजिंग कंप्रेशन ऑफ द, यस, biliary tree. Is it okay? Okay, yes sir. And there is one more triangle, that is a hepatocystic triangle. Hepato means liver, remaining are same, hepatocystic or hepatobiliary, but just remember the inferior border of the liver is there, remaining are same. Done. Now look here, identify the marked structure. So easily you can see, sir, this is the spleen, this is the stomach. So this is the kidney. So this is the arrow between the spleno-renal ligament, lino-renal ligament. Yes, they ask about the ilioinguinal nerve, inguinal hernia. They are asking about the lines. So I told you transpyloric line, L1 lower border subcostal plane, L3 upper border transtubercular plane, L5 upper border. So you can remember the 1, 3, 5. This is the odd number magic. Okay, so they are asking about this portion. So easily you can identify the liver, this is the pancreas, here is the spleen part. Okay, now they are asking true acceptor. So remember this again, inguinal canal part. Okay, so the conjoint tendon, it is not parallel to the inguinal ligament. Okay, now Hazelbeck triangle, inferior gastric vessels, lateral boundary. They are asking about the plane. So you can see this is the transpyloric plane found at the L5. Yes, they are asking about this particular splenic vessels which are running in the, yes, you can say that line, splenorenal ligament. Okay, splenorenal ligament. They are asking about the subcostal plane which is at the L3. They are asking about the umbilicus vertebral level L3, L4. Yes, so these are the things. So get ready for the session. मानव, मानव जब जोर लगाता है पत्थर पानी बन जाता है। यह देख गगन मुझ में लय है, यह देख पवन मुझ में लय है, मुझ में विलीन झंकार सकल लय है, मुझ में संसार सकल अमृत तोड़ता है, मुझ में संहार झूलता है, मुझ में उदयाचल दीरा दीप्त भाल, वो मंडल वक्षस्थ विशाल भुज परिधि बंद को घेरे हैं, मैनाक मेरु पग मेरे हैं, दिखते जो ग्रह नक्षत्र निकट सब है मेरे मुख के अंदर, शतकोटि सूर्य शतकोटि चंद्र शतकोटि सरित सिंधु मंत्र, भूलोक अतल पाताल देख, देख गत और अनागत काल देख, यह देख जगत का आदर्शन, यह देख महाभारत का रण, लाशों से पटी हुई वो है, पहचान कहाँ इसमें तू है, मानव जब जोर लगाता है पत्थर पानी बन जाता है। ओके, फाइन। टीटीपी, ट्रांस ट्यूबरकुलर प्लेन, फाइन, क्लियर। ब्रेक लेना है, एक लास्ट ब्रेक, वन लास्ट ब्रेक, हाफ एन आवर बेटा, है ना, ये 11:30 तक ही खत्म हो जाएगा। चलो, एक छोटा सा ब्रेक कर लेते, देन विल कंटिन्यू। लास्ट ब्रेक। Hello, friends. So, are you ready for the last session? Okay. मानव जब जोर लगाता है पत्थर पानी बन जाता है. So, dear friends, now we are going to look for the last portions of the anatomy. So, look here, sir. Pelvis in the perineum. Sir, we are looking this pelvis and the perineum portion from the three view. It is important for the genitourinary surgery. It is important for your obs gynae. So look, observe this beautiful anatomy. Can you see right hip bone, left hip bone, sacrum? So we will see this pelvis part from the upside. Yes, from the downside, from where the baby is coming out. This is the perineum area between two thigh, and then we will do the section. You can say this one coronal section, and then we will observe. So three view. First, we are looking the downside view. So when you are looking the downside view in the lithotomy position, you can see the area between two thighs is known as the perineum. In the male, two openings, the genitourinary opening and the anal canal. But in female, sir, the genital opening, urinary opening and anal canal opening are separate. So in the female, three openings are there. So when you will do dissection, skin, superficial fascia, deep fascia, then muscles, then bones will be visible. So what is this? These are the boundaries of the perineum. So entry boundary is formed by pubic symphysis. Anterolateral boundary is formed by the ischiopubic rami. Lateral boundary is formed by the ischial tuberosity. Posterolateral boundary is formed by the sacrotuberous ligament. Posterior boundary is formed by the sacrum and the coccyx. Okay, sir. The imaginary line is passing through the two ischial tuberosity. So it is dividing into the anterior triangle, posterior triangle. In the anterior triangle, sir, there is a urethra and the vagina opening. And in the posterior triangle, anal canal opening is there. Okay. So this anterior triangle is known as the urogenital triangle, while the posterior triangle is known as the anal triangle. Yes. This is the central tendon of the perineum, which is also known as the perineal body. Agree? Okay. Now catch this one further. Sir, at this part, central tendon of the perineum, which is having the tail muscles insertion, so never cut this structure in any operation like the episiotomy. So total, there are the 10 muscles. Yes, this is the division. Perineum area between two thigh, urogenital triangle and anal triangle. Urogenital triangle is divided into superficial and deep pelvic pouch, while the anal triangle is divided into the right and left ischiorectal fossa. Yes. So these are the list of the 10 muscles which are inserted into the perineal body. Okay. Right now, what only you have to remember, always give the incision from midline to the lateral side. Never go on the back side. Yes, this is the mediolateral incision. Why? Because if you will cut this perineal body, the 10 muscles are getting paralysis and then it will result into the prolapse of the uterus, prolapse of the rectum. So this is the your surgery and the obs topic. So don't damage it. Okay. Now we are looking the pelvis bone from the top. So remember, here is a pelvic diaphragm. How to remember? Sir, this is the coccyx bone. Yes. Here is a pubis bone. This is the ilium bone part. And this one is small ischial spine muscle, ischial bone. So the muscles are arising and ultimately they are inserting into the coccyx. So the first muscle is the pubococcygeus. Next is the iliococcygeus. And this is the ischiococcygeus. So this all muscles are uniting together and making one sheet of the muscle and the same on the opposite side. So these are acting like a sheet which is separating the abdominal cavity from the pelvic cavity. So these sheet like muscles are known as, yes, you can say pelvic diaphragm. So just remember the three things. Pelvic diaphragm is equal to pubococcygeus plus iliococcygeus plus ischiococcygeus. Sir, this pubococcygeus and iliococcygeus, they are elevating the anal canal. So these two are known as the levator ani, while this ischiococcygeus is a small muscle. So you can say pelvic diaphragm is equal to levator ani muscle. Is it okay? Clear. Now catch the coronal section. So in the coronal section, you can see the rectum, you can see the anal canal. Yes, sir. The narrow part is the anal canal. So here you will see the internal sphincter. Outside you will see the external anal sphincter. So there is a narrow constriction between the internal and external anal sphincter. That is the intersphincteric line, which is white in color. That's why white line of Hilton. Okay. Now see, sir, this anal canal is having the one muscle. When these muscles are contracting, they are elevating the anal canal. So this is known as the levator ani. It is dividing the upper and lower cavity. That's why it is just like the diaphragm. So this levator ani is equal to, yes, pelvic diaphragm. Now look here, sir. If anyone is not drinking the water properly, so he or she is having the hard stool. So now this hard stool will make one crackling in the mucosa. So this is the anal fissure. Now the fecal material is causing infection pus in this space, which is between the ischium tuberosity and anal canal. That's why it is ischioanal fossa. Also, you can say ischial tuberosity and the rectum. So this is known as ischiorectal fossa. So this is known as the anal abscess. And in very severe cases, this is getting open on the outside. Yes. So it is having the two opening. Two opening means you can say this is a, yes, anal fistula. Too much pain in this situation. So remember the song dedicated for this anal fissure, anal fistula. Also the piles portion. Yes. छुपाना भी नहीं आता, बताना भी नहीं आता. Yes, in this condition patient cannot hide because too much pain is there, and patient cannot say why, because the site of the pain anal canal is very odd. Okay, बड़े बवासीर हो यार, ये है बवासीर. कौन बनाता है? उसके दोस्त बना देते हैं. ओके सर, so remember this one. Now this is the your hemorrhoids grading you will see in the surgery. Now another important topic, that is a urethral rupture. So get ready, one question from the urethral rupture. Huh? So look here, this is diagnostic presentation. Sir, this is the penis, this is the scrotum, and this is the, yes, the perineum. The fascia of this area, Buck's fascia, Dartos fascia, and the Colles fascia. So your formula is the BD चौरसिया. हाथ में लिख लो BDC. Buck's fascia, Dartos fascia, and Colles fascia. Now can you see this is the perineal membrane? This perineal membrane is also known as the urogenital diaphragm. Yes. Below it, superficial penile pouch. Above it, deeper penile pouch. So now the urethra is coming from the bladder and going outside. So what are the parts of the urethra? Within the prostate, prostatic urethra. Within the perineal membrane, membranous urethra. Now bulb-like small dilated part, bulbar urethra. And within the penis, yes, penile urethra. Remember, female में penis नहीं होता. That's why in the female, the urethra is shorter. MCQ. In the male, 20 centimeter. In the female, 4 centimeter. Getting the point? Fine. Okay, sir. Now, look here further. Sir, because of the shorter urethra, the UTI chances are more common in female. Okay, sir. Now see the urethral rupture. Sir, if any person is walking here and there and the manhole is hitting in between the two thigh, now what will happen? उसका खानदान आगे नहीं बढ़ेगा. Okay, so try to understand this is a perineal injury, fall stride injury, manhole injury. So look, most common site of the urethra rupture is bulbar urethra. MCQ. Most common cause is the instrumentation. MCQ. So when this bulbar urethra is getting rupture, sir, urine is coming out from here and it is getting filled into the, yes, superficial penile pouch, penis, and it can go up to the anterior abdominal wall. Yes, it can go up to the anterior abdominal wall. Is it clear? Clear? Yes, sir. It is going up to the anterior abdominal wall. Now try to understand. Sometimes there is a rupture at the membrane, so the urine is accumulating into the deep penile pouch. So this all area are normal. So this urethral rupture will be asked in your clinical. On the basis of the anatomy, you will be able to solve. Now, one question shown from the prostate gland. Why? Due to the, yes, BPH. Look here, prostate. So there is a ductus deferens, seminal vesicle. These are uniting and making the ejaculatory duct. So in front of it, you can see entry lobe. Behind it, posterior lobe. This is the middle lobe. Okay. Yes, this is opening into posterior utricle, prostatic utricle. This prostatic utricle is also known as the male uterus or vagina. Now this is the front view. So you can see, so right lobe, left lobe. So this is prostatic crest, urethral crest, where these three opening, the posterior utricle and ejaculatory ducts are there. Now see, this is the internal urethral sphincter. Here is the external urethral sphincter. So whenever there is ejaculation, it is going deep. These sphincters are closing the pathway. But suppose if any surgery and these are getting damaged, then ejaculation is upside. दिस इज द रेट्रोग्रेड इजैकुलेशन। अब ऐसा मत सोचना कि इधर मजा आ रहा था तो ऊपर जाएगा तो और मजा आएगा, दो दो जगह से मजा आएगा, ऐसा नहीं है ना। इट विल क्रिएट द कॉम्प्लिकेशन। फाइन, इट इज नॉट a normal thing. Okay, so look here further. Sir, in the prostate, when you are looking from the top, so this is the entry lobe, posterior lobe, right lobe, left lobe. This is the median lobe, which is producing the uvula vesiculae. One time they asked the question over this uvula vesiculae. Is it clear? Clear? Okay, sir. Now look at the clinical. Sir, this is the prostatic urethra. So when in the periurethral zone there is a growth, that is a BPH, and when there is a abnormal growth on the peripheral side, that is commonly the prostate cancer. Okay, sir. So what is the treatment for this all? Remember, any old patient is coming to you with the frequency, urgency, hesitancy. Then you will give the alpha blocker. What are the alpha blocker? Phenytoin and floxybenjamin. But these are non-selective. So give the alpha 1 blocker, that is prazosin, but still it is having the first dose effect. So it is not. So nowadays we are giving the alpha 1A blocker, that is tamsulosin. Along with it, we are giving the 5 alpha reductase inhibitor, that is a finasteride. It is the best treatment. And if not treated, then go for the transurethral resection of the prostate gland. In this surgery, we are going through the urethra, and now we are cutting the prostate gland from the inside. But what is happening when you are going from the inside? Suppose this is known as the environmental. Suppose you are going above and you are destroying this structure, then ejaculation is opposite in direction also. That is a retrograde ejaculation. So TURP surgery is having the one drawback, that is a retrograde ejaculation. So don't forget this fact. Okay, sir. Now pelvis, the point. Sir, this is a bladder, this is the rectum. So this is a rectovesical pouch, which is the most dependent part in the male in the erect posture. So if you have to treat, then you have to puncture, then aspire, then inject the antibiotic, and then re-aspire. Okay, so these are the things which you have to remember. While in the female, sir, there is a rectovesical pouch, and this is the rectouterine pouch, which is known as pouch of Douglas. So in female, this pouch of Douglas is the most dependent part. So you have to puncture, you have to aspire, you have to inject the antibiotic, and then if needed, re-aspire. So these are the important facts. Yes, one more thing. When the patient is sleeping, then infection pus is reaching here. This is the space between the liver and kidney. So this is a hepatorenal pouch, which is also known as the Morrison pouch. Most dependent part of the body in lying down position. Yes, it is the site for the pus collection. So now we are looking for the PYQs, PYTs. So they ask in the male the rectovesical pouch, but if it is not given, then pouch of Douglas. Okay, sir. Yes, they ask about the venous plexus, Batson venous plexus, which is responsible for the cancer spread. They ask about the urethra rupture. So urethra rupture, urethra parts, they are important. Now they are asking again urethra rupture. Again, I want to tell you, bulbar urethra rupture is more important, common. And now we are going to enter in the thorax part. Okay, so just I'm coming. फैन बस ऑन कर देते हैं. Okay, yes, so now we are going to look for the thorax. कोई लक्ष्य मनुष्य के साहस से बड़ा नहीं, हारा वही है जो लड़ा नहीं. इसका मतलब आज से लड़ाई चालू कर दो, सामने से जो भी आता दिखे पीट दो साले को. ओके, यस. So now look the intercostal space. What you have to remember, sir, the space between the two rib. So outside extra intercostal muscle, inside interintercostal muscle, and most inner side, that is the innermost intercostalis. So you will see the costal group where the intercostal vein, intercostal artery, intercostal nerves are located. Same thing with this image. Can you see? Rib above, rib below. So there is the extra intercostal muscle, interintercostal muscle. Yes, this is the innermost intercostalis. At the costal group, intercostal vein, intercostal artery, intercostal nerve. So always you have to do the thoracocentesis along the, yes, lower rib, upper border to avoid the injury to the neurovascular bundle. This neurovascular bundle is running between the second and third muscle layer. Okay, this thoracocentesis or paracentesis thoracis is done in the at the intercostal space at the mid axillary line. Okay, so these are the things. Also remember that this van relation is everywhere except in first intercostal group where the relation is the AVN, just like the popliteal fossa. Okay. Now look here, the trachea pattern. So you will see the branching pattern of the respiratory tree. So look here, sir, this is the trachea reaching to the carina. Now right and left lung, so right and left primary bronchus. Yes, it is the principal bronchus. Now the right lung is divided into three lobes. So it is dividing 1, 2, 3 lobar bronchus, secondary bronchus. Now each lobe is having the segments. These are the known as the bronchopolar segment. Okay. So there are the 10 bronchopolar segments, so 10 tertiary bronchiole. On the left side, two lobes, that's a two lobar bronchus. Fine. So this is the way. Further, you will see the respiratory unit in your physiology part. So now again, right lung, three lobes, left lung, two lobes. In the left lung, there is a cardiac notch and the tongue-like projection, that is a lingula. Okay, sir. Now you will see in the right lung, sir, there are the 10 bronchopolar segment, and in the left lung, 10 bronchopolar segment. So you have to remember 10 by 10 is the best answer. Sometimes in the left side, 9 or rarely 8 bronchopolar segment may be found. Is it okay? Fine. So catch this one. Sir, most common site of the foreign body or infection? Sir, the right lung, this posterior basal segment in erect posture. But when the patient is sleeping, then gravity dependency is changing. So this is the apical basal part which is getting infection, pus collection. Okay, fine. Now look further, the mediastinum. Just one simple topic. Sir, this is the external angle of the Lewis, MCQ, which is passing through the lower part of the T4, MCQ. MCQ, na, it has been asked. So above it, superior mediastinum, below this imaginary line, inferior mediastinum. This inferior mediastinum is dividing into the anterior, the posterior, and the middle mediastinum. Okay, fine. So these are the points which you have to remember. Next, one question sure from the coronary circulation. The most common cause of the death in the world is a, yes, you can say the blockage in these blood vessels. That's why. Okay. So you can easily see, so right atria, right ventricle, left atria, left ventricle. So is the right coronary artery, there is a left coronary artery. Okay. Apex of the heart. When you will turn left atria, right atria, they are making the base of the heart, posterior surface. So left atria, left ventricle, right atria, right ventricle. Okay, sir. We started the story from the Nibba Nibbi heart, four chambers. Then we tilted three MCQs. Sir, right border of the heart is formed by only right atria. Sir, apex of the heart is formed by only left ventricle. Posterior surface or the base of the heart is mainly formed by the left atria, 2/3, and 1/3 by the right atria. Only these three MCQs you have to learn in the anatomy. Is it okay? Okay, sir. Now these are the same thing. So we had seen the blood supply. Look here. So this is the ascending aorta, arch of aorta, descending aorta. This is the root of the aorta. So here is the three cusp, 1, 2, 3. So there is three cavity. From the anterior cavity, which is known as the anterior aortic sinus, one MCQ. Yes, it is running on the right side and going on the back side. It is giving the three major branches. Your formula is the MTP, medical termination of the pregnancy. One question sure from the MTP. अगर एमटीपी से क्वेश्चन आया तो मैं दावा करूंगा कि ये एनाटॉमी से आया है. ओके, फाइन. आई वांट टू से दैट एमटीपी इज इंपॉर्टेंट ना. यस. ओके. यस, हियर एम फॉर मार्जिनल आर्टरी, टी फॉर ट्रांसवर्स आर्टरी एंड पी फॉर पोस्ट इंटरवेंट्रिकुलर आर्टरी. बेटा ये याद रखना, ये ऑलरेडी ना क्वेश्चन पेपर लीक होता है, उसको अलग से लीक करने की जरूरत नहीं है. पता नहीं अननेसेसरी लोग क्यों मेहनत करते हैं. ऑलरेडी वो लीक होता है. यस, इधर से घुमाएंगे उधर से घुमाएंगे, बट यस दे विल गिव द क्वेश्चन ऑन द HIV, ऑन द एल्कोहलिज्म, ऑन द TB, ऑन द लेप्रोसी, समटाइम्स द मलेरिया. यस, कैंसर, द प्रोस्टेट कैंसर, द सर्वाइकल कैंसर, आने ही आना है. ठीक है. कोरोनरी सर्कुलेशन डायबिटीज से आएगा. ओके. यस, कैंसर से आएगा. तो टॉपिक फिट है बेटा, है ना. 20% थोड़ा बहुत इधर उधर वो करेगा. फाइन. सो दैट्स व्हाई द PYQ PYT दे आर वेरी वेरी इंपॉर्टेंट. वो जरूर देखना. ठीक है. आप कल क्लास करो, लेकिन बाद में बेटा हमारा जो सेशन है उसका ना वीडियो जरूर देख लेना. ठीक है. PYQ PYT वन लाइनर. फाइन. नाउ come to the next. Sir, this posterior interventricular artery, M for marginal, T for pi y artery. This is deciding the cardiac dominance. 90% people they are right cardiac dominance, 10% they are with the left cardiac dominance. One more, the atrial branch which is supplying the SA node is known as the SA branch. 60% cases it is the branch from the right coronary artery, 40% it is the branch from the left coronary artery. Now look for this, sir. The left coronary artery it's arising from the left side posterior side aortic sinus. Now it is dividing into the IVA and it is the left circumflex artery. Okay, sir. Sir, this is the artery which is running like the diagonal. So this is the diagonal artery. Is it okay? Fine. Now catch this another point. Sir, there is the male and the female, right? Males are getting death. Okay. So you can remember the DAL, DAL. Okay. Fine. So diagonal artery, IVA and the left circumflex. This IVA is also known as the the artery for the left anterior descending artery. So Hollywood, Bollywood, Tollywood, all are rising from the anatomy. Yes, even the brand's name they are coming from the anatomy. Yes. So this is a left anterior descending artery. कोई भी यहाँ पर बीच में W नहीं लगाएगा. Okay. Yes, this is the LADA. Fine. This is the most common cause for the death. It is a artery which is getting blocked in the MIN angina. Okay, sir. Now try to understand further. Okay. सर आपने ही लगा दिया. अरे स्नेह सिंह, ये तो कितने देर बाद आया स्नेह सिंह, है ना? ठीक है, मैं लगा सकता हूँ, तुम नहीं लगाओगे. तुम लोग अच्छे बच्चे हो, मैं बुरा बच्चा हूँ. ओके, यस. नाउ कम टू दिस. दिस लाडा इज नोन एज अ विडोज आर्टरी और विडो मेकर आर्टरी. ओके सर, मैं यही थी 5 बजे से. स्नेह सिंह फिर ये गड़बड़ हो रहा है. ये स्नेह सिंह की स्नेहा सिंह है. अरे ऐसा कैसे हो सकता है यार, कैसे लड़की हो सकता है यार? तुम लोगों को कैसे पता क्यों लड़की है करके? और नहीं तो कैसे दिखेगा? अबे स्नेह सिंह लड़की है, लड़का है. चलो. So what you have to remember, sir, this is the your widow's artery, widow maker artery, right? Okay, sir. Now come to the next, sir. Yes, venous drainage से क्वेश्चन जनरली नहीं आता. Okay, so what you have to remember, only these lines. Sir, largest vein of the heart, coronary sinus, 3 centimeters length. Coronary sinus is located on the left side, posterior side between the atria and the ventricle. So this is what atrioventricular sulcus. 3 major veins which are opening in the coronary sinus: great cardiac vein, middle cardiac vein, small cardiac vein. Okay, the great cardiac vein is accompanied by the LADA. Yes, entry interventricular artery. Fine. The middle cardiac vein is accompanied by the posterior interventricular artery, and then small cardiac vein is accompanied by the marginal artery. Done. Now all veins of the heart is opening into coronary sinus except enterocardiac vein and venicaudis minimi. This venicaudis minimi is the smallest vein of the heart. It is directly draining into the right atrium. Done. Okay. Now, these are the things which you will learn in your clinical angina, MI, ECG, angiography, angioplasty, and CABG. Remember, the best artery for the CABG operation, that is the left intermammillary artery. Okay, if it is not given, then right intermammillary artery. If not given, then ulnar and radial artery. So this knowledge of the blood supply, it will help you in this all the situations. Okay, sir. So now can you see the diaphragmatic hernia? Yes. So I'm going to tell you the revision now. I'm going to tell you revision. Do you remember? There are the 3 openings, voice of anatomy. तो कई जगह आप पढ़ोगे कि I 8 10 X at 12 PM. तो भैया देखो, इसको याद करने के लिए रात को 12 बजे उठ करके 10-10 अंडे खाने की कोई जरूरत नहीं है. सिंपल सा फॉर्मूला है, सिंपल सा कॉन्सेप्ट है. जस्ट ऑब्जर्व द फॉर्मूला. द फॉर्मूला इज द voice of anatomy. What you have to remember, sir? Answer is the voice of anatomy. VOI, voice of anatomy. Sir, V for vena cava opening, O for esophageal opening, and A for aortic hiatus. So just count 1, 2, 3, 4, 5, 6, 7, 8. 8 letters, T8. Esophagus 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10 letters. That's why esophageal opening is at the T10. And then 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. 12. So T12 opening. Simple. Fine. Next, what are the different things we created? The very good formula, all the things we can, and then summary. This is summary. No? Sir, vena cava opening is passing the inferior vena cava and the right vena. No. Which lever? T8. So your formula is a V is equal to IR. Means the voltage is equal to current into resistance. इंटीग्रेशन की सारी सरहदों को तोड़ते हुए. Yes. Anatomy integration with the physics. Ohm's law. Then LOVE. L for left gastric vessels. O for esophagus. V for vagus nerve. These are passing through the esophageal opening. बड़ा romantic mnemonic है. Okay. Then ATA. ATM. Azagus vein. Thoracic duct. Yes, these are passing through the aortic hiatus. Aorta, thoracic duct, and azagus vein. T12 level. इतना जरूर याद रखना है. Why? If there is a problem, then there is a diaphragmatic hernia. Two types: congenital and acquired. Congenital diaphragmatic hernia, बिना पेंदी का लोटा, is Bordelic hernia, is posterior side and the left side, and MAR is Morgagni hernia on the anti-side and the right side, just opposite to each other. Also, the acquired hernia, you will see the sliding hernia, rolling hernia. Okay, so diaphragmatic hernia is important, na? Fine. Okay, sir. Now, dermatome. So, do you remember we did the dermatome? How? Sir, everything is here. And whatever I'm going to tell you, it is written there. Na? So, there is a particular segment of the skin which is supplied of the single span nerve. That unit is known as a dermatome. Yes, it is having the referred pain concept. So, whatever I will tell you, it is written here. Okay, look here. C1, no dermatome. C2, angle of the mandible. C3, C4, C5, supraclavicular nerve. So it is having the same root value of the phrenic nerve. So it is the nerve supply of the diaphragm. So whenever right dome of the diaphragm is irritated by the liver or the gallbladder, it will refer to the right tip of the shoulder. Splenic rupture, Kehr sign, it will refer to the left tip of shoulder. Now the C5 is reaching up to the elbow, and then C6 is reaching to the thumb. Okay, so biceps jerk is C5, C6. Yes, this is C6. Middle three finger C7, and this little finger is the C8. So do you remember Hare Ram, Hare Ram, Hare Krishna, Hare Ram? This dancing style is coming from the dermatome of the hand. Okay, so C6, C7, C8. Now T1 ulnar about the forearm, T2 ulnar about the arm, reaching up to the intercostal space. So intercostal brachial nerve. Intercostal brachial nerve is nothing. This is your, yes, you can say the, yes, that is simply T2. Then T3 above the nipple, T4 at the nipple, T5 below the nipple. T4 is at the nipple, very, very important. That's why the pain of the heart, it will refer to the same dermatome. Then T6 not important, deferred process. Then T7, inferior angle of the scapula, which is also supplying the gallbladder. That's why the pain of the gallbladder is reaching to the inferior angle of the scapula on the right side. Then T8, T9 not important, but umbilicus is important. Umbilicus is having the T10 now. Are you getting? Yes, the T10 is also the nerve supply of what? Sir, T10 is the nerve supply of the testis, ovary, appendix, small intestine. So the pain of this all, yes, the appendicitis, testitis, ovaritis, and small intestinitis. नहीं ऐसा नहीं होता. Orchitis, uveitis, and Crohn's disease, small intestine pain, they all will refer to the small intestine. Got the point? Okay, sir. Now what you have to remember, sir, there is the, yes, T11, T12 not important, but L1 is important. L1 is supplying this area which had been asked in the exam, ilioinguinal nerve. Then L2, L3, L4, front of the thigh, which is reaching up to the great toe. Then L5 is the middle three, and then S1 lateral border of the foot. So this question had been asked L4. Now turn the person, S1 from bottom to the top, then S2 is also from bottom to the top. Yes, S1, S2 is the ankle jerk root value. Skin is also same. And then S4, S5, S3, S4, S5, the anal reflex. Okay. So in this way, we completed the dermatome. One more thing, how to remember the dermatome. So important just. Do you remember this one? हमने ऐसा किया था पैर को ऐसे रख लो. Yes, important just. Can you do 1, 2, 3, 4, 5, 6, 7, 8. 1, 2, 3, 4, 5, 6, 7, 8. 1, 2. S1, S2, ankle jerk. L4, L3, L4, knee jerk. 5, 6, C5, C6, biceps jerk. 7, 8, C7, C8, triceps jerk. Simple. Ankle, knee, biceps, biceps. Yes. 1 2 3 4 5 6 7 8 1 2 3 4 5 6 7 8 simple khatam tata bye bye gaya the beautiful integration of the anatomy with the physiology as well as the medicine. Is it okay? Okay, so these are the things about the, yes, so see what are the questions from here. So they ask about the IVA. Yes, coronary circulation. They are asking about the, yes, narrowing of the esophagus. So look here, very easy. Cricopharyngeal junction, arch of aorta, left bronchus, and diaphragm. Okay, cricopharyngeal junction is at the C6, arch of aorta A, which will say about the T4, left bronchus B, which will say about the T6, and diaphragm we know very well, T10. Okay, now it is at the inches, 6 inch, 9 inch, 11 inch, and 15 inch. So you can remember 3 2 is 6, 3 3 is 9, 3 4 is 12, and 3 5 is 15. Instead of 12, just remember 11 inches. So in centimeter, 15 centimeter, 22.5, 27.5, and is 37.5. On an average, this 22.5 and 27.5, it is taken as the 25 centimeter and it is a 40 centimeter. So length of the esophagus is 40 centimeter minus 15, because this first constriction is 15 centimeter away from the upper incisor. That's why. So 25 centimeter. Dude's mnemonic. Do you remember? D for duodenum, U for ureter, D for descending colon, E for esophagus, and S for stomach. Yes. So this is the formula which you have to remember. Okay. Right, sir. Now, can you see the same question? T4 level, sir, arch of aorta, sir, congenital defect or Bogdell hernia. Okay, so again they are asking the constriction two answer, but one answer, the arch of aorta is bigger than the left bronchus. Yes, they are asking about the vein. So the great cardiac vein. Sometimes, rarely they are asking about the vein. Yes, they are asking about the this particular you can say cardio. So you remember आप तुम. Yes, aortic valve, pulmonary valve, the tricuspid valve, and mitral valve. So your formula is the आप तुम. Okay, fine. पहले हम आप करते हैं, फिर हम तुम करते हैं, और फिर हम MBA कर देते हैं. Okay, yes sir. Now come to the next. A patient experiences chest pain radiating to the nerve can be responsible for the radiating pain. Okay, so remember that is a intercostal and then brachial nerve. Fine. Okay, sir. Intercostal brachial nerve. Now, marked chamber. So this is the esophagus. This is part of the esophagus. So base of the heart is formed the left atrium. Left atrium had been asked. Okay. Now, what is the most preferred site for the needle insertion? Upper part of the lower lip. Okay. Yes. Now come to the next. This corresponds to which thoracic vertebral disc level? So they are asking about the, yes, intervertebral disc, that is a T4 T5. Okay, and now again they are asking the your vena cava opening, esophageal opening, and the aortic opening. So through the aortic opening, the thoracic duct is passing. Okay, now come to the next further. Sir, this is the trachea, so this muscle is the trachealis. Very easy. So now we are going to enter for the embryology. Yes, अर्ज किया है, मंजिल उन्हीं को मिलती है जिनके सपनों में जान होती है, पंखों से कुछ नहीं होता मेरे दोस्त, हौसलों से उड़ान होती है. ओके, डन. हाँ. हाँ, चलो. तो बेटा ये स्पर्मेटोजेनेसिस आप जानते हो. ओके, यस, दिस इज द oogenesis. ओके, फाइन. हम सीधे आते हैं. यस, इम्प्लांटेशन 6 डे में होता, नहीं दिया तो 5th डे, और नहीं 7th डे. ओके सर, वी नो वेरी वेल. हम अपने मेन मुद्दे पर आते हैं. चलो भाई. सर, दिस इज द 1 cell stage, then 2 cell stage, 4 cell stage, 8 cell stage, and 16 cell stage. That is a morula. Okay, then advanced morula stage, that is a 32 cell stage, and then blastocyst is formed on the 4th day. So there is an inner cell mass, outer cell mass. Inner cell mass, it forms the true embryo. Outer cell mass, it will make the nutrition to the baby. Okay. Now this inner cell mass, it is dividing rapidly and it is making the first cell of the body, that is the epiblast. Yes, it is a Nawazuddin Siddiqui. It is a Nawazuddin Siddiqui. So it is saying साला अपने ज भगवान है, टक्कसी छू करके मौत को वापस आ जाता है. So it is a god, it is the first cell, and it will create all the different cells. Okay, fine. Now come to this. This Nawazuddin Siddiqui epiblast, it is dividing and making the hypoblast. Now this hypoblast is making the endoderm. So this endoderm is the, yes, first germ cell layer of the body which is formed by the Nawazuddin Siddiqui epiblast. So this is the Mithun Chakravarti. Hasta Mithun. Yes. Fine. So remember, this Mithun Chakravarti is saying, "Oh, सोलो अपन भगवान है, गीता समान है, होटे मोहम्मद की है, होटे कहाँ राजा भोज, कहाँ गंगू तेली, वो दोनों कहाँ है, मुझे नहीं मालूम." Yes, so remember this endoderm is the Mithun Chakravarti. Now he is saying, I will also divide. So now this endoderm is rapidly dividing and making the Husser's membrane. So the cavity of this Husser's membrane is known as the primitive yolk sac. Yes, sir. It will make the GIT, which is endodermal lining. Is it okay? Fine. Right, sir. Now see, this epiblast is getting angry. Nawazuddin Siddiqui ये मिथुन को बोलता है, साला अपुन से तू नौटंकी करता है, अभी अपुन तेरे को मजा चखाता है. So now it is rapidly dividing and making the new cell. This is the amniogenic cell. Okay, fine. So the cavity of the amniogenic cell is the amniotic cavity, and the cavity of the, yes, you can say the endoderm, that is a primitive site. So it is having the one cavity, two cavity. This is known as a double bleb sign. This is known as a double bleb sign. The integration with your radiology, with your, yes, obsgani, the first confirmed sign for the pregnancy. Okay, clear? सर एग्जाम में याद आया ना है, लेकिन आपके डायलॉग जरूर याद आ जाएंगे. और यस मोगेम्बो, अगर आपको डायलॉग याद आएगी तो उस डायलॉग से आपका एमसीक्यू बनेगा. ये मेरा आपसे वादा है. बस बेटा रिवीजन कर लो, है ना. रिवीजन नहीं रहता तो आखिर टाइम में कंफ्यूजन होता है. फाइन. Okay, sir. So now we are looking this bilaminar disc. So there is a epiblast, there is a hypoblast. Yes, this is the bilaminar disc. So B for bi, it is converted to the 8. So 830 it is formed. This is the lateral view. So when you will see from the top, it is appearing round. Now this endoderm, Mithun Chakravarti, is dividing and it is making the procaudal plate. है ना. प्रेम चोपड़ा साहब, जिनके घर शीशे के होते हैं ना, वो बेसमेंट में कपड़े बदलते हैं. Okay, so now it is showing the division and making the procaudal plate. So you can see, sir, this is the procaudal plate. Yes, near to the procaudal plate, the head of the baby develops. So remember, head end of the baby is decided by whom? Answer is the, yes, procaudal plate, the endoderm. This is deciding the craniocaudal axis. Now just opposite to this procaudal plate, now this epiblast is getting angry, and yes, he is saying, साला अपन के सामने सेल डिवीजन करता है, अभी अपन मजा चखाता है और प्रिमिटिव स्ट्रिक बनाता है. So now the Nawazuddin Siddiqui is making the one streak-like structure which is just opposite to the procaudal plate. This primitive streak is dividing the embryo into the right and the left side of the baby. So yes, it is dividing the right and left side of the baby. Is it clear? Okay, right, sir. So now we are cutting at this level. So when you will cut, can you see this is the primitive streak? This is the epiblast, this is the endoderm. Now this particular primitive streak is dividing rapidly and it is making the new germ cell layer, which is the mesoderm. So remember, first germ cell layer which is formed, endoderm, second germ cell layer, that is the mesoderm, and now the remaining epiblast, they will making the ectoderm. So this is the third germ cell layer. Okay, so now this mesoderm is the Hrithik Roshan. He is saying, "Ma, मैं आ गया माँ." Yes. Now it is rapidly dividing and making the one cord-like structure, that is a notochord. Okay. मेरे शक्तियों का गलत इस्तेमाल किया जा रहा है माँ. Okay, so remember this notochord, it is getting angry, so it gets disappear. ये ऋतिक रोशन है, and only small remnant is there which is making the nucleus pulposus. Yes, it is the nucleus pulposus. Getting the point? This is the gel-like material within the intervertebral disc. So you can see here, sir, this is the your vertebra. So at the center, there is a gelatin-like material. So this is the pulp-like material, nucleus pulposus. It is a remnant of what? Sir, it is a remnant of the notochord. Is it okay? Sir, it will compress the nerve and it will produce the radiculopathy. That's why this question had been asked in the FMGE 2025, because it is having the certain clinical value. So one line you have to remember, notochord disappear and forms one pulp-like structure, nucleus pulposus. Okay, yes. Now look here, the center of system development. So for the center of system development, I told you one demonstration. Yes, look here. The CNS development. Sir, there is a neural plate, neural groove, neural tube. It is having the entry neuropore, posterior neuropore. Entry neuropore is getting closed on the 25th day. Posterior neuropore is getting closed on the 28th day. Yes. The entry neuropore, it will grow and it will make the brain. The posterior neuropore, it will not grow. Okay. It will remain narrow and it will make the spinal cord. Okay, sir. Fine. Clear. Complete. Fine. If entry neuropore is not getting closed, so anencephaly, posterior neuropore is not getting closed, then spina bifida, meningocele, meningomyelocele, or this neural tube formation. Yes, proper vitamin B9 is required. So you can observe here, sir, this is the neural plate from the ectoderm. This is the neural plate. Now this neural plate is making the neural groove. Then it is going inside, it is making the neural tube. Yes, sir. In front of the neural tube, this is the notochord. Sir, in the neural groove on the lateral side, the crest cells are there. So these are getting separated on the dorsolateral side. So these are known as the neural crest cells, right, sir? And the mesoderm is dividing into the three parts. Your formula, your sexy formula is the LIP, LIP, LIP. Don't forget LIP. Sir, L for lateral pet mesoderm, I for intermediate mesoderm, and P for paraxial mesoderm. जो lateral है प्लेट की तरह है lateral pet mesoderm. Yes, at the both side this is the, yes, paraxial, and in between that's the intermediate. Got the point? Clear? So this is the organization of the different cells. Now you have to compare this one. Can you see ectoderm, mesoderm, endoderm? At the center, this is neural tube. On front of the neural tube, this is notochord, FMGE 2025 question. Dorsolaterally, sir, these are neural crest cells. And now mesoderm, LIP, lateral pet mesoderm, intermediate mesoderm, paraxial mesoderm. Okay, clear? Okay, sir. So now come to the next. So these are all the things I told you. Vitamin B9 is very important. If vitamin B9 is not there, then neural tube defect is there. That's why you have to know the level of the vitamin B9. Yes, 4 milligram or 400 microgram when you have to give. I told you this all the things. Na? So this is the anencephaly, this is the meningocele, meningomyelocele, spina bifida, meningocele, meningomyelocele, rachis. You know very well. Neural crystals derivative. So you can remember with the formula. Yes, this particular anti Mallika aunty, neural crystal derivative. This is the one topic to mug up. Sir, these neural crystals, with the help of the hyaluronic acid, these are migrating and they are making the very special structure in the body. Okay. So what are these structures? So this is the list. Formula is the pits doing disco in front of the Manmohini Mallika. Getting the point? Fine. Okay. चलो तुम्हारी नींद को थोड़ा भगा देते हैं अगर तुम इस आंटी को नहीं जानते होगे तो. सर, you can see this aunty. अरे कहाँ गई आंटी? You can see Imran uncle. Epstein-Barr virus is the Imran uncle. Okay. कहो न कहो ओ मेरे सनम, वफा के साहिलों का तो किनारा है हमारी. यस, यू नो, अच्छे बच्चे आंखें बंद कर लो. सो रिमेंबर द फॉर्मूला मल्लिका आंटी. ओके. यस, फाइन. So on her name, you have to remember the pits doing disco in front of the Mallika, Manmohini Mallika. Okay. Yes. बादलों से ऊंची उड़ान उनकी, सबसे अलग पहचान उनकी, उसे है प्यार की कहानी मंजूर, आते जाते सबकी रवानी मंजूर, तो ही मौजों का किनारा है, तो ही मौजों का किनारा है, something like that. Okay, so you have to remember. Fine. So Pitt's doing disco in front of the Manmohini Mallika. Yes, P for parasympathetic ganglion, E for enteric plexus, A for NS ganglion, D for dorsal root ganglion. Means all ganglion are neural crystals derivative. Okay. And then you can see the disco, DSC, D for dentine tissue, S for sclera, and C for choroid. Connective tissue of the thyroid gland, connective tissue of the any gland at this head neck area. M for melanocyte, M for mesenchymal bone of the head face, and M for meninges. This is the list which you have to look. Okay. Now, the cardiovascular system development. Sir, the heart lives from the two tubes, and ultimately they are fusing and making the four dilatation B, V, or SAS. Bulbous cordis, ventricle, atrium, and the sinus venosus. And this is the development of the heart. But nowadays they're not asking the question from this part. They're asking the clinical question. So ultimately they are developing, sir, the ventricle is above, atria is below. Ventricle is above, atria is below. So ventricle is going forward and downward. Atria is going backward and upward. It is making the slopey structure in which atria is behind, ventricle is on the front. And this is the truncus arteriosus, sir. The truncus arteriosus, later it is dividing into the aorta and the pulmonary trunk. So I taught you the clinical question which are asked. Sir, this is a section of the truncus arteriosus. Normally, it is dividing into two, aortic wall, pulmonary wall. But when there is no development of this spiral septa, then aortic and the pulmonary wall, they are common. So this is the truncus arteriosus. Sometimes there is the this spiral septa is not developing in spiral way, it is developing in straight way. So in place of the aortic wall, pulmonary wall, and in place of the, yes, aortic, in place of the pulmonary wall, there is a aortic wall. So there is a TGA, transposition of the great arteries. And one more condition, when this spiral wall is displaced, so aortic valve is bigger, pulmonary valve is smaller. So there is a overriding of the aorta in the pulmonary stenosis. Okay, getting point? Okay. So due to this abnormal shifting, sir, the overriding of the pulmonary stenosis, the pressure in the right side is increased. So right ventricular hypertrophy and interventricular foramen, it is not getting close. So right to left side blood is flowing. That is right to left shunt. So these four features are known as the tetralogy of the Fallot. If severity is more, then along with the VHD, AHD is also. That is a pentalogy of the Fallot. And if severity is less, in that situation, sir, the VHD is absent. That is known as a trilogy of the Fallot. And you will see the apex of the heart part is lifted due to the right ventricular hypertrophy. So it is changing the shape just like the shoe, just like the boot. That's a boot shaped heart. Is it okay? So these are the different things which you will see in the clinical, but the basics are coming from the anatomy. Now the pharyngeal arch artery development. No need to remember these all the things. Yes, here is a table for हमने सब कॉन्सेप्ट बनाया था, लेकिन अल्टीमेटली एग्जाम में क्या आता है बेटा, क्लिनिकल चीजें. One thing which you have to remember, sir, sixth arch artery, the distal part, it will make the ductus arteriosus. Later it is making the ligamentum arteriosum. Suppose it is not getting disappear, then it is making the pedant ductus arteriosus. One more thing which you have to remember, sir, there is a vagus nerve. Sir, right, left recurrent laryngeal nerve is making the sixth arch, but sixth arch is making the ligamentum arteriosum. So it is looking the ligamentum arteriosum, which is just below the aorta. So it appears that left recurrent laryngeal nerve is hooking the arch of aorta. But on the right side, can you see this is the right vagus nerve? It is giving the right recurrent laryngeal nerve, which is hooking the subclavian artery, which is the fourth arch artery. Okay, fine. इतना ही बस आपको याद रखना है. Fine. Now, these are the your different pediatrics part. Yes, this is the your urachal fistula, urachal sinus, urachal cyst. Okay, this is the urachal sinus. In the similar way, vitreointestinal duct. Yes, this is having the fistula, Meckel's diverticula, sinus, cyst. Okay, you will see there. Yes, so Meckel's diverticula rule of 2%, 2%, you will see in the surgery. Na? Just remember antimesenteric border in the small intestine. This is the Meckel's diverticula, which is nothing, which is the vitreointestinal duct. Okay, now this is the omphalocele and this is a rupture, that is a gastroschisis. Okay, this is covered with the amnion in the omphalocele. Okay, so can you see the MCQs? Identify the Marley structure. We had seen the two lateral lingual swelling. Yes, can you see the tetralogy of the Fallot? Yes, जस्ट बेटा विद इन द 10 मिनट्स वी आर एंडिंग द सेशन ना, क्योंकि हिस्टोलॉजी में सिर्फ इमेजेस प्रैक्टिस करनी है. मैंने आपको बताया न्यूक्लियस नोटोकॉर्ड, न्यूक्लियस पल्पोसस, Yes, this is the cavity. So this is the blastocyst. Sir, this is the open neural tube defect. So neural CNS development you have to see. Yes, rat tail appearance, the bird beak appearance you have to study in the clinical. Sir, there is the ductus arteriosus which is hooked by the sixth arch artery. Sir, there's a left recurrent line general. It is hooking the ductus arteriosus, sixth arch artery. They will ask, na. Sir, there is the first arch derivative. The malleus and incus had been asked. ENT integration. They're again asking the first arch, first pharyngeal arch. Okay, preauricular sinus was shown. They are asking the neural tube defect. Yes, fourth week of the intrauterine life. They are asking the omphalocele covering with the amnion. Yes, they are asking the first arch defect. Mandible is abnormal, so first arch defect. Yes, they are asking again the neural tube defect, anencephaly, anterneuropod defect, anencephaly. They are asking about the vitreointestinal duct. Okay. Yes, they are asking about the urachal fistula. Urine is coming through the urine. Okay. So now we are going to look for the last topic, the image practice. हिम्मत मत खोना, अभी बहुत आगे जाना है. जिन्होंने कहा था तेरे बस का नहीं है, बस उन्हें ही करके दिखाना है. ये शायरी अपने रिश्तेदारों को चिपका देना. ओके. तो बेटा हिस्टोलॉजी एक धोखा और छला होता है, ऐसा कुछ भी नहीं होता ना. Okay. Yes. So I'm going to share with you my personal experience. The histology was my thesis topic. So I did very nicely in the forensic anatomy, for which I got golden opportunity to be the chairperson of the, you can say, the King George Medical University of the Lucknow. There's the Anatomical Society of India, the national conference. So look here, is all of the personal experience which I'm going to share with you. एक चीज बस याद रखना बेटा, the blue color is the nucleus and pink color is the cytoplasm and the cell membrane. I told you the pink and blue color story. So now the epithelium, one question from the epithelium. If the blue color is parallel to the basement membrane, means squamous epithelium. If the blue color is round, then it is a cuboidal epithelium. And if it is making 90 degrees to the basement membrane, then it is, yes, columnar epithelium. Is it okay? Right, sir. Now let's start. Sir, the nucleus is parallel to the basement membrane, fat squamous, empty. So this is what, this is the squamous, this is the alveoli. Yes, it is found in the lung. So when you will understand, then you will be able to understand the pneumonia, the lung alveoli filled with the inflammatory cells. Right, sir? Sir, rounded nucleus, this is the cuboidal epithelium, follicle and the cavity is there. So it may be the thyroid gland, it may be the PCT, DCT. So thyroid and kidney, they are similar. So that's why there is a thyroidization of the kidney in the chronic pyelonephritis. In the similar way, can you see the tall cells, columnar cells? It is found in the GIT. Yes. In the similar way, can you see the stratified squamous epithelium, which is found in the, yes, respiratory tree? Yes, if it is affected, then State Bank of India. Okay, that is a Cartagena syndrome, also known as the immotile cilia syndrome. So these are S for situs inversus, B for bronchiectasis, and I for infertility. Easy. Now, yes, more image practice, more perfection. बेटा हिस्टोलॉजी का कोई इलाज नहीं है, सिर्फ और सिर्फ एक इमेज प्रैक्टिस करो. फाइन. सर, मल्टीपल लेयर, दैट्स स्ट्रेटिफाइड. इफ अपर लेयर इज dead layer keratin, then keratinized stratified squamous epithelium. If no keratin, then non-keratinized stratified squamous epithelium. Remember, the site where the friction is there, there is a stratified squamous epithelium. If it is dry, then it is skin. Dry and friction, skin. Keratinized stratified squamous epithelium. But if there is no keratin, then it will do secretion. And friction, then conjunctiva. So remember, cornea, conjunctiva, vestibule, palate, pharynx, larynx. Yes, on the downside, the glans, penis, vagina, anal canal. These all are wet and there is a friction. So these are having the non-stratified squamous epithelium. Yes, इसको समझ जाओ. फाइन. जो समझ गया वो समझ गया, जो नहीं समझा वो पोगो देखो. Okay, sir. Now look here. Sir, the upper layer is having the umbrella-like appearance. So close your eye and go for the transitional epithelium. Yes, urothelium found in the urinary tract. And then you can see, sir, this is the pigmented structure. Any pigmented structure coming out from the surface, that is a hair. Hair कहाँ होता है? Skin में होता है. तो क्या bone में होगा? तो क्या gland में होगा? Yes, skin में होगा. So if you will see the soap bubble like structure, then it is a sebum. So that is sebaceous gland. So it is a holocrine gland. Remember, sebum means oil. Oil means, yes, hormuz. Hormuz, H for Hormuz, H for holocrine. Don't forget. ट्रम्प इसी के पीछे तो पागल है, इसी के पीछे तो दीवाना है. सो इफ दिस डक्ट इज गेटिंग ब्लॉक्ड, सो द सीबम इज गेटिंग कलेक्टेड हियर. Okay, so this is what? This is a sebaceous gland. Yes, that will result into the sebaceous cyst. Okay, that is the acne in simple word you can say. Now see, there are three types of the gland. If gland is getting ruptured totally, there is a holocrine gland, the sebaceous gland, the hormone gland, they are the holocrine. And if the apical part is getting ruptured, then it is the apocrine gland. Yes, that is a axillary gland. Fine. So this apocrine gland, they are having the peculiar smell, like the axillary sweat gland. Rub your hand and then smell. Uh, yes. Actually, it is acting like the pheromones. Yes, it attracts the opposite sex. In the similar way, insert your finger within the pant, rub there and then smell. Chi. Yes. But it will attract the opposite sex. Yes. That is the pheromone like activity. So whenever there is the smelling sweat gland, that is the apocrine gland. Okay, so when the apical part is getting, so remember the axillary sweat gland, the perineal sweat gland, these all are apocrine gland. In the similar way, the breast, the lactating mammary, they are also the apocrine gland. Okay, fine. So now try to understand further. Sir, one more question, A for apical, A for axillary sweat gland. Now come to the next. Sir, if gland is not destroying, just doing the exocytosis, then it is the, yes, ecrine gland, the merocrine gland, the normal sweat gland, where there is no smell, like the palm and sole. You can, no smell, na? Fine. So this is what? This is the good gland, ecrine gland. These are causing the exocytosis. Is it okay? Clear? Okay, sir. Now come to the next. Yes, these are not important, just one view. Sir, dark and light band, skeletal muscle. Yes, you can say the intercalated disc, so cardiac muscle. And when you're looking the cigar-shaped nucleus, then smooth muscle. Okay. Now look, histopathology, you will see the Escop body in the heart. This is the myocardial infarction. Okay, sir. Now lymphoid tissue. If any lymphoid tissue, you are having the cortex in the medulla. This is the lymph node. Okay. Two types of the lymphoid organ, so primary and the secondary. Primary, bone marrow and thymus, and rest all are the secondary. Remember, bone marrow and thymus, they are categorized under the primary, remaining all are the secondary. Now look, the thymus. Lobulated appearance is the thymus. Yes, lobulated appearance is the thymus. Okay, sir. Next, in this thymus, you will see the Hessus corpuscles eosinophilic mass. If white pulp, red pulp, white pulp, and red pulp are visual, means it is the spleen. And if you are looking any crypta magna, then it is a tonsil. Are you getting? So this summary again. The four lymphoid tissues are asked. Sir, lymph node, cortex and medulla, thymus, lobules and the corpuscles, spleen, red and white pulp, tonsil, crypt, and stratified squamous epithelium. Okay. Now the bone, very easy, eversion and the Walkman canal. Yes, sir. Now look the cartilage. How to identify the cartilage? Sir, if nest of the cells are seen, lacuna is seen, then this is known as the, yes, you can say further, these are the chondrocytes. Outside the chondrocyte, this is the hyaluronic acid. So this is the hyaluronic cartilage. Where the hyaluronic cartilage is found? So remember the formula high GF car. So when you are getting the GF, okay, with the car, then it is converting to the dancing car. So you can remember the high GF car. Sir, high for hyalin cartilage, G for growth plate, and F for fetal cartilage, C for costal cartilage, A for articular cartilage, R for respiratory tube cartilage. So these are the example. इतना ही पढ़ना है बेटा, बार बार पढ़ना है. हमने एनाटॉमी को इतना अच्छे से रिवीजन किया है. अगर आपने इसको कॉन्सेंट्रेट सुना बेटा, आपका 80-90% सही बनेगा. Fine. Look here. Elastin cartilage. So if elastin fibers are found, then elastin cartilage. Now look where it is found. EEE. Ear pinna is taken to epiglottis. Also, you can touch the tip of the nose. इतना ही याद रखना है. Getting the point? Okay, sir. Now, yes. दोबारा थोड़ी ना पढ़ूंगा. ये क्या है सर? व्हाट इज डांसिंग कर? लेख खोपचे में ले इसको. इसको डांसिंग कार नहीं पता है. जिंदगी का सहार नहीं पता, इसको लेख खोपचे में. Sir, fibrocartilage, when you are looking the thick red wavy bundle, then it is a collagen. Okay, yes sir, it is the collagen. Fine. Now look here, this is a fibrocartilage. Your formula is a Fiat logo. F for fibrocartilage, I for intervertebral disc, A for articular disc, T for tendon, and L for labrum, glenoid labrum. Okay. Now this is one last topic, collagen. Total 28 types of the collagen, but important is asked type 1. You can remember the one, just add the B. So bone is having the type 1 cartilage. Type 2 cartilage is found in the cartilage. Okay, fine. So the type 4 cartilage, yes, it is found in the basement membrane, the glomerulus membrane, and the pulmonary basement membrane. So if there is a mutation in this type 4, there is the hematuria and the hemoptysis. This is the good posture syndrome. Yes. So thick red wavy bundle, these are the collagen. Yes. So if this collagen is involved, then collagen vascular disorders are there, like the rheumatoid arthritis, SLE, keratoconus, systemic sclerosis. Collagen is important. That's why this collagen tissue disorder are asked. And in the vessels also there is collagen. So these are involved and resulting in vasculitis. So thank you very much, Beta. Just last view of the PYQ PYTs. Look here, they are asking the Bowman's capsule. They are asking about the Purkinje cells, which we had seen during the cerebellum. They are asking about the elastin cartilage. So epithelium and the cartilage you have to study. You have to study about the lymphoid organ. Thymus they had asked. They are asking about the, yes, gland. So they are asking about the thyroid and the parathyroid, calcitonin secreting gland. They are asking about the gland again. They are asking, in the physiology, GFR, the glomerulosa fasciculata and reticulus and the medulla they had asked. Yes, yes, they are asking about the primary lymphoid organ. Answer is thymus. Yes, they are asking about the epithelial lining. So epithelium, gland, cartilage you have to study. Lymph tissue you have to study. Again, they are asking epithelium. Read the epithelium. Yes, again, you can see they are asking the epithelium in the fallopian tube. Yes, they are asking about the obs gynae physiology. You can say the antral follicle. So thank you very much for your support. Any kind of problem, better you can connect to me. And at the end, success is not permanent and failure is not final. Again, I want to say, बेटा अगर इस वॉर में तुम जीत गए तो क्या जिंदगी की जंग जीत गए? नहीं। और अगर बाय द वे फेल हो गए तो क्या बेटा जिंदगी की जंग हार गए? नहीं। ये एक एग्जाम है, लाइफ का एक पार्ट। इसको आप सिंपली एक पार्ट की तरह मानो, इसको जिंदगी नहीं मानो। फिर से, इस जिंदगी में आप हर चीज हासिल कर सकते हो, लेकिन हर चीज दे करके ये जिंदगी हासिल नहीं कर सकते। फिर से, आप इस जिंदगी में हर चीज हासिल कर सकते हो, लेकिन हर चीज दे करके ये जिंदगी वापस नहीं पा सकते। इसलिए ये एक लाइफ का पार्ट है, इसको हवा नहीं बनाना है। ओके। नेवर स्टॉप वर्किंग आफ्टर सक्सेस एंड नेवर स्टॉप ट्राइंग आफ्टर फेलियर। अगर बेटा तुम जीत गए तो भी काम करना बंद नहीं होगा। यस, मेहनत चलती रहेगी। और बाय द वे, अगर मान लो तुम हार गए, सेलेक्ट नहीं हुए, तो भी बेटा हम कोशिश करना नहीं छोड़ देंगे। ओके, याद रखो, आदमी या तो जीतता है या फिर सीखता है, आदमी हारता कभी नहीं है। आदमी हारता उस दिन है जिस दिन वो कोशिश करना छोड़ देता है। क्यों डरे जिंदगी से कि क्या होगा? अरे कुछ नहीं होगा तो कम से कम तजुर्बा होगा। ओके। सो थैंक यू वेरी मच, बट आई ट्राइड माई बेस्ट। आई नो यू आर इन पेन, आई एम ऑल्सो इन द पेन, लेकिन नो पेन नो गेन। इफ यू वॉन्ट टू गेट एक्स्ट्रा, yes, we have to do extra. If we want to shine like a sun, then first we have to burn like a sun. तो बेटा रगड़ करके पढ़ो। जब हम अभी रगड़ाएंगे ना, तो जिस दिन रिजल्ट निकलेगा ना, उस दिन खुशी मिलेगी। अगर हम अभी नहीं रगड़ाएंगे ना, तो रिजल्ट के दिन हम रगड़ाएंगे। ठीक है बेटा? थैंक यू फॉर योर ऑल द सपोर्ट। लव यू ऑल। टेक केयर। एनी काइंड ऑफ प्रॉब्लम बेटा, यू कैन कनेक्ट मी एट दैट नंबर। ओके। इंटरव्यू मिलता है, बिल्कुल इंटरव्यू मिलता है, सेरिबेलम में मिलते हैं। ठीक है? ओके। थैंक यू। अच्छा, कल 10 बजे हमारा यूट्यूब का सेशन है, बिल्कुल वहां पर हम रॉक करेंगे अगेन। ये फाइल बेटा वही ऑलरेडी ये एनोटेड है। यू ऑल कैन गेन, यू ऑल कैन गेट एट द टेलीग्राम। ओके, यहाँ पर। और ये हमारा पुराना यूट्यूब का सेशन जिसमें ऑल 19 सब्जेक्ट्स हैं। ओके। और वैसा ही कल हम एक नया सेशन करने जा रहे हैं। फाइन। सो ऑल द बेस्ट, गॉड ब्लेस यू ऑल, और इसे सारे दोस्तों तक पहुंचा देना। फाइन। ओके। टेक केयर। बाय बाय। टेक केयर बच्चों, ऑल द बेस्ट, गॉड ब्लेस यू ऑल।